off the field base. I remember getting up at 5 o'clock, going to Kola, like 100 kilometers, doing the test myself, because we wanted to understand how to do the test, what's the pulse of the people, etc. I think that was very, very critical for us to learn what is needed to actually be tweaked. For example, we were generating the report, it's going to the cloud and coming back after a couple of reviews of doctors and so on. That was not going to work in a real end user scenario, because I still remember the first camp me, there was a positive Sharadamma. I'm still looking for her because there were two Sharadammas. They didn't give the address, they didn't give their phone number, they ran away, and one of them was positive. So instantly we knew that the technology had to be point of care, and immediately, like, you can't say we'll give you the result next day or even. So it actually went back, many of these learnings and privacy, so we added that. So it went back into refining this, but I'll cut short, and then after this, we actually wanted to try it out in a hospital, because unless it's used in a hospital, then the trust in the rural solution was not going to be there. So went to a doctor, we presented to the board, we had some good clinical data by then already, and then we actually got a doctor who knew thermal imaging and was willing to, who believed in our results and willing to take the liability of signing the report for a hospital. I think that was very critical. If you have to install in a hospital, then there should be a doctor who will sign it and take the liability of any errors that's happening. So that was an interesting part. Dr. Ramprakash sir is still our mentor, and he's very happy with the progress we have made. So these two were sort of the real, very critical tipping points to actually take the solution and use it on real people for real use in some sense, right? So after that, it's been like a lot of studies in the hospital to prove that it actually works in a prospective setting. And then we went on to do some studies on the field with small number of patients with Government of Karnataka. I mean, I'm from Bangalore, so I know every pillar of NHM office, the old one and the new one, for those of you who are in Bangalore. So yeah, literally pillar to post many times. Then we found a funder. We got it approved with the TA team that they have, saying that yes, you can do this. So we got sponsorship from one of the pharma with about 5,000 people. They said, okay, after this pilot, they'll adopt. Honestly, we haven't got a serious adoption in government yet. I'm hoping this will change soon. But yes, I think the latest one, we've been doing a lot of pilots with governments, smaller scale, 5,000, 2,000. I think the latest one was actually with Dr. Karthik Kadapa sir and his team in Punjab, where we did about 15,000 women screening, where we did a lot of analysis on the ground and so on. Maybe I'll pause here in the interest of time, but happy to answer any questions.
Thanks a lot. And I'll also come back to Dr. Adappa later about the pilot, and maybe he can tell us a little more about that. But I'll now move on to Chandy. If you can, he's got a mic. So Chandy, Malbio is an incredible story of scale, adoption in India and across the world. Similar question to you. What was the journey like? What were some of these inflection points? And what drives Malbio? And and it's not just your scale. You're also now working with Niramai, helping them scale. So there is a spillover effect for other innovators too.
Yeah, thanks, Ajay. So we started in the year 2000 with a dream to take a platform like PCR to primary care. Correct? This was a time when most doctors did not know what PCR was, and PCR was a research tool. It still continues. In fact, the embodiments of PCR used in clinical settings are still research tools. 2005, we had a working prototype that you could touch and feel, and the Nimitli program of the CSIR decided to give us a soft loan. And we got a soft loan because we were a bunch of internally funded guys, people with IT backgrounds trying to put money to incubate something like this. I still remember my very early conversations with the venture capital company, and they kind of shooed me away saying, you don't even know the terminology, what are you talking about? So by 2009, we had a working prototype, a functional prototype. And H1N1 happened, and we were able to show that we could take a sample, provide results in less than an hour at a time when people took weeks to get an H1N1 result. That was an incredible experience, primarily because I used to get calls from all around the country saying, I have a sample, I need to know now. It does not matter whether your regulatory clearances or not, but I need to know the answer. Correct? Obviously, we could not do any of those things, but what it did is got ICMR interested. By that time, we had already done a bunch of infectious diseases, thanks to Dr. Ban and the BIPP program, the first avatar of BIRAC. And we had shown that we could use this platform in clinical settings. We started an H1N1 validation with ICMR that took 4 years. At the end of those 4 years, H1N1 was not there anymore. So I still remember when I went to somebody in the health ministry, they said, you should give me a platform that could do any combination of H and N, and then I'm interested. Otherwise, I'm not interested. But Dr. Soumya, I think, who was in the other room, by that time had already come back from Geneva, and Dr. Katoch was there, and they talked to us about working on TB. From a business front, Big Tech Labs by that time had already spent 10 years of spending a lot of money without any return, zero return, correct? So we pulled Sriram in and we formed Malbio, and this was in the year 2010. And then Sriram exited PerkinElmer and put every single pie that he got from there into this business. So we spent about 400 crores getting to scale, correct? This was not the amount of money that I thought I could talk about when I started the company. If somebody had said 4 lakhs, I would have been happy, correct? That was the background in which some of us came into this journey. We started work on TB, and by 2014, we had a TB test. And by 2017, ICMR had validated it. And then we were told that we required to generate more evidence on this. And the PMO, in fact, spearheaded a program where 100 sites across India, across the country, from Kashmir to Kanyakumari, one high burden site and one low burden site in every district, was selected for doing a pilot with smear microscopy technicians. So these technicians who were untrained were now going to do PCR. Very interesting story, and this is one point that I have to make. Because we don't scale our own technologies, the burden of proof, evidence that is required is sometimes far higher for a technology that is homegrown. So I think we did about 40,000 data points before ICMR decided to take this forward. But then we did not have WHO approval, so we spent another 3 years doing WHO approval along with ICMR and FIND. So in a way, if you can see this, this is a joint effort, a quest of our entire ecosystem to generate a PCR. So we were just the operating partner in this entire journey. 2020, COVID happened, but just before that, we got an order from Government of India to deploy 1,500 devices and 6 million tests. And the mad company that we were, we planned for more, correct? And then the supply chain was completely broken, and all of those devices were repurposed for COVID, and that allowed India to actually do COVID testing in secondary and primary settings across the country. So we didn't. Otherwise, we didn't have PCRs at all. In 2020, we didn't have PCRs. In fact, the day we were approved, only 14 centers of ICMR were approved to do COVID testing. And we added 1,500 devices to that in one stroke. Today, we are a global company. We are in 85 plus countries. And what we realize is that the innovative part of that journey is really small. The journey to scale is a very different scale, very different beast. And what we are trying to do is to work with our ecosystem and help technology scale across the globe.
Thank you so much, Andy, and such an incredible story. I don't know what we would have done if we didn't have your devices during COVID. I'll now move on to Ramakant, and we've talked about medtech, biotech, and we now come to digital health. And you work in a very stigmatized, sensitive area of mental health, where it is very, very nascent in India. It is not something that is where care is sought for. So tell us a little bit about breaking into that, and how do you again, your story, origin story, but also where are you today, especially in India?
How much time do you have, Ajay? No, I'll keep it short. As a healthcare entrepreneur, especially in mental health, I think you need two very important qualities. I think one is conviction or fire, and the other is um, you have to be naive. I think really to actually become a healthcare entrepreneur in India, you really have to be naive and not know what is about to face you or what is about to hit you when you get into the market. And that is really our story, right? So when we started, so Visa, for those who don't know, I'm the founder of a company called Visa, which does a therapeutic intervention for mental health on an AI chatbot. And we started this about 5 years before ChatGPT. Again, we were very naive and we didn't know what was about to happen. And so we started. And it was completely personal. So personal needs. So my father had bipolar. I'm not a mental health professional by background. So we were solving for a sample size of 1, which is ourselves. And so my father had bipolar. We came back to India from bouncing across the world. I have a financial services and management consulting background. But personal need, my co-founder and spouse and partner, she went through depression. Jo, I think some of you might have met her. We had suicide instances of suicide in friends and family. So once you start seeing mental health, then it's very hard to unsee it. And that really is the genesis of, I think, our journey. And we said, and of course, and when you're going through depression, it's hard to get out of bed. It's hard to even have a bath. So how the hell are you going to get into a car and drive to a therapist or a scooter or whatever and go to a therapist and see someone? It's just not going to happen. And we saw it ourselves. With all the best will in the world, with all the resources, it was really, really hard to get access to help. And so we were like, okay, so there has to be a different way. And you turn to digital and then you see what is out there. So for those who are professionals, so things like ICBT or internet-based CBT, they're very clunky and they feel as if they belong in the 80s in terms of the way they're delivered. So we said, so it was almost a hypothesis, slightly foolish at that time, saying, what if you were able to use these things called chatbots and deliver something like mental health? We put it out on the Play Store 2016, early 2017, with a little bit of trepidation and some optimism. And with an invite code and said that, you have to write in for an email code to unlock it. And before you knew it, we had some hundreds of emails a day. And we were just not being able to keep up. So we threw it open and it just exploded. And this was 2 years before COVID. And we didn't know what happened. I mean, literally, and what we found out was people were looking for help online. They were using words like anxiety, depression, therapy, because the health system was not helping or it was failing them, or for a variety of reasons, there were lots of barriers for access. And they were turning to their phone, they were turning online for help, and Visa happened to be there. So that was phase 1. And when we started, and our journey, I think, has 4 phases. So there's this incubation phase, then there is a conviction phase, then there is a adoption phase, and there is a scale. And so I think what I've described is kind of the incubation part, saying very personal story and a personal journey. And from there, we went to conviction, because when we started, I was a skeptic, saying who would talk to a chatbot about things like mental health? It sounds really funny. But then 5 months after we launched in May 2017, we got this email from a 13-year-old girl from the US saying, I have depression. I tried to commit suicide. I have no one else to talk to, so thank you for helping me hold on. And I remember Joe and we were on holiday in Shillong at that time, and when we got that email, and we held each other and we looked at it and said, is this real? Is this even possible that someone's actually saying something like this? Can a chatbot have an impact like that? I think that is the time when I started really leaning in and saying, I think slowly building conviction, saying this is real. This actually can help somebody where there is nothing. Or it can help someone when they are unable to or unwilling to reach out and take help from a therapist or a qualified mental health professional. So there is a space. This can be part of a problem. A very, very large problem, which obviously, and those of you who are again in mental health, it's a very, very large problem. I think it's number 3 in terms of disability-adjusted life years in the world. India is a world suicide capital. It's a very, very large problem, which we did not know when we started. So I think that was phase 2. So that was conviction. And then we went through a process of adoption. And interestingly, for us, COVID was the catalyst, where I think mental health suddenly became part of everybody's lexicon. The WHO says 1 in 3 people or 1 in 4 people need help at any time. I think COVID proved that it was 1 in 1. So everybody had issues. Everybody wanted to talk about them. Everybody had issues, worries about the future, worries about health, finances, and so on. And we started getting inbound interest from public health systems, not India, but public health systems from elsewhere. So the Ministry of Singapore reached out, said that we want to launch this platform for the entire population of Singapore, and it's web-based, but we want it to be more interactive. We want a chatbot to power it. We started working with them in 2019, so we are now in our 5th year, serving the Ministry of Health in Singapore across their 5 million population. Clinicians from the NHS reached out, the National Health Service in the UK, saying, oh, our wait lists are 1 year long for somebody who wants to see a therapist, and people deteriorate when they're on a wait list. And some people go into a very high-risk situation, and they don't have anything to help them while they are waiting. And I tried your app, and it is the only thing which is sticking on people's phones. Who are you? Do you know that you're legends here? And I initially, when we got that email, I was a little, I think I thought it was a prank, but then I saw the email ID and it said nhs.co.uk. And then we reached out, and now we are present in 40% of the NHS adult therapy footprint 4 years later, supporting people who are either going through the initial assessment or wait list. In parallel, I think our journey was not just about adoption, but it was also about validation, because as this thing started getting more and more serious, as we started to build scale, we realized how important it was to demonstrate and emphasize on features which are now becoming really important, which are things around safety, around validation, around research, around outcomes. Because if you have to go and now start convincing clinicians saying, look, this is serious, and you need to give this to patients, not just give it to students or employees, then you do need a lot of data, and you need a lot of evidence to convince people. And so we went down that journey. Now we have results from randomized controlled trials. We have the world's largest evidence base in this space, and which is now helping us literally turn inwards or turn back home. So now WISA at this point in time has served 7 million users across 9,500 countries. We've raised 20 million, 25 million. We're a venture-funded company. We have more than 750 million conversations on the platform. So it's a very mature platform. And initially in English, then turned into Spanish, then Hindi. And now from Hindi, we are going into various Indian languages. So in a sense, our path from validation, our path to scale has completed the circle, and we are coming back home. And ACT is a huge supporter of that work in terms of us wanting to take this solution out of English into Bharat. And it's just started. So I think now we've gotten a lot of support from impact investors and grantors to start thinking about the solution in a Bharat context. But that journey has just begun. And would love to talk more about that, but that's our story.
Thank you. And we'll come back to that. And I think, I'd love to see your services like they're available in Singapore and the UK also to be available to Indian citizens at scale, right? So, thank you. So I'll now come to Dr. Adappa. And, you've worn multiple hats. You've been an administrator. You are with the WHO now. You've also worked with innovators. You're clinically trained. You're a scientist. And you've worked on some of the validation pieces. So the things that I would actually want to ask you is, what are there is a gap clearly between, somebody building the innovation, getting to the conviction stage, and then transitioning into India's public health system. And there are, from the demand side, I feel like there is a gap in terms of demand of administrators or of the healthcare system itself wanting innovations. And then there is many steps, both regulatory and policy, before you can actually adopt something. So, tell us a little bit about your experience working with innovation, but also tell us what you would like to change or see change in the policy regulatory landscape.
Thank you, Dr. Ajay. I think this is fantastic. But before I delve a little bit into your question, I should really narrate my own journey. That'll kind of help people give the context. I'm a trained medical physician. Then moved into public policy making. Continued to serve as an Indian Administrative Service Officer. But then took a sabbatical for about 10 years. Went to the US, did a master's and a PhD. Worked at the Yale School of Medicine and UNC Chapel Hill, doing more research and working as a faculty, and then came back to the government again, worked for a year as secretary to government of Punjab in health and IT, and then now work for the World Health Organization. Now, the reason why I'm sharing this journey is trying to pick on what Nachiket essentially talked about, which is essentially on why do healthcare providers, doctors in India, really continue to work with the pen and paper. The reason is, and I'll try to tie it up with what you talked about as barriers, is primarily because education, which is very fundamental to us, is extremely siloed, right? With typically medical doctors, only medical trainees only go to medical school. They really don't go to an engineering school, which is just beside them, right? The distance between AIIMS Delhi and IIT Delhi is probably not even 5 kilometers. But do you really have education that transcends into two different zones, right? So we really don't have interprofessional education. And over the years, as a country, we've really not had digital health competency frameworks. Really, both were existing and to a new stuff. New people would join healthcare. So what's really happening is we're caught in this vicious cycle where our education systems, our curriculums are still of the 70s and 80s. And your new workforce, or the workforce that is existing, is really not trained in. So therefore, you would have in about 2 decades of implementation of EHRs in the US, where the US government, essentially when you talk of Obamacare, the US government is essentially put in about 21 billion US dollars on EHR adoption. What is it that we invested? Entire of ABDM is just about 135 million. And that's just about 4 or 5 years of ABDM implementation. So over 20 years, US has essentially accomplished 99% of EHR adoption in their entire hospitals. And we've literally invested close to $0 on EHR implementation. So one is on capacities, and the other foundation is on the very fact that when we invest our resources, where do donors essentially invest? Donors essentially invest on what is high impact, right? But you're not really investing on highly intractable, difficult problems that you see in the field, right? So for example, and that's the essential regulatory policy space that we're talking about. How many donors really focus on implementing standards-based, highly interoperable tools? Almost none in India, right? How many donors really invest on digital health capacities for existing workforce? I think you talked of Koita. Koita is the only one which first came out with this open source digital health competency framework with the Maharashtra University of Health Sciences. Apart from that, there is some interesting work that's happening in UP where they're working on digital health competencies for ASHAs and ANMs. But overall, as a country, we just don't have even a roadmap on what is it that we need to change in terms of a curriculum for our healthcare workers, whether it is physicians, pharmacists, nurses. And if you don't have them, this conversation that you need to have between technologists and healthcare professionals is certainly not going to happen. Because what you need are people who understand a bit of healthcare, also understand IT, right? Because essentially, when you don't have people who understand both, the conversations are going to be each of them talking two different languages, right? And then you build tools that again don't talk with each other. So both from a human point of view and from a capacity point of view and from a technology point of view, we're really not having a conversation where tools can talk to each other, individuals cannot talk to each other. So therefore, what I want to highlight is, and that's where I want to wear the hat of WHO, where what the kind of work that we do with governments is essentially lay those foundations. So first and foremost is building the digital health strategy. Like for example, India, ABDM is essentially built on a foundational document called the Digital Health Blueprint, right? So now in entire of Southeast Asia, there are about 5 countries which are still yet to have an active digital health strategy. Now those are not things which any donor would want to fund because you really can't see an impact on that. Now there is no country apart from say Sri Lanka which invests on creating this workforce of health informatics. Sri Lanka has been investing for the last 2 decades, and it's now built an entire workforce of health informaticians. These are all MBBS doctors who spent 3 years in an MSc program for biomedical and health informatics, and then do a board certification on MD program for health informatics. And therefore, today Sri Lanka, even as a small country, has 2 homegrown EHR systems, which are really built by this group of health informaticians who bring in the skills of both healthcare as well as IT. What do we have in India? What we have in India are 2 homegrown EHR systems. One is eHospital from NIC and eShushrut from CDAC, which are essentially built by IT professionals who don't understand the workflows of a healthcare. And so therefore what will happen is these are tools that are not going to be adopted, right? So what we really need to focus therefore is, are we building these systems for our end users? 2, are we building the capacities for the end users? So I want to pause here because I know there are wonderful speakers. So what I want to just leave for a variety of donors sitting here is, are we truly working on funding truly foundational elements of these applications, right? Without these foundations being there, none of your applications are going to fly. So I just leave it there. Thank you.
Thanks a lot. And we'll also come back to this a little bit. I would also argue that in India we have another, when compared to the US, there in the US you also had these large payers who were paying for the care, and they insisted that the records are electronic, and that actually makes a big difference, right? In India we don't really have that in the private sector. But I'll come back to you, Dr. Adappa. But before that, I just want to quickly go to Sandeep. And Sandeep, you've been with ACT and have been driving ACT's health portfolio. As a funder, and you've worked with a lot of these entrepreneurs, both in your role in the private sector as well as with ACT. What are some of the gaps that you are seeing? And obviously, COVID has catalyzed a lot and a lot has changed. But what are some of the gaps that you still see in getting, because it's quite incredible to see all of these great innovators succeeding elsewhere and not being able to scale in India. So what are still some of the gaps that you see from both on the funding side as well as the policy demand side?
So I think just quickly introducing ACT, right? So we are a group of venture capitalists and startup founders that got together around the start of COVID, so in April 2020. So COVID actually is an interesting phenomena from a standpoint of how does emergency catalyze change, right? So we can have all these conversations. We had this conversation about IT and medical training together and so on. But fundamentally, I think the biggest gap that we have is we only move when there is a serious emergency. And I think in some ways, for all the negatives of COVID, I think the positive of COVID is it actually led to some fundamental changes. So ACT getting formed was one of the things that happened because of that. What happened, what sort of drove us is all of a sudden, because of COVID, we had a lot of very smart people that had nothing to do. That's the truth, right? Make My Trip, nobody was flying. So the engineers were sitting at Make My Trip saying, what do we do? So as a group, we all got together. We had amazing resources. Can we take this private resource that's available and make it available for public health? So we had resources, and we said, okay, what's missing is money. So we actually went out, and as a group of VCs and startup founders, we raised about 100 crores and said, let's work with the government, figure out where there are gaps, and we will put these private resources to work with the government. That's where we started. We actually ended up having interventions in 55 areas, everything ranging from a drone company working on surveillance to a company that was, we worked with Chandy at Malbio, we did work with Visa. So we'd worked in all these areas where we said, okay, there is a need for somebody in Pune, who's, the Pune Municipal Corporation came to us and said, we're struggling with workers and health issues. We went to Visa and said, can we use your, app to do this? And interestingly, that's where we learned that the only app they had was in English, and they were working on Spanish. And we said, we need something in Hindi, we need something in Marathi, right? Why can't we do this? So, so that emergency impact got ACT started. What we realized after we got involved is that there is one, and I think, Dr. Geeta mentioned this, Chandi's mentioned this, that there is a big gap in terms of when you start, when you have the incubation, all the way to validation and then scale, right? Adoption. And there is a gap that exists, particularly in India, in funding that. So in the US, there is a very well-developed investor ecosystem that takes the risk in doing clinical trials. So if I come as a innovator and I come to this group of investors and I say, hey, here's a innovation that I have, these investors are typically doctors or scientists and so on, and they have the capabilities to actually evaluate whether this is something that will work, and then they'll actually fund the clinical trials. And so there is a very robust system that exists in these developed markets. We don't have that in India. So in India, the challenge that they run into is great ideas that don't get validated because there is no capital to run the clinical trials. So we said there is this gap here. So what we would do is we will use our capital to provide a means for running these clinical trials. So that was one part. The second thing we also realized is that there is the government system in terms of procuring innovation is broken. The way the procurement works in India is completely on L1, right? Now, L1 means that there are multiple players who can actually bid for a tender. Now, in the case of innovation, the fact that it's innovative means that there's no tender, right? There's no, if I tender, I'm the only one that can tender because I'm the only one with the innovation. So there is a big gap in how the government can procure innovation. So we also said that let's work with the government where we will say we will provide the initial trial money so that there is no procurement required. And once the innovation is proven in a government working environment, then it becomes easier for the government to actually procure. And the notion, the risk of getting caught with the CVC and so on, all those things go away, right? So I think that's the role that we are playing in the ecosystem right now. We've identified 4 areas that we've chosen to work in. So tuberculosis, mental health, comprehensive rural healthcare, and oncology. Those are the 4 areas that we've chosen right now. And I can talk about, Gates is doing so much work in other areas. So we have chosen not to focus on maternal and childcare for that reason. But that's a little bit about, our experience.
Thanks a lot, Sandeep. And I think you talked about de-risking, which what ACT is doing, and I want to actually continue the conversation with Anita. Anita, Gates Foundation is often the only funder sometimes for some of these foundational pieces that Dr. Adap also spoke about. And you've done a lot of that in India, especially in digital health. Could you tell us a little bit about what that journey's been like, and also tell us a little bit about the state journeys in Bihar and UP, where a lot was done with the government, and then some lessons from all of that.
Thank you. Firstly, I think everybody made my life easy by saying what the funders don't do, because that's what we do. So I think... Can you hear me now? Yes. I was just saying that my life was made very easy by Nachiket, Karthik, by talking about everything that the funders don't do, because that's literally the building blocks of what we are supposed to do. Where we are on that journey is something that the government can attest better and the citizens can. We talked about capacity building, and I think for me that's front and center, whether it's for a very long time, initially I think Gates Foundation worked a lot with international partners, right? And increasingly, we realized that if we are to contextualize and make that big impact that we all talk about, there have to be the right kind of local partners who are incentivized and have the ability to do that on a day-to-day basis for the government to tap into them when that crisis emerges. So I think that's like cornerstone of how we are thinking about our digital work, closely working with the government. Karthik alluded to some of the work the Koita Foundation is doing, which is phenomenal, because as we think about the ABDM journey, we're not even talking about the demand side at all. We talk about patient healthcare applications. Can I just do a hand show of how many of you use PHR apps? Personal health record applications?
On the stage.
I can count the hands. There's like 5 or 6.
My point is, it's great, fantastic. DigiLocker, and there are so many of them. Eka Care, which is an ABDM enabled solution, the biggest private sector player. Great, but is it really designed for who you intended to design for? Because that's where we talk about the challenge of the private sector players who are developing all of these applications, but then because of monetization challenges, because nobody is willing to pay, there is a health-seeking behavioral change required. They're going to different countries outside of India. So I think the second point I wanted to bring in was the contextualization. While we can all aim for big impact, I think the building blocks of ensuring it's contextualized to the needs in different state governments, in different state or village contexts is important, and I think that's something we try to play a role around. You talked about de-risking. A funder, you're funding, so means you're giving capital, and that's the end of it. I think our role becomes a lot about actually collaborating with the government when they can't put a line item in the budget, but want to test something out so that they can build evidence to put that line item, right? And we were talking before this, Ajay, where you said that something like this had happened, it went into the PIP, the leadership changed, and then it got discontinued, right? And these things will happen. We're not here to say that things will be set in stone forever, and there are many partners, I know, innovators in the room who are nodding their heads on this. But I think the point is to keep trying, right? Because when you have the right leadership within the government, things can stay. And when you have the right solution, tech being the smallest of all the challenges, if it is designed the right way, with the right intent, they can stay too. And to talk about the UP Bihar journeys, which have been over 10 and a half, 12 years, I was working on the implementation side before I joined the Gates Foundation. They both took very different trajectories. UP developed its digital health roadmap way before ABDM came into construct. They had their health facility registry ready. And just to be integrated to the HFR ID that was created. But why did that happen? COVID. For the longest time, UP was focusing on digital solutions from a health system strengthening perspective, right? They were focusing on supply chain, they was focusing on HR management, financial systems management, and building that layer. But given the expanse of the state, it was quite unthinkable to have something at a unitized level actually created. But COVID really accelerated that. And for the first time, the government actually created an end-to-end platform for management. Now we can talk about management could have been better, etc. But this was the first time they actually were able to bring private, public labs, connect right from the case identification till the outcome, and have those lab results available for citizens to see. And that gave a lot of confidence to the government to start thinking about the unitized layer that we all keep talking about. I don't think there is any country in Southeast Asia who's actually cracked the backward-forward referral pathway which all our guidelines talk about. Those were the building blocks that the UP government has started to put into place now. So they have something from a comprehensive primary healthcare application, and I see the Argusoft team at the back. Still struggling on the HIS side, like Karthik was saying, where there are these solutions which have been developed by different agencies, but have they necessarily been developed keeping in mind what the doctor needs? Not necessarily. So registration will definitely be filled in, billing may be filled in, OPD is a question. But this is the work that's happening, and the government is taking up a lot of ownership to drive some of this, to truly bring it back to service outcomes. But this is not a one-time implement this application and it's done, right? You have to keep going back to the ASHA, to the ANM, to the CHO, to the MO of what's working for you, to the block officials when they go for their visits. How can we make your life easy on what you need to actually look at when you're doing data-backed decision making, right? And so it's an iterative journey. Now that's where language comes in, that's where NLP comes in, that's where actually being able to have design which serves these different digital personas comes in. And some of the digital health capacity building work that has been done in the state is to be able to service this. Because there were, I think till about 3 years back, there were no phones for the ASHAs that were distributed. In the last 3 years in UP, they've distributed over 160,000 phones to the ASHAs. They are from the GEM portal. They may be outdated very soon already. But we're talking about ASHAs from different age groups, right? So how do you help them with the digital literacy? If you go on the field, and many of you must be spending time on the field, they'll be like, great application, great application. I'll be like, thoda dikhana. I'll just speak in Hindi for a minute. दिख नहीं रहा है, क्यों नहीं दिख रहा है? Font बड़ा कराना किसी ने नहीं सिखाया. Just like basic, right? So we are talking about those shiny new things, but we have to start from scratch. And I think that transition is important. I think some of the problems we continue to see is that, sure, we're giving these applications, designing for the end users, but the registers are still there. The APIs to be made available for central applications are not there. So there is a lot of duplication of work. So are we really trying to help and provide job aid, or we are trying to increase their work? There is that transition lag that's happening. Bihar took a very different journey. Bihar government, with again de-risking, right? Demonstrating to the government when they really want to be able to get the funds, that this is the kind of digital continuum you can create using digital tools. Our partners help support that. The Bihar government reached out to the ministry. Now the ministry is developing their own applications, may not necessarily want the state to also start developing and that not be an efficient use of funds. So they didn't get funds for that. So the Bihar government actually reached out to their state government and got a 300 crore digital health mission scheme approved, of which they rolled out for more than 2/3 of that amount an entire digitization roadmap. So they've onboarded a managed service provider using standards. I think all RFPs slowly in India that are being released by government have this needs to be ABDM enabled listed there. And hopefully we'll do that for diagnostics also, so that there can be interoperability there from a software vantage point. And now they've actually started the entire digitization journey right from the ASHA to the A&M, CHO, health facilities, keeping in mind the needs of the workers. So all of this has been digitized by integrating into the foundational systems that I was mentioning earlier, drug supply chain, diagnostics, so on and so forth. We're just at the tip of this journey. We're just getting started. But there is promise. And I think there was a time where digital would be seen as ribbon cutting. So whenever there is a change in leadership, some new application is introduced and we'll cut a ribbon, and the first application that was being used will be completely shut down, and the workers are, अब ये लो, आप इसके साथ काम करो. So I think that's changing, given some of the foundational building blocks, and actually being able to leverage them appropriately and not having to, create these piecemeal solutions which are verticalized programmatically. I'll pause here and hand it back to you.
Thank you so much. So we've covered a lot. We had time till 10:30. How are we doing on time? The ACT team? Another 20 minutes? Okay. So we'll maybe take last comments from the panel and then open it up to the audience. There's a bunch of really interesting folks in the audience who can maybe add to what the panel is talking about. So maybe I'll come back and we just go sequentially. Dr. Rappa, any responses to what has been said so far?
I'm kind of wanted to extend on what Anaita has been talking about, what governments have been essentially doing, because we certainly don't have a government player here. So I will talk about what governments have been doing, and I can certainly speak for Punjab, where I worked there. For example, some of the most innovative works that we're seeing, like I want to take a couple of names now. Noora Health, which some of you will be knowing, essentially started its journey in Punjab. Some of the most innovative work in terms of doing iTrek, which is a clinical decision support system which has come from for hypertension, has come through a randomized controlled trial in Punjab, for example. Now, some of the earliest you would see pilots that happened in terms of implementing EHRs, again happened in Punjab. So there's a lot of pilot work, a lot of initial innovative work that states have supported. For example, what Dr. Geeta talked about in terms of implementing this breast cancer screening at the population level, while the initial work happened in Karnataka, it was Punjab which essentially kind of said, yes, we are ready, we believe we as a state are ready to implement it at a population level. Now, what really happens in government is people are open to a lot of innovative ideas, but one has to really think about, are these innovations will also require a lot of re-engineering of public health systems. Now, Dr. Geeta's AI machine learning tool for breast cancer screening, it's not just about using it for just screening for breast cancer. What is going to be more important as a public health researcher and a public health practitioner for me is, once I've screened, what do I do with these people? It's not just that you screen and leave them in lurch. Now, it's just lucky that in Punjab, we've had a scheme called the CM Cancer Rahat course for about a decade, much before even we thought about this breast cancer screening, where we've realized in Punjab there used to be a train called a cancer train which would run from Batinda to Bikaner, where people would actually take a train in the evening, go to Bikaner, and in Bikaner they would actually get the tertiary cancer facilities. Because Punjab, about a decade and a half back, did not have even tertiary cancer facilities. So the first foundational work that we had to do was ensure first strengthen our government medical colleges, ensure that they have cancer facilities. Then we set up advanced cancer centers both in Batinda and Hoshiarpur. And then we realized that there is not enough public facilities. So what we did was we empaneled 16 private hospitals. So we've created this Cancer Rahat Kosh, essentially where we said any resident of Punjab, if he goes to any of these empaneled hospitals in the public sector and the private sector, the first thing is give them access to diagnosis and treatment. So we said, you go to a hospital, you get diagnosed with cancer, we will provide you 5 lakh rupees, cashless hospitalization, so that you can at least get diagnosed and you can start your treatment. Now this started about a decade and a half back. Now how we leveraged was once we started using this breast cancer screening tool, we then built in a new category of people called patient navigators who would then talk to this patient with an abnormal report and then also tie them to this Cancer Rahat Coach and the empanel hospitals. So what is going to be therefore very important is not just have an innovation, but ensure that you don't leave them in lurch after doing this innovation. So for breast cancer screening, it was very important that we re-engineer our public health systems in such a way that you can ensure that everyone with abnormal report also gets diagnosed and treated. And I think you needed that ecosystem, and there are going to be states which may not have that ecosystem to provide this advanced care facilities and therefore will not be able to support that innovation. So for true scale up, therefore what we need to think is what are our existing workflows and the public health re-engineering that you would need to support that innovation. And states that can do that are continuously, I think, innovating in that space. So I just wanted to kind of provide that government angle as well.
No, thank you. Very useful. And I think that we see this in other states because there are other states where when governments try and do a cancer screening, the patients don't show up because they're very scared of what will happen at the end of the screening because they don't want to be left in the lurch because there is no continuum of care, right? And yeah. So Geeta,
Yeah,
come
so
to you.
learning from this and building on what Dr. Karthik mentioned, we have made this a part of, we made this a part of our proposals to the government to figure out, especially now the government has announced, quite a few hundreds of daycare centers and so on and so forth, at least to do the follow-up chemo, etc. So we go with a proposal which has the integration plan. We try to, based on what we learned, of course it won't be as sturdy as the system that we have in Punjab, but which is the nearest district hospital where, people can get treated, etc. And we made it like an integration plan, 2-pager, which goes in. So, but that's something, I'm so sorry, that's something that we do. But just going back to the title of the panel, right, Bharat to India, Bharat to the world, I just wanted to share some insights, 2 minutes on, as a founder trying to think about solving the problems in India for the rural as well as urban ecosystem. We did 2 things, I think, I think it is well enough. So the first one is try to design a system where they can pay for value in a hospital setting, as well as the same system can actually be used for impact-based. Just to be more specific, because it's an AI-based tool, we have 2 types of reporting, where the same technology can be used to do just triaging, instant reporting, at a very, very, $1 or $2 kind of mode, per person kind of a mode in a village setting. And the same tool with detailed reporting, annotation, explainable AI, radiology certification, etc. can be done for, let's say, $20 to the end user in a hospital like an Apollo hospital or a city. So that way we are, we are also VC funded. So that way we are able to do the impact as well as, deliver the right returns for our investors as well. So this is one thing that we did. The second thing that we did, and some of the innovators here may want to sort of try and see if there is a possibility of replicating a similar equivalent model. The second one is that thanks to COVID again, I think all of us here are thankful for it for very reason, So even in Niramai, we had a lot of people could not go on the street to do training camps, or hospitals were busy with other things. So we all turned inwards and started cleaning up our processes, getting regulatory clearances for Europe, US, obviously FDA, CE mark, and so on and so forth. And of course, we have got all the ISOs 1345, 27001, all those standards in place. That really helped because right after COVID, when we got covered by BBC News, etc., we got a lot of incoming requests from other countries, and we were able to, within 6 months, go to 20 countries. You know, you can't imagine that happening. For, of course, it's an AI based. We used, external hardware, but that is very, very important to scale as well, right? You know, because we generally shun quality processes and writing things in the right way, form filling, etc. Digital, not papers, but that really helps. In scale is another piece that I just wanted to drop in as an advice.
Thanks a lot. I've just been informed that we don't have a lot of time, so if I could have quick remarks from the rest of the panelists, and then we can open it up to the audience, because I'd really like to get some audience questions in too.
Yeah, quick thought on what Nachiket talked about. How do you empower our our health centers to be leaders in terms of test entry? And this is going to require a lot of resources, correct? How do you make them frugal? There are a lot of innovators in India today and in the globe. What we are trying to do is to see how do we help them transform their journey beyond their functional prototype. How do you very quickly build a prototype that is ready to manufacture? Because there are lots of gaps here. This is an engineering problem. It's a problem of reagents. It's a multi-dimensional problem. So we are trying to use our experience of over the last couple of decades to be able to do this along with the innovative ecosystem. We built a program called the Edge that allows innovators to work with us. This is in its second iteration. We're also building a center of excellence in engineering for IBD, which will have state-of-the-art machines plus state-of-the-art skills that can help possibly reduce these time frames from years to weeks. So this is our thought as far as that's concerned.
Thank you, Chandi.
So
Ramakant?
I have a question.
We'll come to questions. Thank you.
Yeah, promise I'll be quick. Just one very quick question. How many people are actually innovators in the audience? How many people are building stuff? Right. So I think my remark is addressed to all of you, saying our path back to India from wherever else we were working. So I think 2 or 3 things, stories, very quick snippets of what you were probably going to go through or already going through. One of them is funding. So I remember when we were raising angel funding, I once went into an office of a diamond merchant in Bombay. And we were actually, and he said, what do you want to do? And I told him this whole thing. And he looked at me very strangely and said, what? ये सब तो MIT में होता है. भाई आप लोग कैसे करोगे? So this happens in MIT. So don't lose heart. This stuff will happen. Probably, definitely will happen. But push through because, and I think all of us know that India has some of the best talent in the world. We can actually build really world-beating stuff. I think the second story is around validation as well. Luck plays a role. As long if you're in the market long enough, and if you're trying and talking to as many people as possible, you will find an advocate. You will find a supporter. I think Geeta spoke about that first doctor who said, you can try this on my patients. So you will find that person who will say, I'm willing to give it a try. So don't lose heart. I think that's probably the second thing I'd say. And the third thing is around pricing. So you really, really have to, and I think Nachiket, you said it so beautifully, saying stuff which will work for, say, the US healthcare provider or the NHS will not work in India. We are discovering that we're getting a lot of bloody noses right now. When we are trying to go out and deploy and test, we are finding that stuff which works with Western users or even users who speak English, they're very willing to have long conversations about how they're feeling with a chatbot. But the moment you take it to Bharat, it all falls apart because they're used to consuming content. They're used to, watching Bollywood, watching cricket, and asking them to talk about how they're feeling it completely goes kaput. So really reinventing it for Bharat and throwing out all your assumptions and saying, okay, fine, this is actually de novo, it's a clean slate, and starting from scratch and having the humility to do that. It's not that, oh, we've kind of cracked it in so many different places and in so many different countries. That will not. So you really have to reinvent it. So those are the three messages.
Thank you, Ramakant. Any closing remarks, Sandeep? Or questions? Okay. Yes. We'll go to the gentleman in the white. If somebody can get my mic, he's been keen to ask a question for a while.
Good morning to
Please
all of you.
introduce yourself and also
Yes.
address the question.
I would love to, yes. Thank you so much. Good morning to all of you, and thank you so much for giving me opportunity to ask a question. Anyways, my name is Ashwini Dudeja from One Infiniting, and by grace of God, I'm environmental products, and I'm going to make something unique product also, which I cannot name right now because of I want to patent it first.
Yeah, we've about 8 minutes, so if you could get to the questions.
Yeah,
Thank you.
Yeah. So my question is that I'm looking for grant funds. Okay. What would be plan of action after this conference for people like me? That how can I approach you guys to work with actions? I want somebody to suggest me or to guide me. Though I've learned a lot here within this conference only, but for I'm talking about the action because I'm working for India, Asia, Africa, Latin America.
Thank you. Maybe Anaita and Sandeep, if you guys could respond to that.
Yes, I think anybody that is looking for funding, you have to make a choice between whether you're looking for grants or whether you're looking for sort of, venture funding or commercial funding.
Initially grant funds.
I'm
then
just
followed
I'm
by-
addressing your question and I'm
Overall.
answering for everyone since it's a general
Thank you.
question. So from a grant funding perspective, I think that ability to convey that you're doing something for public health is going to be very important. Yes. And there is enough information now today on the web. We are all putting it out there that we are doing this work. If you go, you'll see ag grants. We have a LinkedIn handle, a Twitter presence, everything. Gates Foundation also talks about things. So there is actually enough information. You have to make that effort in terms of trying to find those opportunities and reach out to them. People will speak to you because we are searching for latest innovations.
So can we connect after this? Sure. Thank you so much.
Yes. Please.
That was a question. That was a primary question.
Can I just build on that 1 second?
Yes, of course, please.
Additionally, if you will also look, Gates Foundation, while we are a grant-making organization, we have a sister arm called Strategic Investment Fund, SIF, and they look at capital funds here, right? So if you want investments where you're thinking about some of the impact goals that Sandeep was talking about, or you're also thinking about global access, because pricing, etc. comes in, you can look that up as well.
Yeah, there's more people waiting, so if we can go to the next question. Maybe you can take it offline after this. Please.
Yeah, morning everyone. This is Lavkesh Arora. I have come all the way from South Africa. My question to the panel is, I've just heard is like health is not valued till sickness comes. So we have that understanding of many conversations around. So what's the view of the panel from a self-care and a preventative healthcare in a context of reduction in a national disease burden and the associated cost?
Yeah, maybe I can ask Geeta and Ramakant to.
Since I have I think I'll go first. So I'll address that question. It's a great question, and I think from an innovator's point of view or from an entrepreneur's point of view, the biggest question to answer is monetization. Because governments, insurers, employers pay for illness. They pay for people when they get sick, they leave work. And it's very hard to make the case for preventative health to a payer or a funder saying, oh, if you do this in advance, then it will save money down the road because people will not get sick. That is the biggest problem we have to solve as an innovator. And I don't have an answer for that, but I think the only answer I have reached is it's probably the user who's most concerned. And you have, of course, the worried well, but you also have the worried not so well or worried who may not be very well soon. And those are the people you will have to go after and say, look, you guys need to pay. And or you go to the employer. I can't think of too many examples where an insurer, apart from maybe the US, where in value-based care kind of settings, there is an incentive to invest in preventative care because there is a systemic reduction in cost. It's a very hard problem to solve.
Yeah.
Okay.
Yeah, so I kind of, I guess a different perspective, but we need to solve this. That's what I would say, right? I think most of us here believe that prevention is definitely better than cure. And talking about breast cancer itself, we know and we have data that if detected in stage 0, stage 1, it can be just maybe 10% of the cost of treating a person who is detected in stage 3, stage 4. That's known, but it's about awareness at the government level, proof points, as you said, with longitudinal data saying that in this particular country, has it really saved life? Have we been able to detect in the field, like in a preventive manner, a smallest cancer? So somewhere, some kind of a proxy to show this benefit from a economic perspective is important, and we are in that direction. But definitely, I think things are changing thanks to COVID. At least end users are more open to getting vaccinated, getting for screening camps, etc. So I'm looking at the silver lining, and definitely that's what at Niramai we are trying to do. How can we move most detection to the earliest possible? We can call it preventive. Of course, there's other angle of wellness parameters, wearable devices, and so on. So that will, to become medical grade, there is the challenge. But we can talk on and on about several other challenges around it. But it's definitely important direction where innovation is further needed.
Thank you.
Okay.
Thanks a lot.
The
We have time
last
for two more
question.
questions. Yeah. One question here.
My name is
We'll
Dr. Ramaswamy. I am coming from Bombay. I've been in the healthcare for the last 47 years. My last 15 years was on quality of the medicine improvement. So we have a social organization where we work globally on improving the quality of the drug produced, not only in India and abroad also. And that is closely working with the drug control department, CDSC. But today, the question is more personal to Dr. Ramakant. You really touched your talk, not only the story, what you are doing, because I am also, I think I would say, an opportunity to have an younger brother for 62 years in my life, where I feel when you have a child, today we can say especially abled child, that's a term we use, the parents and the family, there is nothing for them in their life. So, when they are younger, the parents treat them. But when they have become 40, 50, 60, what to do? Parents have become old. Brothers are all in abroad. Nowadays, single child, no child. So they are suffering. So do you have adult physically challenged or mentally challenged centers? There are a lot of money makings. I have traveled across India to select one for my brother in the last stage. Unfortunately, I got one called Aadhar in Nasik. So do you have any idea or have set up institution in all the 4 regions of India which can be professionally managed for mentally retarded, physically challenged adults?
Sir, by the way, I'm not a doctor, but I am. There are a lot of people here in this room who have access to a lot of resources. I think very, very touching story, and I think we should connect after, and
Sure.
I'll be able
I would
to
love
make,
to
some
do that.
connections here. What I do know is that there seems to be an increasing amount of venture funding going towards exactly that, towards serious mental health, towards inpatient support, towards broader ecosystem caregiving support, where people are willing to pay because the need is so high, it's so acute. So people are willing to open their wallets. It's a very different problem from the preventative early intervention. Here, there is a need which is not being met.
Yes.
And I think the landscape is changing. And I know that there are a couple of startups which have also received large venture funding here, who are trying to set up centers for serious mental health and so on. Very happy to talk after the
Yeah, I would love to connect after this.
Thank you.
Thank you.
Thank you for sharing.
And I stop this, even though all of you have really tickled our brain for all of us here, especially Dr. Geeta and Chandrasekhar. I have a lot of things to ask to you. Maybe I will ask after this.
Thank you so much. We'll take one more question from there, from the end. The lady in blue.
Thank you. I'm Akshaya Akhilan. I run a cohort of 3 mental health organizations, predominantly working with marginalized communities. We work with youth and a lot of people who cannot afford therapy, so we provide pro bono therapy services to a lot of people. So I'll keep my question short, right? And this is about AI and health, and I understand there is a lot of global anxiety around AI being implemented in health, and how there are, especially in the field of mental health, when that's something you do really deep inner work. But AI and mental health, it's here, right? AI is with us, it's around us, and I don't think there is like a group of people that can just stop it from being part of the health system. But people who are really looking at, oh my God, is AI going to be taking care of me? And it's not going to be a human. It's not another person who can empathetically understand me. There is a lot of resistance, right? And I know for a fact that that's something a lot of you have seemed to have overcome, at least in many steps and aspects. So I would really love some wisdom on how to approach this, either with the general public or the government or with investors. Yeah, thank you.
Thank you. So
Just a data point. So that I know somebody at OpenAI, and they were mentioning the other day the largest use case for ChatGPT is personal therapy.
yeah. And with India's health system, one can argue that the machine might be slightly more empathetic.
There are actually tests which have actually.
No, and we've done research, by the way. So we've published research on how people form a therapeutic bond. And what we found was that people form a therapeutic bond with an AI agent almost 3 times as fast and about at the same level as a human therapist. And we published that. It's actually peer-reviewed research we published.
Yeah, and to add to this, there was a recent paper in UK, and where they showed that people prefer AI with mammography than radiologist only interpreted mammography. It's a proven thing.
So I just 2 thoughts here. I know we're at the end, so I'll be again very quick. So I think you're right. AI is here to stay, especially that intersection between AI and therapy. But at the same time, it is only one component to the solution. It cannot be the solution. If it is, then we are doing something wrong. In a world where anyway the real people out here are a second screen, and I'm on Instagram all the time, and I sometimes look up to see what my mom or dad is saying, but otherwise I go back on my phone. So at that point, if you start saying, oh, this is going to be the answer, I think there's something wrong. So I think that's one. The second is, even though it is a part of the solution, and if people are using ChatGPT for personal therapy, safety is extremely important. And and this is a much longer topic we can talk about offline on how do you institute a safe AI environment which can actually be part of a stepped care solution where both can play to their strengths and still support the patient or the user.
Dr. Karthik, if I could ask you.
Sorry, I just wanted to add, while how much of the enthusiasm is on AI, as much as I build, we would still want the human in the loop. I don't think we've really reached a stage where we just want AI chatbots to do, whether it is any sort of screening. You certainly want the human in the loop. And so I think going forward, what is going to happen is, whether it is radiologists or psychiatrists who use AI tools are probably going to replace physicians or radiologists who don't use AI tools. I don't think AI is ever going to replace, but we certainly need healthcare professionals who can use AI tools. And that's the reason why I want to say, as a developer, you would want to always think about having human in the loop, even as you build AI tools.
Thanks a lot. We'll unfortunately not be able to take any more questions right now, but hopefully the panelists are around and you can ask them questions. Sorry.
Yeah. Questions from India. One question from Yemen.
Okay, please. Please.
I'm Dr. Abdullah, WHO TDR scholar and WHO Youth Council in Emro. I want to ask all of you, reach to many countries. Any plan to reach to in developed country like Yemen, conflict country? Also I serve as CEO in one of the telemedicine organization. So I want to hear you if you reach to these countries.
We are on the App Store, 103 countries. Want to do Arabic? I think definitely would love to, and if we are, then Yemen is the first place we'll come.
We can do it today.
Yeah, because our patients spend more than $10 million for traveling abroad for seeking small things, even for India.
We have an installation in Yemen.
And you have Vicky there who handles LMIC. Please exchange cards. We can do it today. Thank you. Thanks a lot for asking.
Thank you.
Yeah. Thank you everyone for staying and for everyone who stood at the back throughout the session. I think that's huge encouragement for the relevancy of the topic. I'd like for a picture with the entire panel, but I'll also be remiss to not thank the ACT organizers, Deeksha, Nayonika, and the rest of the team who put all of this together. And big thank you to everyone in the panelists as well. Rounds of
इसमें डाल दिया है हमने, ठीक है. So you can keep changing your own slide, okay? Yeah, with your presentation, I think you're supposed to come here and talk, है ना? Then you will be also. आप इसको slide show पे ले जाना, ठीक है? And अभी हाँ, ये बस slide show पे, हाँ.
हमें वहाँ से देखा जाएगा, हम जैसे डिस्प्ले कर देंगे, हमें सब पता चलेगा.
हाँ, ठीक है.
कौन सा पहले कौन सा ये फर्स्ट है?
नहीं, इससे ये सेकंड पीपीटी है. डॉक्टर ध्वनि यहीं पे पीपीटी है, ठीक है. ये पहले, हाँ ये आएगा पहले. आप यहीं से कर सकते हो.
अच्छा ठीक है, then I can operate ना.
Yes,
Perfect.
you just take it on slide show.
Sure, done.
ठीक है.
Done. एक मिनट, मेरे को बस एक स्लाइड हाइड करना है.
हाँ, ये वाला ना कर दो आप.
I'll ask her. It has to be done first.
I think we are all to get kicked out.
Kick it off outside. Then men and then
Sorry for disturbing. Making healthcare products, environmental products like solar photovoltaics and smokeless stoves are going to make world the slimmest and solar reduction. Likewise. Oh, thank you, sir. So, may I take email ID which I like to share my details to you? You can. And your number, sir? Your number.
Why not say?
I'll think if we can start. Take an appointment for online classes.
That's it. Please.
Thank you.
Hello. Hello. Good morning, everyone. It's a pleasure today to welcome you all to this critical panel discussion on harnessing digital health and integrated nutrition strategies to end undernutrition in children under 5. We are honored to be joined here today by the distinguished panel of experts with extensive experience across public health, digital innovation, government systems, and on-ground program delivery. I am Dr. Shilpa Jain, Regional Director at AIF, and I will be the moderator for today's panel discussion here. Allow me to introduce to our abled panel here today. We have Dr. Rakesh Kumar, who would be chairing this panel discussion with us. He's the former IAS Joint Secretary RCH and currently Chief Consultant Global Health at Wish US. Dr. Kumar is a seasoned public health leader and with over 33 years of experience in policy making and program implementation. Welcome you. Then we have Srimati Shubha Sharma, Principal Secretary, WNCD, Government of Orissa. We have Dr. Dhwani, Technical Director, Public Health and Nutrition from AIF. Ms. Divya Sivakrishnan, Delivery Lead, Asia Solutions, Dimagi. Then Mr. Sameer Kanwar, Director, Digital Health, India and South Asia, PATH. I welcome you all for this panel discussion. To set the context for this important dialogue, I invite Dr. Rakesh Kumar, Chair for today's panel discussion, to deliver the opening remarks and highlight the delineating problem of malnutrition in India as well as key approaches to address the same. Sir.
Good morning, friends. Very distinguished panelists. I'm joined by the top leaders who are working in the field of nutrition and technology, very distinguished participants. I think, in my view, this is one of the most important subjects and one of the most important public health problems in the country that we are going to discuss today. I'm also, grateful and thankful to the organizers and especially those who have curated this session, because in my view there can't be a bigger problem in the public health than the malnutrition. So I think this is so very contextualized. I must congratulate American Indian Foundation PATH for having this done today. Friends, you all know that the kind of problem that we are facing in the country right now, and I always say India is a story of numbers. We are a population of 1.4 billion. Was the largest in the world. We used to be second only to China, but we took over from there just recently. Our birth cohort is close to 25 million, which is too high. We produce one Australia each year. It's about 2.5 crores. We lose about 750,000 under 5 children in the country. Again, it's a huge number. Close to 500,000 or more than 500,000 newborns who die within, let us say, 28 days of their birth. When we talk about maternal mortality ratio, though, it has come down like anything. I always say that from about 560 per 100,000 live births way back in 1990, it has come down to 97. But still, the absolute numbers are quite alarming. It's as high as close to 25,000 mothers we lose each year because of complications due to pregnancy and unsafe abortions. When you talk about malnutrition, again, as I said, the number is too huge. More than 40 million kids in the country are stunted, and we contribute to close to 1/3 of the total malnourished kids in the world. So any problem we talk, India contributes close to 1/3, anything between 20 to 30%. When we talk about under 5 mortality, maternal mortality may be close to 15% that we contribute to the global burden. But when it comes to malnutrition, it's as high as 40 million people, and 1/3. So you can say that we are a home to a large, under 5 children who are malnourished in the country. It's also understood, and everybody knows that when we talk about under 5 mortality, malnutrition contributes to close to, or maybe, more than 60% of total under 5 mortality, directly or indirectly, but it's a huge thing, unless we fix this problem, I think we are not able to make the kind of headways that, India would have been able to do recently. I was looking at the data, friends, I said, because I always say that, unless we look at the data sets and all, we won't be able to understand the volume and the problem across the country. I was looking at the NFSS 4 and 5 data. So we can always say that, yeah, we have improved, slightly in stunting. It used to be about 38.4% in NFSS 4, that is, I'm talking 2015 and 16, but now it is 35.5%. So the decline, in my view, in those 5 years has been less than 3%, which is too small, in my view. Wasting, from 21% that used to be in NFSS 4, it has come down to 19%, again, close to 1.7% decline. Again, it is too low. Underweight from 35.7% to 32.1%, a decline very marginally by 3.6% in 5 years duration. Some of the states, Meghalaya, especially in the northeast, is one of the, it contributes maximum when we talk about the undernutrition, malnutrition, followed by Bihar, which is 43%, UP by 40% or so. They have shown the highest stunting rates in the country. And Meghalaya, other states in the northeastern region, they have done pretty well. But Meghalaya is one state that has not really done. There are multiple reasons behind this. Because I was again trying to look at the data and I recall my previous data at the Ministry of Health. At that point of time, also way back, about 10 years back, look at the highest number of TFR, early pregnancies, multiple pregnancies, spacing was too low. The maternal mortality ratio, under 5 mortality, newborn mortality used to be highest in Meghalaya. But the better off states are like Puducherry, which is about 20% of stunting. Sikkim is 22%, which is lowest. But when you talk about the problem in the country, malnutrition, I always say yes, it is a huge problem. But there are 5 states in the country which contribute to close to five states, and 50% of these districts of these states, they contribute to close to 80% of the malnutrition. So I think that's a silver line which is available with us, because if we know the problem and we know where exactly we need to target, the problem of malnutrition, then it's easier for us to get into. But I think the more alarming situation, when I look at the data, is about, the increase in the anemia rates. And again, children, NFSS 4 and 5 trying to compare. If it were 58.6% in NFSS 4, it has increased to 67%. I'm talking about anemia in children, under 5 children. Similarly, women in the reproductive age group, from 53% to 57%. So increase in anemia is again very alarming. And we talk about anemia in pregnant women, friends, I know even 10 years back it used to be about 52%, more than 50%. Today also it stands taller at 52%. We talk about adults and girls, it's now close to 60%. We talk about lactating mothers, about 61%. My point is that unless we have healthy mothers, healthy women, healthy adolescents, and malnutrition being intergenerations, I see this problem becoming more alarming, with the passage of time. When I look at the global, hunger index, again, India has not really done very well. We might debate that, okay, the data sets are not so well, but we rank 105 out of 127 countries. I'm talking about GHI of 2024. But friends, I always say that malnutrition is a very complex problem. Complex in the sense, we as a country are the biggest, but complex, it has got multiple factors that those are contributing. So I will say that it's a complex interplay of multiple factors, and it's multidimensional. It's intergeneration, we all know that it runs from generation to generation. If let us say a mother is anemic, malnourished, then obviously you don't expect a healthy baby, being born to that particular mother. One more important fact, because you all know the subject, I'm sure, and stunting, 50% of stunting happens during the pregnancy. It happens in the womb, and unfortunately that is uncorrectable. So if let us say somebody is stunted today, 50% of that was contributed when, mother was pregnant. and after that there's no scope even to correct that particular. So I think we need to ensure, when you talk about the kind of corrective steps and measures to be taken, the maternal nutrition plays an important role, and I think will come speakers I want to talk about this. But I always say that malnutrition is not just related to malnutrition. There are multiple, I would say, beyond the nutrition related, I would say, interventions, they play an important. We talk about wash. So a potable access to water, potable water becomes very important. We talk about hygiene. We talk about sanitation. Important, So unless we fix these problems, which are very basic in our country, I think the problem of malnutrition is going to, look at the economy, poverty. There are about more than 20% of the families who can't really afford, let us say, more than $1.25 per day as their purchasing power. So unless we fix that, so you'll find that if 20% of the family are not able to afford, more than $1.25 per day to purchase, things for that, how can we expect that nutrition levels are going to be better? We talk about chronic disease, we talk about diarrhea, pneumonia, we talk about tuberculosis, other, childhood illnesses and all. Again, they contribute. Chronic diarrhea is one of the major problems. Any child who gets into chronic diarrhea, then obviously it's a vicious cycle that sets into, and the problem becomes, aggravated. We talk about environmental factors. Pollution contributes to anemia. We all know it very well. And there are certain taboos, cultural practices, especially in the tribal areas. There are good practices also. I was looking at certain data, when that was about, 10 years ago. And I found that, in tribal areas, you go to Chhattisgarh, Odisha, my colleague Shilpa is there, she'll talk more about this. Tribal areas have good practices, certain good practices, For example, we talk about kangaroo mother care, In tribal areas, you'll always find babies, close to the mothers, They, exclusive breastfeeding, we talk about it needs to be done, let us say, for 6 months minimum. But because the baby is close to the mother, the feeding becomes very. So I was looking at the data, I was surprised in tribal areas, the IMR rates are better than other communities. IMR rates. But suddenly when they start with the complementary feeding, then unhygienic conditions, they lead to diarrhea, and then, then the under 5 mortality or IMR becomes, it increases with the passage of time. But I think that is also the culture. But, at times when you find that the colostrum, feeding, you have to feed the baby within 1 hour, which is very, very important. In certain communities, you'll find that they would like to throw it away. I think, so these are very, very important practices I think we need to, keep into mind. So all these leads to, all these factors, they lead to, mortality, morbidity, poor development of the child, poor health, anything you talk. So I would say nutrition is the very fundamental core component of any healthy life that your baby is going to, have with them. Also, another factor, and then I'll pause, we talk about the development of the child. So malnutrition, certainly the first 3 years, I'm talking about the first 3 years, are very, very crucial for any baby to grow healthy as an adult. Because ultimately impacts on the sensory motor development, cognitive development, and social involvement. So these are 3 important things. Bob Black is one of the top professors at Johns Hopkins University. I met him, had a privilege of meeting multiple times. He has established this particular fact that any baby, let us say if somebody gains normal weight, during the first 1,000 days, then finally the adult is going to have a thin, lean body structure. But any baby, any child who's going to gain, let us say, more weight or start gaining weight after 1,000 days, the first 1,000 days, then the body is going to ultimately become more fluffy. It's going to be obese. So you'll hear that when we talk about malnutrition, friends, it's again a complex problem because it not only leads to, let us say, the communicable diseases, because low immunity. So we talk about TB, malaria, we talk about pneumonias and diarrheas, but also finally they land into non-communicable diseases. You must have heard about type 5 diabetes, under this case they finally land into type 5 diabetes. You talk about cardiovascular diseases, these are the cases. Those who are stunted, they finally land up, with these kind of. So friends, what I say that, there are multiple things, so it's a very, very complex subject. And I thought, let me just set the tone for this session by, sharing, a few basic, things. I know you all know about it, but I just thought that let me refresh again, because this is a problem which can't be just tackled by, let us say, by the governments and all. Everybody has to put, and the multi-sectoral approach needs to be, needs to come into play. So I'll pause here, friends, and then certainly I look forward to, a very exciting, speakers. We have top-notch people to speak about this. So I'll come back to you again. Thank you so much.
Thank you. Thank you, Dr. Rakesh. So thank you, Dr. Rakesh, for setting the tone so powerfully with the citations and the statistics. As this discussion stands at the convergence of public health, digital transformation, and social equity, and rightly said by Dr. Rakesh also, undernutrition is not just a health crisis. It's also a reflection of equity, social disparity across the sectors. So addressing this requires integrated, innovative, and equity-driven solutions. To move forward with the first round of panel insights, I would like to invite Dr. Dhwani to share AIF's experience on how integrated solutions have worked in addressing undernutrition.
So, good morning everyone. I hope everyone is settled. So, thank you so much, Dr. Rakesh and Dr. Shilpa, for setting the stage and context. I'm Dr. Dhwani, and currently I head Public Health and Nutrition portfolio at the American India Foundation. It's an absolute pleasure and privilege to be here among such passionate thinkers and change makers. I want to start this session by sharing a very simple yet profound incident that happened to me. I started my public health journey in my early 20s as a medical officer of a primary healthcare center. And when you are a medical officer, you work very closely with the frontline workers, right? And one fine day, one of the ASHA workers, she came to me after completing her duty, and she simply told me one thing. And I particularly remember this incident very vividly. And she told me in Gujarati, but I'm just paraphrasing. So what she told me is that when child is well fed, mother smiles more. And that particular thing stays with me ever since. And at American India Foundation also, we strongly believe that healthy and nurtured childhood is not just a development goal. It's a very deeply human story. A story of human interactions, learnings, hope and love. With that being said, let me just quickly give you a walkthrough about the flagship program of American India Foundation called SNAH. Talking about rationale, we all know the science, right? First 2 years of life, they are very critical and basically lays the foundation for everything that follows. This particular window is very fragile when we talk about vulnerable and underserved communities, right? We have seen toddlers who are sick. We have seen toddlers, they are too tired to play. We have seen mothers trying to stretch one meal into three. Young children entering into school already behind. So that was the reason when American India Foundation decided that we have to act early, holistically and boldly. Talking about problem statement, in India almost every third child under 5 years of age is undernourished and nearly half of them are not school ready. But these statistics are just, they don't just represent the numbers, right? There are faces and names to it. They are the future children who have not realized their full potential yet. And that is the reason we have decided that let's do and address something around nutrition and early learning all together via our integrated approach called Program SNAH. Because that is how child grows, right? Child grows in an integrated fashion, not in silos. So basically what we had done is that we have launched this program in a close coordination and participation involving government from the very beginning in 6 aspirational blocks of 3 states, namely Madhya Pradesh, Odisha and Karnataka, targeting almost 30,000 children of 0 to 6 years of age. And now let's talk about the differentiator points of this particular integrated approach. So we essentially decided to work on 7 key elements while ensuring this integrated approach. Obviously, the first thing was that how we can bridge the nutritional gap, right? So essentially, we have started with creating a age appropriate recipe and providing hot cooked meal for the children of 6 months to 3 years of age. So this was not a part of traditional government ecosystem, right? In the ICDS program, they usually provide take-home ration to this cohort. So we have started providing with this hot cooked meal to this particular cohort. On top of that, we also have introduced nutritious snacks for the children of 3 years to 6 years of age. So this was a nutrition part. Apart from this, we have put a lot of emphasis in terms of how we can strengthen the existing system, right? So we have put a lot of efforts in terms of building capacity and competency of the existing frontline workers who are responsible for delivering these services at the Anganwadi center. Apart from this, we had ensured how we can actively engage the caregivers in this entire process, caregiver being mothers, whoever takes care of child in their homes. Simultaneously, we have done extensive community outreach as well. And to make this more innovative, we also introduced element of management information system, how we can essentially leverage digital platform, in terms of decision making. And simultaneously, towards the end of the project, we also introduced some of the AI innovations as well. Talking about the differentiators in early childhood education, essentially what we had done was that we have adapted and transformed the Anganwadi center where we were working, and essentially we had transformed them from a feeding practices to a learning spaces, right? We also have provided a lot of learning initiatives in those Anganwadi center. We have co-created learning calendars for those frontline workers who were working in these Anganwadi centers. We have also created context-specific, age-appropriate teaching and learning materials, co-created this for those people. Those were contextually related, so that with added local flavors, right? So that content felt familiar to the children. And this learning was basically followed by a periodic assessment of these children as well. This shift from passive service delivery to active engagement, I would say, was one of our most meaningful outcome. Now talking about outcome, let me give you a brief idea about what were the findings of the evaluation, right? For this, we had hired a third-party external evaluation agency who had done a baseline and midline evaluation for us, and I'm going to present few numbers of this evaluation finding of Vidisha district, one of our geography where we had worked. So baseline and endline duration was 18 months apart, and the result, the least to say, the results were really promising within the span of 18 months itself. We have observed a reduction of 10% in prevalence of stunting. This was more higher gains for a particular girl child. We have observed underweight cases fell significantly with higher reduction among the children 6 to 23 months of age. These were our target cohort where we had actually provided this hot cooked meal to these children. We have observed that overall undernutrition declined across the board. We don't think this was a magic, right? It was result of a well-structured, coordinated efforts powered by trust and backed by data. Talking about effect of early childhood education initiative, we have observed a 27% improvement in school readiness among those children at a different learning levels, whether it is writing, comprehension, speaking, reading. We had adapted tools created by World Bank to be able to deliver these learning services to those children, and we have observed remarkable learning improvements here as well. So what did we learn from this execution of this integrated project in a very shorter duration of time. Firstly, integrated program and approach actually works, and it has shown a promising result. When we use digital tools embedded within the design of the project itself, it certainly will help to feel the frontline workers empowered. When you give caregivers and mothers a seat at the table, community automatically rises. And most importantly, the way we have executed this entire project, we are very confident that it is possible to deliver appropriate nutrition and early education with the unique cost of 10 Indian rupees per beneficiary per day. Can you imagine this? Most importantly, we have realized this transformation doesn't need to be imported. It can be designed with the help of community, for the community, within the as complex system as we are having in India. So in conclusion, if I have to summarize and conclude, when we are moving ahead, what actually we are looking at is a scale. Scale which is sustainable, system-led, and rooted in equity. And that was the very reason when we have executed this entire project, we work very closely, hand in hand, with the government ecosystem. Whether it is at the state level with ICDS directors, or at the district level or block level officials, we have very closely worked with them from the inception of the project itself. Our approach has always been to, complement and augment the government systems, because we already know that public system work best when they are supported, not bypassed, right? And just to add one last bit, given the turmoil and the thing currently happening within the public health financing landscape, I think this represents a very crucial opportunity, particularly to India, in terms of how we can identify and leverage locally available sustainable financial resources, right? This moment actually calls for strategic efforts to think beyond the traditional system of donors, right? How we can engage experts across the board in channeling and mobilizing local resources in a meaningful way, how we can leverage public-private partnerships, CSR funds basically. An idea here is to ensure long-term resilience and self-reliance in public health financing. So this is overall highlight of the project that we had executed. Thank you.
Thank you. Thank you, Dr. Dhwani. Thank you so much. Thanks, Dr. Dhwani, for drawing our perspective towards the on-ground integrated approach and how, when it is banked by a data-driven planning, leads to positive outcomes. Thank you. Moving on, like we know, government plays an important stakeholder in pivoting all these interventions on ground. So now I would like to invite Subha Sharma ma'am to share the key government insights on the same.
Good morning. It is a privilege to be here in this room with practitioners of the health and nutrition sector. And I would like to thank the organizers, the American India Foundation, for giving me this opportunity to be here to present some of the good work that is being done by different governments, and more importantly, to learn from people here who have shown success in various parts of India. The first speaker, Rakesh sir, has already set the context beautifully. In the interest of time, I will just mention the points because I don't want to repeat. Nutrition and health is often an overlooked problem, the preventive aspect of health, because one doesn't realize the consequences till it is too late, and sometimes it is irreversible. It is also an intergenerational issue, and therefore results are not immediate in coming. And especially from the bureaucracy point of view, it is easy for me to construct a building or build a road or complete a bridge, and everybody is able to see it, visualize it, acknowledge it, use it, appreciate it, but to bring about a 2-point reduction in the IMR or the MMR or stunting or wasting will take years of effort. And by the time that result comes, most of the people involved in the entire campaign would have moved on. It is not a single factor which is in my control or any single department's control which can affect this. There is WASH, what Rakesh sir mentioned, drinking water, sanitation, anemia, food supplement, community practices. There are so many issues that it is perhaps impossible for one department or even one government to take care of. Wherein this lovely word of convergence comes in, which sounds beautiful, but is sometimes a very challenging task to achieve when you are working with human beings from many different sectors. The problems confronting us today are again very interesting. On the one side, there is malnourishment and undernutrition, and on the other side, you have a growing trend of obesity. So now sugar, if you reduce sugar, it is not palatable. If it is not palatable, the child does not consume it. There are substitutes available, but everything comes for a price. The problem is defined. Today we are very fortunate. You might have read the Poshan Tracker application of the Ministry of Women and Child Development received an award from the Prime Minister's and the President just last week. I think that is an amazing achievement in a place like India, where I have put in 25 years of service with the government, and we began with literally no data, and today we have such disaggregated and detailed data available. It's a great achievement, and it helps us to identify pockets which require attention, to identify individuals who require greater care. The solution, to my mind, has 2-3 parts to it. One is the abstract or the policy formulation, wherein it has now been accepted widely that there is no one solution for the diverse country that we have, or even, I think even in other countries it would be similar, that there is no one solution which works. It has to be contextual, it has to be regional, it has to be local. And Poshan 2.0, the scheme, provides for this under various heads, innovation, IEC, so you have the flexibility to devise locally appropriate solutions. Data is such a blessing for a policy practitioner because you know what is required in which part, and it definitely helps in optimum utilization of resources, not the words itself, but actually putting in resources in areas where they are needed. I stand here as a representative of the government of Orissa today, and Orissa is blessed to have certain advantages. The state government's budget is frequently used for topping up and complementing whatever central government initiatives are there. More than that, we have a robust civil society partnership happening. AIF is one. There are many others, and in case any more are interested, I am open to talking to the civil society partners. Our Anganwadi centers and the ICDS machinery actually works. ASAR report has identified that the enrollment in Orissa in preschool, pre-primary education, which is basically the work which is done by Anganwadi centers, is 92%, which is the highest in the country. So there is some value which communities see in sending their children to the Anganwadi centers. Our Anganwadi workers are present in literally every, we call it pada, a small locality in the state, and they are frequently, they are the face of the government in that locality, be it election work, be it immunization, be it the VHND, be it nutrition. We also have a very strong network of self-help groups comprising of women. About 70 lakh women are involved in this. This helps in bringing about some amount of cohesion and ease in networking and mobilizing the community. If I come to the practice part of it, we have introduced several innovations in the state government, and I would briefly like to share some of them with you. As you might be knowing, Orissa is a tribal dominated state with more than 33% forest cover. It is one of the few states where the forest cover is increasing year on end, And it has its own difficult terrain and therefore unique challenges, because reaching to the most marginalized groups is generally in the most inaccessible pockets. So we have this small program called the Pada Pushti Karikram, wherein if a locality has more than 5 young children in the age group of 3 to 6 years, and the distance from the Anganwadi center is high because young children cannot walk beyond a certain distance, or if there is a geographical barrier like a hillock or a river or a nala or something, then we utilize one of the self-help group members, women, and they cook locally and they provide food to the young children in their house on the veranda, and they get reimbursed with a very small incentive. The other very interesting initiative that we have taken up is called the Purnahar program. Thanks to Poshan Tracker, we were able to identify children who are in the SAM category, the severely and acutely malnourished children, who are most at risk. And then we do a concentrated feeding program for them for about 112 days. It has been specifically designed: additional eggs, an egg a day, additional augmented take-home ration, which has basically energy-dense nutrients and oil. And this has shown phenomenal results, with more than 82% children getting cured. That means transitioning either to the normal or the normal category, and 90% plus if we include children who have moved to the MAM category, because then from MAM they obviously with some more care and effort can transition to the normal category. This has also been evaluated by the Kalavati Center of Excellence and has been identified as a best practice. As a result, when we started, we had something like 17,000 children who were in the SAM category in 2023 February. Today, in April 2025, this figure has come down to 9,800. And this is also not, it's not as if the same children are continuing. It's, as you realize, most of you understand, new children will enter and children who get cured will exit from this. The state government provides topping up apart from what the central government gives, and using these funds we provide eggs. Luckily there is no community or social discomfort with consuming eggs, so that has really helped in improving the nutritional status of our children. A lot of millets is locally available, greens. So we have this Nutri Garden scheme wherein in the Anganwadi center our agriculture department, Convergence, and the horticulture department gives papayas and drumstick trees and greens, so we use those. I think what Rakesh sir said was a very interesting thing when he talked about how malnourishment starts much early on than when we actually physically see the baby. So perhaps, I mean, I would say even before pregnancy, because if you look at some of our adolescent girls, they are underweight, they are anemic, and they are malnourished. So taking this life cycle approach, we have introduced a nutritional supplement. Government of India also has it as a scheme for adolescent girls, which operates in select areas of the state, and in the rest the state government operates a similar scheme wherein we give them nutritionally rich food items every month. We ensure that they visit the Anganwadi center once a week. So we have this unique scheme which is Advika and which also says I am unique. So each Saturday adolescent girls visit their Anganwadi center. It is now a 2.5-year-old scheme. It has been evaluated by international organizations and found to be actually working. And so that there they do a couple of things. They consume their iron and iron tablets. They consume their boiled egg. They also take their nutritional supplements. And more importantly, they talk about issues which are relevant to them. So menstrual hygiene, child marriage, career and training and self-employment or employment opportunities. Any issue which is troubling them, we have a monthly calendar. And during COVID, it also used to be hygiene and hand wash. And this has received tremendous response from the community. So the attendance in these Advika sessions has been going up. And then on popular demand, we also introduced Advika boy version. So they, the boys, the adolescent boys also join once a month on a Saturday. And then we have now this network of about 12 lakh adolescents who are connected through wonderful WhatsApp groups, and information dissemination happens amongst them. During pregnancy, a woman is most vulnerable, so cash transfer schemes like the Pradhan Mantri Matru Vandana Yojana, which operates throughout the country. The state government has its own scheme called Mamata, which provides for cash transfer to the lady. And you might have read about Subhadra. This is a new initiative by the government, which was launched in September last year, which makes a transfer of 10,000 to eligible women every year. And though there are, I'm sure, some people who would feel that this is a dole and this doesn't work, but while we are doing a detailed impact assessment, our dipstick studies show that 40% of this money is being used for enterprise with small investment activities like poultry, goatry, vegetable cultivation, supplementing the working capital in an existing business, whether it is sewing or a small tea shop or a small variety store. The rest, 60%, is very interestingly divided. About 20 to 30% is used for, is left in the bank for using it when the money increases and she has some more funding, and the other for emergent needs related to health or education of her family. So Subhadra has empowered women, and there was also a mention about the first 1,000 days of the children. So apart from giving nutrition and telling them all the time, we have launched this scheme 2 years back, which focuses on the under 3 age group. There was no scheme in either the center or the state for the less than 3 kids. And in that, it is basically bringing about social and behavioral change by engaging with the caregivers, by engaging with the community. We have these flip books which allow families to know that what is the development milestones with their babies should achieve. They should start holding up their heads, or they should start crawling, or they should start babbling. So it helps, and every month the caregivers come to the Anganwadi centers, they sit with the worker, they talk about the problems which they're facing, whether it is feeding, whether it is tantrums, whether it is some health related issue, and they also talk to each other, and we find that is a big network and support. AIF is working in Mayurbhanj district, a tribal dominated pocket of Orissa, and Dhwani has shown some of the results. They are actually quite impressive, but I have a caveat there. It is not always easy for government to scale these up, because we have competing resources, we have a limited budget, and therefore sometimes it becomes difficult. Now, recently we have also started looking at building the capacity so that the data which comes to us is authentic and it is very good. So AI is being used. There is a pilot which is being run in Orissa now by the Vadhwani Foundation, and that I believe will be a game changer, because if you have accurate data, it helps in formulating your policies. At the end, I would just like to say that these wonderful events help us in A, getting to know the good work that is happening in different places, but B, I think also it is time that we learned to, there is a requirement for some kind of disruption in this sector. We've been doing a lot of things for a long time, but if we have to leapfrog or make a jump which is visible, then some disruption needs to come, and I think you are the people who have worked long enough to be able to suggest what needs to be done. But above all, it is time that we started valuing nutrition and health as a society, as a community. Because unless that happens, the funding won't happen, the community interest won't happen, and we will not change as a society. So that is my request to all of you here. Let us make nutrition a centered theme which needs to be discussed, which needs to be focused, because otherwise by the time the results come and we want to go back and redo it, we may not be able to do that. Thank you so much.
Thank you. Thank you, ma'am, for sharing the enriching experience and the perspective of the state and the government, and also highlighting how even in remote tribal areas, inaccessible areas, with these kind of state-led models, we have been successfully implementing most of the programs. Moving on to, like rightly shared by Subha ma'am, in terms of the partnerships, the convergence, which remains, at a standing point if we need to have those kind of positive outcomes. So, with respect to partnerships and convergence, would like to invite you, Sameer, to share certain insights on how the PPP model works on scaling up initiatives along with the digital health infrastructure.
Thanks, Shilpa. Good morning, everyone. I hope we are awake, and I understand the seats are a bit less, but I think there are a couple of seats vacant here if somebody wants to just move up and occupy them. Okay, so I'll speak from the perspective of a person who's been outside the government but has been associated with, to start with, the Poshan Abhiyan. In fact, I wrote the guidelines for Poshan Abhiyan when it was started in 2017. Right, a fantastic initiative, and we talked about convergence, right? And it talks about 12 to 14 ministries coming together, like the principal secretary said that probably one of the most difficult pieces to do within the government is to achieve convergence. So I think we need to look at convergence from the bottom to top approach rather than trying to do a top to bottom approach, right? And that's where I think a couple of states have done fantastically well. In terms of, if you look at the village level, you have the ASHA and you have the Anganwadi workers. Largely, you will find the norms are the same in terms of population, about 1,000 each. So roughly, you would find the same number of ASHAs and same number of Anganwadis in a village. What doesn't happen is the coordination between the two, because they would be addressing the same set of families, but their groups would be different. So number of states, what they have been able to achieve is to do a buddy system between them to ensure that both of them as a pair are reaching out to the same set of families. And that's exactly where convergence actually starts. All right. Unless and until we don't do that, what happens is that technology will never be an enabler for you. Right. Now, if you look at technology, because technology, unfortunately, in our country remains siloed, the way it is rolled out. Right, we do not look at technology as a system when it is rolled out, because the beneficiary is the same. It's the same family, the same mother, the same pregnant women, the same children being addressed by different departments, right, for service delivery. But we do not look at it as a system, and therefore whatever we roll out in terms of programs or processes goes vertically down. And therefore technology can be the only one which can get all this together. And that's where I think we should look at technology coming in, and when these two workers start working together, they are at least able to address the same families. You have a continuum coming up on your systems, right? So if, let's say, I have a portion tracker and I have an RCH 2.0, which is addressing the same set of beneficiaries, you at least have a continuum coming up in terms of data at the block level, at the district level, when it can be effectively used, right? So a continuum approach, a systems approach is extremely important when we are looking at convergences to happen on ground, and it is possible. Like I mentioned, a couple of states, I have worked in a couple of states where they've been able to do that. UP is doing it today. Gujarat has already done that. And technology has then been an enabler and a binding factor of these partnerships, coming up. The second is when we look at capacities, and I saw Dhwani's presentation as well. I think we have enough data. And please don't connect data to technology, right? Data is not always digital, right? Data can be on an Excel sheet. It can also be on a paper, right? It needs to be used. And use of data and capacities to be able to use data is extremely, extremely important right from the ASHA, right? But unfortunately, in our capacity building landscape, we do not look at digital or data being used for decision making at each of those levels, right? And if you start doing that, your quality of data will automatically start improving. You really don't have to do anything about it. The systems don't have to do anything about it. When you start using data, the quality automatically improves, right? The next is the use of technology. AI has become a fact. By the way, I come from a tech background, so I am a party to it. But everybody today wants to use AI. For what? We really don't know. There's a tool available. Okay, fit it in, right? And do a pilot to it, and get some data, and say, oh, fantastic, we've done a wonderful change. That's not how technology works, right? We need to fit technology into a problem and see what are those problems which we want technology to solve for us. Right, in that continuum of care, right? Do I want to detect HRPs? Do I want to do an early detection for LBWs? Do I want to do a fetal monitoring to ensure that when the child is born, it is healthy, right? Do I want to do a preventive care for detection of malnutrition? And if these are the things I want to do, then let's look at technologies being plugged in at that particular place, right? But then before you do that, you still need a continuum. When I say continuum, means a digital continuum of care being recorded. Otherwise, these technologies are just going to be pilots and failing us, right? Now, if you look at the portion tracker and the growth of portion tracker, it is fantastic, right? How is it engaging? It is engaging, as I understand, as we speak. Vadhwani, like ma'am was mentioning, is already doing a pilot, but that anthropometry tool is now being integrated as part of the portion tracker because it's been able to give you a continuum now, right? And the next step to it, what is required is to be able to use that for decision making, for planning purposes, right? Being able to use that data for service delivery effectively. So that's the place where technology starts playing up and partnership starts playing up in terms of convergence. These are very simple things which can happen at the ground level. If we try and do convergence at the highest level, it is always overwhelming, right? But when we start the convergence the ground level, it's actually already happening. You have to just start strengthening around it and ensure that it's in place, for delivery. When we look at technology being able to give us the kind of results which we are talking about. Again, coming back to portion tracker, a fantastic thing which has been done, as I understand, is also a citizen-facing application interface has been provided now. Now that's the way and the power of technology, right? And in terms of being able to engage the user, the citizen, onto the platform. Now it can be a fantastic tool for doing BCC, for very targeted IEC campaigns happening, right? It needs to be contextualized in terms, we understand that as a family in India, it's the mother-in-law and the husband who probably take decisions in the family. And therefore, is that application being used by them? Is it being used effectively to do BCC for the entire family or do targeted IEC campaigns for them, right? How does it translate into the services being delivered, let's say, at a VHND or a VHSND or let's say at an Anganwadi? Now, all this needs to come together when we are looking at convergence, we are looking at partnerships, we are looking at all of us, sitting in this room are doing some pieces of work, right, when we go down on the ground. How does all these pieces of work which we do come together in that particular geography? Please look at it from the systems perspective. Kindly do not look at it, when I say system means a village is a system, a block is a system, a district is a system. And when we look at health and nutrition, they go hand in hand. They can't be seen as separately because otherwise we'll not be able to look at the leapfrogging which we are looking at and talking about, right? So please look at it as a system and ensure that wherever you are working, you are achieving that convergence at the ground level because that's extremely, extremely essential for effective service delivery for nutrition and health. Thank you.
Thanks, Ami. Thank you so much for emphasizing the systems approach as a core to design any kind of an intervention and also building on to the user-centric technology tools which we have been talking about. That also brings me to the next, inviting Divya for sharing how even in the low resource setting, we can do the digital innovation in technology to address the core issue of undernutrition.
Thank you, Shilpa, and thank you so much, American India Foundation and PATH, for having me here. I am really honored to be part of the panelists and the important dialogue today on addressing the more important sort of topic on nutrition. I am Divya from Dimagi. Dimagi, for those of you who are not aware, is social enterprise, digital innovations organization that has been working to amplify the lives of frontline workers for the last 2 decades or so globally. And we have quite a deep sort of experience in India. And the collective partnership with a variety of different organizations and the governments, including the frontline workforce, has been driving us and our impactful work across the different domains. Speaking of maternal and child health, there are a few different aspects that Dr. Rakesh mentioned about mortality rates, about kangaroo mother care, about malnutrition, etc. There are a lot of aspects that go really beyond the RMNCHA domain, and potentially also look at mental health. How are we building the capacity for the caregivers, etc. So it's really a very dynamic sort of conversation that we are having today, and I don't really have to talk about the power of technology. I think Samir has really beautifully incorporated that into his speech, and I think collectively there are a lot of work that is being done. I think the idea is to really bring that together, and that's really the way for us to look at it more futuristically. So based on the experience that we have had, the MAGI has sort of developed a nutrition solution which looks at improving the nutrition and health indicators for children between the age of 0 and 5 years of age. And this is basically built on the fact that the frontline workers can have innovatively designed job aids for them that is offline based, and can be used in local languages, and is intuitive enough for low literate frontline workers to be able to use it, and it does kind of cover the critical life stage for the children, specifically looking at addressing the nutrition aspects. As part of the various efforts, I want to take the time to specify and talk more about the association that the MAGI has had with the American India Foundation in piloting one of the more important sort of aspects from the SNE solution standpoint. So our association dates back to a few years back when we started thinking about the nutrition solution. As Samir mentioned, there is a lot of data capture that already happens on ground, right? There is information that is being collected either manually or through digital aids. What we essentially have done is to develop a solution that is aimed at empowering the frontline workers, because they are an important link in this entire systemic change that we are talking about, and providing them a job aid and a tool to be able to address the situation. So we have about 60 odd frontline workers who are utilizing the application, and we have reached to about 50,000 children through this program, specifically looking at data capture. But is data capture really enough? Can the aspect really stop there as far as we're looking at addressing important issues? No, I think data is really the formative aspect, right? What do we do with the data? Are we utilizing that for program implementation? Are we looking at data-backed decision making? Are we empowering the various stakeholders, whether they are frontline, administrative units, or decision makers, to be able to say, okay, this is the kind of data that is coming in. Is it good quality? I think Shubha ma'am spoke about the importance of the quality data coming in. Otherwise, there is trash in and trash out, which we all are aware of how that is probably adversely affecting the implementation that happens on ground. So just moving forward, what we have essentially done is to be able to utilize that data that is being captured across various beneficiaries and look at it more from an analytics standpoint, but also going a step further, looking at data from a predictive analytics model is what has been a truly game changer for us. So I think here technology is not just enough from a systems change standpoint, right? So looking at the ability to look at a predictive model has been through using the existing data and machine learning aspects to generate risk scores for children, to be able to inform, predict, as well as really empower the frontline workers who have been associated with the implementation. So the idea is to look at a algorithm that can be developed based on the risk scores for children who have basic anthropometrics like weight for age, their height for age, weight for height, etc. And we essentially have collected the information, assessed that in a manner that allows us to identify top for priority children who need interventions on ground, and more from a preventive standpoint. So I think retrospective work has always been on the run, but how do we look at a more preventive framework? So this kind of hinges on that particular aspect. And we also have a randomized control trial that looks at both the treatment as well as the control groups, to be able to see what is the kind of evaluation, what is the kind of positives that is coming out from this implementation. And this is being done in a coordinated fashion with the Anganwadi workers and the Anganwadi centers on ground. This is being piloted in Madhya Pradesh and Odisha. And we have about 600 children who have been identified through the implementation work that has been done across a few targeted, 150 targeted Anganwadi centers. So what are we really looking at when we look at predictive analytics? So on the ground, you all know there are frontline workers who collect the information. The information allows them to engage with the caregivers more specifically in terms of counseling, in terms of talking to them about what can we really do to be able to look at more preventive aspects. But is the protocol management really enough? Perhaps not. So the ability for us to look at aspects specifically from a child's anthropometric standpoint, letting the parents or the caregivers know that this is where the child really stands, and not allowing the frontline workers to kind of manually input their status on the graph, because not all frontline workers are literate enough to be able to do that, right? They don't know how to potentially use graphs and plot them. The importance of probably looking at the decimal figures when the Newark screening or the z-scores are being captured. So there are really small and integrate points that need to be kept in mind when we are designing innovative solutions, specifically from a frontline worker standpoint. So the idea here has been to kind of identify the children at top risk, empower the frontline workers with that information. And the idea is to ask them, the integrated community volunteers, to be able to go to the caregivers across 14 different visits to them and talk more about counseling, about various aspects in which they can provide the information to the caregivers, and look at it more from a preventive standpoint. So while we are at the early stages of the evaluation itself, we do believe that this has more positives for us to offer, and across the 600 children that we have looked at from an intervention standpoint, we know that about 88% of children have sort of completed the intervention, all of the visits that were expected by the frontline workers to be done, those have been completed. And we also know that about 95% of the children have received more than about 10 coordinated efforts from that side. So right now we're looking at ways in which we can potentially look at the information that we have already captured on the ground, and see from an evaluation standpoint what can we really do more from a data standpoint. The idea is to also look at how can we compare this information with the intuition that the frontline workers already have. So there are Anganwadi workers who have looked at these children and the communities for years together, right? When they look at the beneficiary, when they look at a child, they already have sort of a formed opinion about what this child's health status looks like. So the idea is to also compare between their intuition and the data that is being collected, to also see, okay, now look, when I look at a child, do I see that child to be slipping into a SAM or a MAM? And if not, can technology really come into play to be able to tell them, okay, maybe you're not able to identify that, or maybe it isn't obvious because the child is not stunted, the child doesn't seemingly look underweight, but there are other aspects that need to be looked at, and here is probably a list. So how can we probably give that information to this very important linkage as the frontline workforce, to be able to bridge that gap between the various stakeholders who are collectively looking at a systemic change. So the information is hope for us to kind of scale up as well. as we move forward. And I'm hoping that the learnings that we get from this particular implementation will really help us move forward, more from looking at data being the pivotal aspect for decision making and improving the programs at large. And I think at Dimagi, it's not like the focus is really not on digital solutions or technology really. I don't think technology alone can solve all of the problems. It has to be a collective call for action. It has to be looking at, investing and financials from a child lens standpoint, given the importance that this topic really has, and to be able to see what can the governments do, how can we amplify the work that they are already doing, how can we bring in the domain experts or the subject matter experts into the play, and how can then technology be a catalyst rather than a tool in itself. So I think all the empowered panelists here have spoken about all of these aspects in detail, so I will not get into the specifics of it. But I really hope that technology can be an enabler and look at implementation more from an integrated fashion. Thank you.
Thanks, Divya, for sharing your insights on building the tool which is user-centric and incorporating the adaptive learning towards creating a predictive tool and as a model. Quickly, because of the paucity of time, I would like to just go to each one of the panel and ask a key practical takeaway. What should be our top priority to end undernutrition using digital and integrated strategies, ensuring resource alignment? So to begin with, Sameer, if we can.
So I think to me the key word is convergence at ground level. If we can make the systems start talking to each other and exchange of data possible, which is possible technically, if that happens, I think we would have achieved quite a bit.
So convergence at ground level one.
Yeah. The technology convergence.
The technology convergence, great. Dhwani?
So, well, in my opinion, at this point of time, the challenge is no longer about the resource scarcity, right? Many things have changed in the past for good. So now it's more about how efficiently we optimize and mobilize the existing available resources which are available within the existing public health ecosystem, right? Real ask is to ensure the collective action to ensure that resources, whether they are financial, human, logistics, consumables, are actually reaching to the point of care delivery site in a timely and efficient fashion. I think it's a high time, as Mem was also mentioning, about coming up with some sort of a disruption, right? And any program, any pilot we won't be able to scale it up without the funding, right? So funding is a major bottleneck. So I believe it is a right time to explore how we can leverage innovative alternate financial mechanism, financial tool, right? Such as blended finances, performance-based financing, direct facility financing, right? Social impact bond, social stock exchange. And these are not just like far-fetched ideas. Everything is doable, right? It is more about how we can put all our critical minds together and act with urgency and intent.
So, Dhwani, can we take it as optimal utilization of resources with blended finance?
Yes.
Yeah, great, thanks. So, moving on
Thank you, Shilpa. Just I think, as I mentioned in my previous talk also, I think I'll again like to bring in on a sharper focus on those first 1,000 days, because the problem starts from there. And always say that good nutrition is as foundation for a healthy life. So in my view, I think let us start focusing on the first 1,000 days. That includes pregnancy, that's 9 months plus 2 years of the child. And when we talk about this, I think let us also look at one thing, that let us try to identify at-risk, families or pregnant mothers and those children up to 2 years. So that way, if you start looking, at a village level, as Sameer mentioned, it becomes easier. Otherwise, it's a huge problem if you look, at the national level. At village level, if you start identifying those at risk, means those pregnant women who are anemic, malnourished, and those kids up to 2 years, I think that becomes. And then we already have an essential nutrition package which is available for these families or for the pregnant mothers and all. So how best maternal nutrition becomes important. We talk about IYCF, that is very important. When we say that early initiation of breastfeeding, even today it is just about 40%. How best we can improve it further. Similarly, the exclusive breastfeeding for a period of 6 months, absolutely mandatory. That we need to ensure nothing else is to be given except for mother's, milk. The third is complementary feeding. It has to begin at 6 months, but it has to be of quality and quantity both. Because if kids, and then obviously, if you do it under unhygienic conditions, then what's going to happen? The child is going to have diarrhea. So all these things, and then, so the convergence of portion and RCS, reproductive maternal newborn child health interventions, becomes of paramount importance. I think that is where, in my view, lies the success. So let us start looking at these, and then finally, I would like to say that, the long-term measures, that I was talking about, whether we talk about the nutrition, whether I'm talking about wash issues or education, empowering mothers and all. So that needs to keep on occurring, simultaneously. But I think a sharper focus on first 1,000 days, in anybody's life is going to be of paramount importance. In my view, my last point, that we need to call for action. You mentioned about this. Absolutely. The action needs to become, needs to come, it needs to start early. It needs to start urgently, and then let us start focusing. Technology obviously is going to be a huge enabler. It can't replace, what exactly is supposed to be done over there, but huge enabler. I think we have to use technology also optimally, whether we are talking about digital or AI solutions, which are currently available. So I'll pause here. Thank you.
So we get as a key takeaway, focus on 1,000-day approach with call to action. Great. So Subha ma'am, if
So I would like to see things. Yeah, I would like to see things from the other side, which is that all these things are necessary, but once the stakeholder is convinced that it is necessary, and I would cite 2 examples, or maybe 3, yes. English. We never had to push our auto drivers or our tourist guides to pick up English as a social skill or a soft skill. But even the poorest of the poor in some states would prefer to pay a premium to put their child into an English medium school because they see a value in later on in life. Let us look at UPI. Nobody had to push for UPI to be used. Today, I think hardly any of us carries cash in our wallets or in our handbags. Let us look at online commerce. The most illiterate, or not illiterate, but semi-literate person today will order a lovely dress online or order a mobile case online. These things have picked up not because we told them to, but because they saw value and benefit in it. The day the people, the stakeholders, see value in investing in nutrition, in doing all that we want them to, all these technologies will click and they'll pick it up. So as a practitioner, I think my 1-point agenda is to convince the community, to convince the people in general that 1,000 days are important, that disruption is needed, but it's going to be a long, long journey on that. Thank you.
Great. So we take it as user and stakeholder centric design, ma'am, as a key takeaway. Divya?
You can word it. Well, actually, ma'am stole my answer. So I'm going to say that there are a lot of initiatives that are being done in silos. The urgency is probably to look at it in a more consolidated fashion and see what really contributes to the success of an implementation, and probably really push forward from a goal perspective rather than, for like individual agendas. So, and perhaps focusing much more on preventive care, because treatment, of course, can take its own course. So that would be my takeaway.
Great. Thanks, Divya. So moving on to thank you all the panel for the beautiful and the thoughtful contributions. We would like to take a few questions from the audience.
Yeah, hello, the panelists. It has been an interesting discussion in terms of child development. My name is Dr. Sunny from Bio-Natural Medicine from the UK. Very interesting topic, but all of you have maintained the issue of the child development and the real position of nutrition. The question I'm asking you right now is, all over the medical school around the world, the training for doctors has a very, very minimum approach or integration of nutrition into the curriculum. Why do you think that's the case? When it's a fundamental issue.
You were GS Health. You are squarely responsible.
No, if I heard you correctly, you want to say that, why don't we have that kind of robust curriculum?
Correct. Should be robust.
Yeah, so in India, I don't know, we do have a subject called as Preventive and Social Medicine, PSM, that's part of an MBBS course. It's taught for close to 1 year, it's an important subject. But as you rightly mentioned, curriculum, yes, it need be, maybe our NMC, National Medical Council, needs to look at the, because ultimately in India, I say, our public health, though it's now things are improving, public health I've seen is very orthodox. So we need to have, in India, what public health means, there's a patient, there's a doctor. What we need to do that, how best we can now turn that into a public health approach, which is, the preventive side, the promotive side. And obviously, I think we need to have more public health, experts in the country. When we are establishing, new all institutes of medical sciences in the country, I was part of that mission in the first set of 6 new AIMS were established, including Bhubaneswar. So, we ensure that, all these new AIMS should have a school of public health.
Correct.
So it's not that. So the focus is increasing, and right now I can easily say with confidence that I think we have more than 200, schools of public health across the country. So things are improving, but ultimately, the public health means, we need to shift a focus from clinical to the public health.
Correct.
Thank you.
Hello, I'm Jayaraman. I run a nutrition company. So I don't know if I have a question, but partly sharing and partly question. Where do we take our lessons from in terms of women, child, and under nutrition? Looking at the Scandinavian countries who are very good in their quality of life and happiness index, food security has really solved the nutrition equity problem is a question now. Because food has ended up as a problem now. Because very recently I was in the University of Copenhagen and some of the social meetings where they are addressing the problems related to the food creating problems to the school children. And so they are looking at focusing on residue-free food for children, contamination-free food for children. It's not, so the nutrition equity problem is not just for the poor, it is equally there for those obese or people with. So there's a question which, because if at all we have to look at a disruptive policy intervention, probably we need to go to the fundamentals and see before actually planning, creating data models and things like that. That's one thing. Second, looking at the convergence. Where is the critical convergence essential in terms of setting the bottom line is probably first, before technology, science should come. Scientific validations are becoming extremely critical because another example is, so the women's health, their premenstrual syndrome, prolonged nutritional deficiency is leading to irreversible genetic modifications. What used to be nutritional problems results in metabolic problem becoming a metabolic disorder, becoming a metabolic syndrome in the child. So it's a kind of a problem, prolonged nutritional problem. So maybe we need to look at the policy health initiatives should look at the menstrual health of women, which is unaddressed. These are some of the things that I think some of the advanced nations have started looking at the fundamental level, where I think the participation of universities, National Institute of Nutrition, scientifically validated technology intervention probably should be the key in convergence. Then probably public health finance, any innovation of public health finance can sit on top of it. But I think the fundamental is what I wanted to share, opinions of...
Dr. Dhwani?
would you like to?
So I think every question is coming to me. So, but anyway, I think okay. You raised very pertinent point, about and both the it's not that you mentioned about the convergence part. I think Government of India is making all the efforts. When we, they started and Samir was very much part of this mission. When it was conceived way back in 2017 and 18, it was launched, if I'm not wrong. So then, the question started that, okay, you can't have these two vertical, programs running, at by the two different ministries, like, reproductive health and newborn childhood by Ministry of Health and Portion by. Then you said, okay, we need to have a convergence. And that is how, the emphasis started, happening at the village level. Because ultimately, when you talk about convergence, we can have these policies and programs created at the national level, state level, but ultimately the convergence needs to happen at the village level, where action lies there. And there, I think the role of technology, so science needs to come first, followed by technology. So the convergence. Yeah, it's at the last, but it's very critical. So in my view, I think things are happening. Convergence it's a good word, it's a music to everybody's ear, but it's so difficult to happen. It doesn't happen, at least, and I have seen and my colleague Shubha would like to ditto, what I said, is that convergence is the most difficult thing to happen. Maybe the district magistrate at the district level, they are the top people who can make things happen because all the departments are over there. Similarly, at the village level, who is going to make it happen? And now when we have Anganwadi workers and Asha workers, these two, they want to really maintain their, their forte. They are different, they said, okay, nutrition belongs to me, and she said, okay, health belongs to me. So how to make those things work is certainly an important issue. I really don't have any answers to this thing. Yeah, we need to have a robust, scientific, solutions, vetted ones by scientists. NIN can always play an important role, and I've seen NIN also. But somehow I've seen these institutions, what they do, they work in silos again. So I think, again, it's government's priority that we need to bring in these institutions, right in the center stage. They are busy in teaching, imparting trainings and all. But when it comes to, at times I've seen, I see them, when they are making the policies and all. And after that, at the implementation, what about implementation research? It's again missing. So these institutions can play an important role in implementation research, and then obviously we'll have a robust, evidence over there. Sorry. Yeah.
Just to add to what Sir was saying, I think you made some very valid points, but the fact remains that what is relevant for Copenhagen may not be relevant for Kakinada. So, it has to be very contextual and what is required locally. The second is, I think one of the strengths of India has been that ideally, yes, science should come first, technology should come later, but luckily Indians have jumped and gone front, come back. We have completely not followed the sequential model, which has its negatives and disadvantages, tremendous. Sometimes policy is not very well planned, sometimes we don't have clarity of thought, but sometimes it yields a lot of benefits. You don't wait for stage 1 to get over before you jump into stage 5. So your points are very valid, but from this side, as a practitioner, it's nice if everybody is doing their thing and it works. And just to add to my last point, because I thought this was very relevant, when I talked about creating value for nutrition, I also wanted to add that if people start demanding, then political representatives will respond. Currently, nutrition may not be fetching you votes. The day it starts fetching you votes, things will change. So that is why everything hinges on what the community wants.
Thank you so much, ma'am. I think there are a lot of questions in the room, but we can, of course, connect with the panelists offline due to the paucity of time. And I would like to lastly call again Dr. Rakesh for the closing remarks for the session.
So I think we are running short of time, and Firstly, I think thank you all the eminent speakers and my colleague Shubha and Divya and Tiffany and Samir. You did a tremendous job. I think you've heard the panelists, very well. Just a few final points. Again, I'm just trying to summarize. There's nothing new in that. So obviously, I think nutrition becomes malnutrition is an important problem, a major problem in the country, and that needs to be, tackled, urgently. The action needs to start as early as possible. We spoke about convergence. So without convergent action, because there are multiple players, it's multidimensional. So not one single department is responsible. It just can't be nutrition alone or health alone or these two departments alone. What about wash, water, sanitation, hygiene? Then multiple things have to happen. So it has to be, multidimensional. Convergent action needs to start. I mentioned about the at-risk population. I think if you can bring in a sharper focus on these at-risk populations, 1,000 days agenda, I think some way, we are doing a lot of work. But are we really focused when I mentioned that, 5 states are contributing, and in 5 states also 50 districts are contributing more than 70 to 80% of malnutrition. So I think we can always focus, when we conceived in the ministry, we focus that, which are the districts which have got the lowest or less than 50% or full immunization coverage. So similarly, the districts who have got the maximum malnutrition, I think we can start focusing. So Government of India can always come up with a new scheme or program. I think that could be only a mission that is only focused to these districts and areas. Technology, of course, is an enabler, but technology is playing a tremendous role nowadays. We talk about AI, what about predictive technology? It's very important. We talk about monitoring. Look at the portion tracker, which Shobha mentioned and Samir also mentioned. It's a great, but we have another tracker, this RCS portal, which was created way back, in 2012 and 13 when I was there. So I think these two now, they need to speak with each other, because having two vertical portals, everybody is confused. But, look at the poor fellow who's sitting in the village. She's handling so many apps, whether it is Asha or A&M, or let us say an Anganwadi worker. So can we have some super app kinds of super app that, just one app, everything is there? Because, look at the poor lady, she's supposed to do everything. And I always say that, any directives or going from the Ministry of Health, from the Secretary of Health, who is implementing ultimately is the poor Asha or the A&M. And then we have laden her with a lot of technology. So it becomes absolutely difficult for her, So where is the service delivery? Does she just punch, those kind of figures in these portals, or she should, do the delivery of services? So it becomes very, very important that we need to, so technology has become an enabler, but also it is becoming a problem. So how best we can, so again, we have to find some technology solutions. In my view, I think we need to have a family-centric approach.
Yeah, Rajasthan, Madhya Pradesh.
Because, in every family you'll find, if you say 1/3 of all kids are, let us say, undernourished, so in each family or a smaller group of families, a joint family, you'll have these. And again, everything comes from the, your kitchen, your food, whether it is about the pregnant mother or the babies or anybody. So can we start focusing on so they, the role of behavior change communication becomes of paramount importance. I think that is something which we are missing at times, because we are so much into activities and technology and everything, but simple behavior change communication, hand washing is so very important, because hand washing, we talk about sanitation, and we talk about complementary feeding, but let us say if it is unhygienic, it's going to lead to diarrhea, and the baby again will get into a vicious cycle of malnutrition. So I think behavior change communication, we need to have, so whether it could be, in my view, I think interpersonal communication is going to play an important role than the mass media or mid media. So I think let us focus, and now use of technology, in one app to families, what needs to be done. It should not be cluttered, simple state messaging on malnutrition, what needs to be done, do's and don'ts. I think that can always, Michael Lewis finally mentioned about the politics, when we talk about any health sector reforms, there's always a trigger. COVID came in, so there was a trigger. How anything you talk. So similarly, when we talk about how these policies are made, maybe some disaster happening, kinds and all, but when the elections they are closer, then you'll find so many policy reforms being announced and being created and constructed. So I think if it's an opportunity. I think we as let us say public health practitioners, we can start working around this. Anything you find, I think reaching out to our top leaders or the politicians or the policy makers. At times I also feel that I find a sort of sort of not exactly, we are not really linked with them. Anything good, I think, if when I was joint director in the Ministry of Health, anything I go to, I learned from all these development partners and players. I didn't learn this. I learned on the job, and who taught me? It's all people like about you. So getting and feeding these kind of good ideas, whether about nutrition, health, or anything, it's important. And policymakers like Shubha and all people who matter in the system, they are quite receptive to these ideas. It's maybe that we need to have more of advocacy. Friends, I'll end just by saying, India entered in demographic dividend phase in July 2018. So it's already we are, 6 years, 7 years down the line. So if India has to, Japan entered in 1964, similarly China in 94. You talk about, South Korea, we talk about Thailand, these countries, they entered, and at that point of time, the growth has always been in double digit GDP. But that's going to only happen if we have, we start investing in the education, we start investing in the health and nutrition, in their skill sets, because ultimately this is a huge opportunity for the country, which is available till 2055. So we still have 30 years to go. But unless we invest in nutrition, and we won't have, those kind of robust youth and young people, who are potentially productive population of the country. So we need to invest. And we should not lose time. We don't have time. We should start working. Call to action and urgent, early, convergent action seems to be the way forward. So I'll pause here. Thank you so much for your time and patient hearing. Thank you.
Thank you so much, Dr. Rakesh and all the panelists. Now I would like to invite Matthew Joseph, Country Director AIF, for the felicitation of the chair as well as the panelists. Subha Sharma, ma'am. Sameer Khanna. नहीं नहीं जाओ बाप ही को बुलाने वाले हैं डॉक्टर ध्वनि हाँ अच्छा लेने दो डॉक्टर ध्वनि दिव्या
क्वालिटी कॉन्फ्रेंस में भी आप दोनों थे when we had in विज्ञान भवन. Ma'am was MD NHM at that time. अभी आप कहाँ पर से? I've been following you on LinkedIn.
But I worked for this foundation in USA for the Global South.
Yes, yes. जयपुर में है अभी विश्व का काम कि आजकल नहीं है?
चल रहा है.
We have a social enterprise. We are making nutri bars, millet-based nutri bars for the ICDS in Jaipur and Punjab. आएंगे
After this, text me.
Yeah, I don't have your number. May I give mine to you?
I text you. I text you immediately.
Hello, sir. This is Sumita, and I work with community radios. A lot of what we work on proactive health-seeking behavior through scripting and card games for social change. I would like to have your card.
I don't my card, but I'll text you my number. You want to note down?
Yeah, I would love to.
5035. Just text me, I'll do it.
I'll write. Thank you so much. Hello, sir. दोनों कैसे No, there are 4 speakers. And one, so we had given the updated names, but we don't have to name it. Good afternoon, everyone, and welcome. We have to start on time, but I feel like there's a lag from people coming down from lunch. But in the meantime, I would like to invite you to the panel discussion that we have today titled Public Health in a Changing Climate, Strategies for Resilience. Our panelists who are joining us today are extremely grassroots, bottom-up driven, solution providers, and yeah, it'll be very exciting to hear what they have to say to us today. My name is Nirmita Chandrasekhar. I'm at Selco Foundation. My background is in architecture, but I've been a development practitioner for almost 10 years now and was an architect before that. And I'm with Selco Foundation that works largely on solutioning for energy and medical technologies within the healthcare space. We are honored today to have with us 4 distinguished experts working in the intersection of health and climate. And the topic today is very close to all of our realities. I'm assuming a lot of us are practitioners on the ground. And some of these issues have been very relevant to us for many years now. And to be at a discussion like this or a dialogue like this is not necessarily just to identify what the issues are, but to also recognize that there is a lot of solutions out there, and how do we all take back some parts of those solutions to impact our communities on the ground. Few statistics, because this is something we will have to do as part of the context setting. One of the key players around public health is looking at out-of-pocket expenses for communities. To access even the most basic healthcare requirements, communities will have to
travel for days, sometimes lose pay, and there is a lot of other, out-of-pocket expenses that they might face across the referral chain. And statistically in India, states like Karnataka have more than double, which is around 5,000 rupees of out-of-pocket expenses per day. And then you have states in the Northeast where that number goes up to by 7 to 8x, depending on, where they are based out of regionally. Again, globally, 2 billion people by 2100, which is a very far away number, but will be exposed to severe heat. And a lot of us are living in that reality. I mean, when I landed in Delhi yesterday, it was 40 degrees. 99% of the world is breathing unsafe levels of air pollution. Again, in the news the other day was a small city based out of Meghalaya is the most polluted, city in the country in India, and not Delhi, not Bangalore, none of the cities that we live in. And then there are extreme weather events, disasters like storms, landslides, cyclonic activities that are getting increased because of climate activity. And what does that do for disease outbreak on the ground, right? Where a lot of our panelists today will be talking about how disease burden has been increasing, and it's projected to rise by 20% over the next few years because of just rising temperatures. So basically, the climate crisis is a health crisis. And like I was mentioning, what we have today is a group of solution providers. And I'm going to maybe now introduce our panelists and have them come on stage so that we can begin. First, I would like to introduce Dr. Tluangi, who's the Assistant Director at the Directorate of Health Services from the Government of Mizoram. In her capacity, she plays a pivotal role in the administration and implementation of health programs across the state, notably involved in the Mizoram Health System Strengthening Project, where she contributes to enhancing the state's healthcare infrastructure and service delivery. Welcome, ma'am. We also have Dr. Gracie from Tamenglong Government of Manipur. Dr. Gracie has been playing a key role in overseeing health services and improvement of health infrastructure within her district. And she will be representing not just that, but also the work that's happening at the state level in the context of Manipur. We have Dr. Devdas Mohanty, who is the Associate Director at Swasthya Swaraj. He holds a PhD in arts and specializes in tribal economy and change from Sambalpur University in Odisha. He has 30 years of experience as a development practitioner and social science researcher, especially working with PVTG groups. He has worked exhaustively in supporting communities in rehabilitation, especially displaced by industrial projects within the regions of Kalahandi, etc. Dr. Devdas currently serves as an associate director at Swasthya Swaraj. Like I mentioned, Swasthya Swaraj is a not-profit providing healthcare delivery at the last mile in Kalahandi, and we've been associated as Selco Foundation with them since before 2015, 2016, and a lot of the work they've done has provided the basis for our scaling efforts across the country. And then lastly, Dr. Ramnath Balala, who's the Director of Health Systems and Strategic Partnerships at Blockchain for Impact, which is a philanthropy. He is a medical doctor and public health professional with a focus on strengthening health systems and innovative program designs. He's collaborated with multiple not-profits across states in India, driving improvements in primary healthcare access for underserved communities. He holds a master's in public health from the Institute of Tropical Medicine in Antwerp, and is representing Blockchain for Impact today with us. A huge welcome to our panelists, and I think maybe I'll have to shift that side, so I'll just do that. Okay, so yeah, thank you so much for joining us today. We often hear about climate change and healthcare issues in silos,
a lot of my work also is not in the health space. So when I see people talk about livelihood access and in the healthcare space talk about healthcare access without, looking at convergence and intersection, that tends to become like the biggest issue when actually solving on the ground. But yeah, we're looking forward to maybe hearing from what actually works in deployment. I'm going to maybe start with Dr. Tluangi. Given Mizoram, the state, the hilly terrain, the seismic activities, the landslides that the state faces, there are many challenges that can cascade and impact the health systems on the ground exhaustively. We saw that last year also with the landslides in the state. So from your perspective at a state level, and obviously managing so many districts and health professionals on the ground, what are the emerging issues currently, as well as that you're potentially seeing in the immediate future?
Yes. So with regards to the challenges that the health system in Mizoram faces because of the consequences that could be attributed to climate change. So like an example you give, like, the main challenges with this lag that happens when a consequence of climate change does something to a health system and the time it takes to respond to that, So I think that can pose a great problem. Say, for example, Cyclone Ramal, did a lot of destruction to the infrastructure. But it's only recently that any intervention to possibly remediate that damage has only just begun, 1 year later, because of the lag in, getting the resources. So I think it is for any challenge that the state face, say, for example, because of landslides, there could be major landslides, there could be minor landslides that can, hamper access to the facility or could lead to, damage to the water supply, which has happened. And to bring that back to its normal, course, it takes a lot of time, and that is a very big challenge. And in a resource-constrained state like Mizoram, it is very difficult. So there are numerous challenges. I mean, I think people who are gathered here, public health professionals, are well aware of the challenges that climate change can bring about. Damage to infrastructure because of the disasters, challenges in what is already available in the system and what is required on an immediate basis, which we had not possibly planned for or could not plan for also. So I think, so there's a lot of gap there. And I think for me, that is the biggest challenge as a planner and also as an implementer. I hope that answers your question to some extent.
Thank you. For our colleagues who may be not familiar on the ground, you can imagine people not being able to access their most immediate health facility in the case of a disaster, and what does the community do when they are reckoning with that kind of a state? I'm going to ask my next question, in the same thread to Dr. Gracie. Similarly, in Manipur, we've had with the COVID-19 pandemic, the ongoing conflict. There are many challenges in a district like Tamenglong, which is so remote and so cut off from the main center, even within Manipur, that you must not only face issues around accessing infrastructure, but there are also sort of challenges that the health professionals within your teams must be facing. So maybe if you could also help us understand a little bit about what are the issues coming out on the ground.
A very good afternoon to everyone. First of all, I would like to express my yeah. Okay. Yeah, I would like to take the privilege to express my gratitude to the Selco Foundation, because Tamenglong, this is a very hard to reach area, one of the farthest district in Manipur, and it is more than 150 kilometers away from the capital. And as it is mentioned that not only the infrastructure, but even the human resource due to this pandemic and the ongoing ethnic issues. We are facing quite a lot of challenges regarding the human resource. Tamenglong having a very difficult terrain, and most of the districts or most of areas are all hard to reach area where the transportation, public transportation is not available easily. Then during this, the most of the roads are not seasonally okay. So we are facing quite a lot of problems dealing with those other sometimes outbreak of some diseases. But this, even though we are facing these issues, we are trying our best with the limited resources. We are having around about 1.5 lakhs population, and for this we have only one district hospital, and we have 3 PACs, and we have only 15 sub-centers, where some of the sub-centers are without any human resource, and some of the one of the PAC is still remaining vacant for the doctors. So with that limitation, somehow we are facing quite a lot of problems still. We try our best requesting the doctors, whoever is posted there, to go and look after the issues if there is any outbreak. So that way we are facing it, but not only the infrastructure challenges, I just wanted to mention regarding this increased disease burden, like say due to this climate change, we are facing a lot of vector-borne diseases, then like waterborne diseases. Example, this year there was an increase of say scrub typhus, though it is not included in the National Vector-Borne Disease Control Program, but we are having a lot of cases of this scrub typhus, not only the dengue and malaria. Malaria has been, so to say, eliminated, we can say. Since 2021 till today, we haven't got any malaria cases. But dengue, we had, within that last 6 months, we had only 2 cases detected, but they are not, those people are staying outside, though their address is, they have written as the Manglong, but they were not staying in our district. So regarding the scrub typhus, due to these climate changes, we are seeing that many of those type of diseases are coming up. So scrub typhus, as everyone knows, that we are doing only with the rapid diagnostic test, and that we cannot confirm it, so we cannot put it through the IHIP. This is also another issue with us, but still, even though without the diagnosis, if it is tested positive with the rapid diagnostic test, we usually started with the symptomatic treatment. So even though we are having a less infrastructure or human resources, the Selco Foundation has provided so many things with us, especially for the Tamenglong. So say especially the sustainable intensive care unit, having 10 beds, those things we are utilizing for emergency purposes. So like I just wanted to mention one more regarding the limited access. Because of these far-flung areas, the patients and the attendants, they could not come to the district hospital easily. So even for the internet facilities, so many difficulties are there. And there is so many places where the internet accessibility is not there. So regarding, like in those cases, somehow we try to connect through ASAs, then like passing the message through one of the village authority from one village to another village. So that way we are very much we really face a lot of problem. So with the climate changes, this situation, I think those challenges we need to come together and face together and put our head together, and so that at least for those who are staying in the remote area, difficult areas, what can be done, that needs to be talked about.
Thank you, Dr.
Yeah,
Casey.
thank you.
Thank you. Similar question, Dr. Devdas. I remember when we were working in Kalahandi in 2016, when there was no, say, phone service, they were just like, because petrol khatam ho gaya hai. So the region is extremely, there has been a lot of strides in the last few years, but can you maybe talk to us about the current realities that the communities are facing on the ground, and how is Swasthya Swaraj looking at the problem statement on the ground?
Yeah, thank you. Thank you for giving me this chance for this august audience. And just giving a brief idea about the area we are working. It is one of the most remote area in Odisha, which is around 500 kilometers from from the state headquarter Bhubaneswar, and the block is Thuamul Rampur, and most of the panchayats are hard to reach. So there, this Swasthya Swaraj started working from 2014. So it was some abandoned, either it was some abandoned house of government or some NGOs that the organization took over and started small clinics in the villages. And in 10 years time, 2024, we have our own hospital, 9-bedded hospital and 3 sub-centers. So we only focus in this block, which consists of 80 villages, and a team of doctors, mostly from outside Odisha, passionate doctors, young doctors, under the guidance of one of the great philanthropist, Dr. Aquinas. They are serving there, the people. So as far as this disease burden and climate change is concerned, I would like to mention 2 points. One is water, and the other is forest degradation. Water, whatever in this tribal region were there maybe 15 years back, all the perennial streams and water bodies, they have reduced to small ponds or mostly extinct. So scarcity of water is one of the major issue in the area, where this open defecation goes on, and humans and livestock drink from the same source. So these are some of the reasons why we have intermittent cholera, diarrhea outbreak, as well as vector-borne diseases, that is malaria and dengue, and typhoid also. So these are there, and solution, what we find out, government cannot reach every nook and corner of these hard to reach areas. So we have in this block at least, we have a chain of peer educators, what we call them, Shishu Sathis, Swasthya Sathis, Sikhya Sathis, and Adolescent Sathis. So they are around 300 in numbers, and they belong to the community themselves. We have a tribal community, they are a particularly vulnerable tribal community, Kutiakons. So these Sathis, these friends, comes from the community itself, and they are well trained to take care of mostly the preventive aspect, because the treatment infrastructure is so poor. The preventive aspect, and these Sathis, they are of great help in decontamination, in educating people in times of need. So that is one point from water, climate change and disease outbreak. And the other is forest degradation, which is the main contributing factor for malnutrition. Malnutrition is rampant with children, with mothers, with adults. So for that, the main reason is that some time back, there were multi-crops. They were growing in the hill patches, millets, pulses, cereals, roots and tubers, which is also vanishing very fast. And people's income has increased to some extent, and government schemes also are benefiting people. But at the same time, there is a reduction in the dietary habits of people. So now, from multi-crops to, there is a transition to rice-eating habits, which will bring in the lifestyle diseases, which has already shown the symptoms. that lifestyle diseases also would very well come to the tribal areas, which was not there before. So that also we need to be very careful for that. And to address this malnutrition, we have only programs still now by the government and Women Child Department giving food to the people, which is not a sustainable way of dealing with that. So maybe we can think in terms of reviving the traditional multi-crops for the nutritive value it gives to the people. Thank you.
I think a big push that the Odisha government has also is towards bringing back traditional millets and other kinds of local, which is obviously very much needed in this climate. I'm going to sort of also, Dr. Balala, our panelists have given us a good context about the kinds of issues that are there on the ground. You run a fellowship program that was also designed given these impacts on the ground that communities are facing. And the intent largely was to look at hyperlocal public health solutions coming up. Can you maybe take us through a little bit about where the idea came from and what exactly is happening on the ground and what are you learning from the fellowship program itself?
Thank you, Nirmita, and good afternoon, everyone. So, we all know that climate has impacted health disproportionately to especially the vulnerable and rural tribal communities. That is, we don't need evidence for that. But what we realize that all the solutions are designed in a way that what is comfortable for us, but the climate, whether it is works for a particular climate, disturbance or problem, is an afterthought. So it's designed after the solution has already been designed. So we realize that getting that information, like what exactly happens in the ground, is something that is really missing. So there are a lot of solutions, but people spend less time on looking at the problem more deeply. So we designed a fellowship. In fact, it was a conscious decision to call it India Health and Climate Resilient Fellowship, where we realize that our public health system is not yet there, being resilient especially in terms of responding to climate change. So we really don't know what is, especially if you look at health and wellness centers. We are not ready to act on any climate disaster or anything. Even if a person comes with heat stroke, we are not ready. We have primary health care. People don't know how to manage a heat stroke, a person who comes from heat stroke. So then we designed a fellowship where we directly working with the district administration, especially the district collectors and the DHOs and health department, not running a parallel system where we say that, oh, we have a solution, we want to implement this, but actually working with them to understand what exactly they need and supporting them through a group of experts and little bit of philanthropy money where they can use quick prototyping, quick solutioning. So we realized that a lot of time, the people who are very marginalized, their voices are not even heard. Really, what exactly they need, we don't know. So the idea is to have a fellow, one as a public health person who brings a public health, ideas or concepts like insights from the ground, and another social work or anthropologist. So it was a conscious decision to bring in two different diverse understanding from the ground and actually design solutions or for the ground. So we realized that health is a very complex, very complex issue, and added to this, climate change has exacerbated even more, because we are not even ready there yet. So it impacts nutrition, it impacts especially food security, vector-borne diseases, then
mental health,
especially especially heat. The people who are working in heat-intensive areas, like laborers, quarry workers, they have a huge disproportionately affected. So they are not our audience. So what we want to do, we also want to look them as one of the people that we actively design solutions for them. So this is something that we are bringing onto the table and trying our best. Yeah.
Thank you so much for sharing about that. I think something you spoke about on how do you respond to heat stroke, and I think Dr. Gracie, in Tamenglong, you were talking about what it takes to maybe make national and state policies into action, as well as what are the other kinds of solutions that are deriving from the work that your ASHA workers, the ANMs are doing from the ground. So maybe if you could talk to us a little bit about how do you address preparedness and screening and diagnosis, etc.
Yeah, regarding that management part, like since the climate change is there, actually Tamenglong, the rainfall is quite high, and usually the temperature used to go up to only 27 degree earlier, but last year it was increased, and the neighboring district of None, they had a maximum, it reached up to 42 degrees centigrade. So it was quite high for us. Usually for us, Tamenglong, the climate change, the weather was very pleasant earlier. But now the changing of this weather, we need two things. One is infrastructure, because infrastructure, the state government has plan to construct new infrastructure for the sub-center under PM ABIM, or some most of our health structures are constructed under PMJVK. But under PM ABIM, the roof is concrete, and so far we have completed only 2 for the Tamenglong district, and some other districts also is still going on. This is an ongoing program. So the infrastructure, that also will give us more it can prevent us from the extreme heat. So any that particular type of construction is needed. But so far, with the limited resources and with the compromised infrastructure, we are trying to capacitate, or we are trying to train all the maximum number of the people out there in Tamenglong. So one thing for the district level, we have one district hospital. So from district hospital, we have advised, I have already issued an order also, since I'm the chief medical officer, and hardly people wants to come to Tamenglong for their posting. So with the limited and handful staff, we always try to equip ourselves to manage for any uneventful events. So I advise our MS to organize or to prepare for the heat corner, and there we have arranged designated 2 beds, especially for the heat-related illness. If there is any issues, then there in that particular room, we provide, towel, then water, then some ice pack. If it is possible, we try to keep ready a designated room for any issues if arises. Then even the ambulance, we prepared the particular ambulance for if any issue arises, to go and bring that kind of reports if there is. So that way we try to equip our PACs, and then the district hospital sub-center level, since there is very limited resources, we always advise the ASAs to tie up with the village authority. So regarding that, we have sometimes we give awareness program to not only to the health staff, ANM, Anganwadi workers, ASAs, and even the police personnel and the traffic police. We have already trained since last year, and this time also we have done again, because the heat is, the climate is change, we can feel it. So just few days back also we had a training program awareness on this for the police, for the Anganwadi worker, and for the traffic police. So they should know the the sign and symptoms of heat-related effect. So those things, how to respond, emergency response, how to tackle, and when to refer the particular patients to district hospital. That way, we have given them the awareness, and then moreover the ASAs at the village level, since we don't have a human resource health staff, so we used to tell the ASAs to, whenever they have a village and health sanitation nutrition day every month they organize. So during that time also the ASAs used to talk regarding that heat related ill effect. And so the village are, most of the village like PRI, they were, so to say, they were aware of the heat changing. So that way we are trying to tell them to give the knowledge, to impart the knowledge even to the villagers and even to the school teachers during this National Deworming Day program or International Diarrhea Control Fortnight, then even during that World Environment Day. Sometimes we used to go to the schools and then during the assembly some children used to faint. So those are the like the teachers should know that like when like how long they have to expose in the sun during assembly. So those knowledges we imparted. So that way we are trying to help them. Then we also reporting system in our district as advised by the state. We are giving the daily reporting IHIP portal through IDSP. Not only the heat related but for the vector-borne disease also we are giving the reports. And if there is any issues from the village level through either ANMs, then we try to contact the state people how to cope with that issues. And then not only that, for the climate resilient water and the sanitation systems, we always used to tell the staff in the PIC and the district hospital to have the knowledge of safe water, then to have a knowledge of this rainwater harvesting. Since the Tamenglong district, we have a scarcity of water sometimes during dry season. So in that way, how to save the water through rainwater harvesting, we have in the district hospital, the facilities are there. Then in the PICs we have that facility, but in some sub-centers still yet to equip with that type of facility for the rainwater harvesting. Then the water conservation system, like say notifying the public whenever they come to the hospital or any health centers, they should know how to save water, not unnecessarily using the water. We paste the the written words on the wall, like say to off the tap after use or to save water. Those messages we are try to impart to the public also whenever they visited the health center. Then especially for the say regarding the solarization in the district, the Selco Foundation has given us the solar impanel there in the district hospital, and also to all the health sub-centers. We have 15 health sub-centers, but 2 are yet to be installed because the building was not completed. And with that solarization, the best part is the power supply, we can rely on it. So since we are having a district hospital with the tele-ICU facility, then dialysis project, then the OT, and then the blood bank, sometimes the power cutoff used to give a very much problem and headache to the staff. So with the coming up of this solarization, this problem is being solved, not only helping in the climate change, but also helping us in managing the emergency cases. So we don't have to rely on the power grid or the electricity. Even if there is no electricity power, we are very much happy that at least solar is there to back up for the backup. So so these are the issues we are facing. I mean, these are the things that Selco Foundation has provided us. Not only that solarization giving the power to the health staff or the department, but also they have helped us to construct one sustainable intensive care unit for the district hospital with the 10 beds, and there we are planning to set up that one for the critical case, like say heat related ill effect, if there is any cases, or if that particular ICU we will be designated. I have already instructed the MS to designate that particular room. So with that, somehow with the limited staff, then with the limited infrastructure, we ourselves, we don't always depend on the government, because sometimes it takes time to reach out the state government, waiting for the process to complete the the procedure. So we tried our best from our local resources, especially we are getting some amount from the health card, then from the user's fee. So that way we try to manage the emergency cases or the emergency equipments, or sometimes even the medicines, and sometimes we outsource the staff. That way we manage the limited resources and the other things in our districts. Thank you.
Thank you, Dr. Gracie. That was extremely comprehensive on how we need to not just look at preparedness and awareness, but also talk about long-term resilience within a district. And I think a true example of decentralization and what it can do for ensuring that the public has access to.
Yeah, one more thing with the solarization, the vaccines, because of the power cutoff, sometimes we cannot maintain the temperature. So with the solarization, even the vaccines for the immunization, then sometimes this anti-snake venom, then anti-rabies, these things can be like kept properly in the health center with the maintenance of the proper temperature. So this is also another achievement with that.
Thank you, Dr. Gracie. I think one of the things that Dr. Gracie was articulating was the need for really robust grassroots movements, not just from the ASHAs and ANMs, but also looking at the community itself owning the climate change-related issues and the kinds of proactive behaviors and practices that the communities themselves can take forward. Dr. Mohanty, if you could maybe next talk to us about a little more about how does Swasthya Swaraj empower women and girls locally from within the communities, and if there are any other new approaches and processes or models that you have been taking up within the district, that also would really help us understand what it takes to build community adoption.
Yes. So after this, when we started in 2014, after some time it was realized that one of the most pressing challenge is to get professionals, to get doctors and to get middle level health workers to work in these hard to reach remote areas, and very difficult to bring these professionals to the ground. So Dr. Aquinas, the founder, realized that how to develop human resources from among the community. So this tribal community, they are Kui speaking Kutiakans, and the literacy level is very low, and the girls' education is at its lowest. So how to get people from there to get them trained in these middle level health workers. So that way they started community mobilization, and since 2018 one course was started on the ground, I mean close to their houses, that is diploma in community health practice. So it was started and it was affiliated to one of the prominent private university in Odisha, Centurion University. And in 5 years, I think 43 girls were admitted, and the challenge was that around 25% of the girls dropped out because they are tribals, and the classroom, the clinical conditions, going to Bhubaneswar for exams, all these turned out to be intimidating for them. So 25%, in spite of a lot of counseling, we failed to bring them back to this course, and at least 65% succeeded, and they now serve in the sub-centers and hospitals we have in this remote block, and they are trained in disease surveillance, they are trained in child and maternity health, they are trained in primary health care. So that is that's a very good innovative example the organization created for others to follow. These girls are +2 students, those who have got some chance to get into government residential schools from the beginning. They pass the +2 and they are there. And last year we tried to bring 2 very bright students from them to Bhubaneswar for vision technician course, because in the hospital in this Thuamul Rampur block we don't have a vision unit, so that was the purpose of bringing them. But last year we failed because these 2 girls, in spite of lot of counseling, they returned back. They didn't want to stay there. So this is again third attempt we will take this year to have a vision technician for the region. So thank you.
There's also a model where Swasthya Swaraj has been deploying, severe acute malnutrition units, different kinds of mobile care where, kids are taken to the communities to ensure that there's not just institutional deliveries happening, but even post that there is a lot of care provided to mothers and children. So maybe you can also help us understand a little bit more about those models.
Yeah, so we have also we have one hospital in the heart of this Kotiakand region with 9 beds and 3 centers, and each of these centers have one delivery point. And apart from that also, it is not sufficient to cover all the remote places and small hamlets that are lying quite distance away from the centers. So for that, we have outreach camps. Doctors used to go there twice a month, and we keep track on the antenatal and postnatal care and children's health. And since 2 years, we have this Rural Crèche Initiative, RCI program, that is happening in 60 villages, where children from 7 months to 3 years are taken care of with good food and also some kind of pre-primary fun-filled learning. So that is going on. Thank you.
Thank you. I think both Dr. Gracie and Mohanty were talking about the need for some kind of flexible funding to be able to invest into these kinds of, in some way risky innovations, because if you're able to prove it out at a block level, at a district level, then it's something that can be scaled at a state level. So I think I wanted to ask Dr. Ram that BFI was started as an action-oriented philanthropy to be able to look at flexible funding for innovation in the health space. You also support a lot of grassroots organizations and scientific institutions. So maybe you can talk to us a little bit about what kinds of solutions have been developed from the different players that have been working closely with you.
We didn't start as an action philanthropy. We started as a relief. So then we realized it's just a band-aid, and we need to move from just sticking band-aids to actually building some sort of system, work, so that we leave something behind. Otherwise, it's just giving food packets, oxygen concentrators. It started as a COVID relief. So from there, we have 2 verticals. One really looks at biomedical research and innovation, which supports, startups, very innovative young startups across institutes to come up with novel solutions or ideas, and also improve or increase that research mindset and translation research at the institutes, medical colleges, and other incubators. The another one is the district full stack program, where we work in a health system strengthening. One is really looking at from molecular biology, disease preparedness, to actually systems, like how do we bring these solutions to the ground, and how the ground informs the institutes that what solutions is required. So one good example is what as a philanthropy, what we did was trying to bring people who need who have a problem with the people who have a solution. So if you realize that with Celco, the work that we have done, we actually, it was a small seed money. When you look at the large scheme of the amount of money the government spend, it is very small, but the small amount actually help the Celco Foundation leverage that money to now go into almost 25,000 health and wellness centers with energy access, energy efficient equipments, and actually helping. I think Meghalaya has almost 1,800 facilities which has been solar powered, and also look not just energy access, but also how do we make it efficient, how do we design efficient systems, and also how do you push for efficient equipments. I think that is also something that really is important, and also along with that built environment, how that plays a role. So another initiative which, I especially BFI really likes to take some risks. One is supporting the hospital ship on the river of Brahmaputra. It's a huge 10-bed floating FRU, which is still yet to be functional, but it's completed. It's along with the government of Assam and Northeastern Council and Center for Northeastern Studies. So the idea is that especially in those very low riverine islands where it's very prone to flooding, and all the systems, the public health facilities really get flooded and there is no access. So how do you build a system where it's accessible throughout the year? And the seniors had a very good innovative solution. They realized that boat clinics are okay for primary care, but what about secondary care? So then we supported building this hospital ship. That's also an idea that how do you make it more energy efficient? Because there is a lot of things which is innovation required on biomedical waste, on boat. And there is also a need to understand how do you certify hospital ships, because currently there is no guidelines. How do you operate on a floating ship? So these are the things that really BFI started understanding. What we can do, what we actually did was start taking risks in terms of taking ideas or identifying the problems which actually conventionally gets filtered out because it's not fancy or it's very difficult. So we realized that that's something that we need to do. And also the idea is that focusing on vulnerable groups. So as a conscious effort, to not just as an afterthought, but as a conscious effort to really identify those pockets, to identify what they actually need, what different problems that they have. So bringing those insights is something that we're really looking at. And obviously the convening power to bring people together. I think that is also a big strength that philanthropy can bring into climate action and help build solutions. Yeah.
Also, maybe for people who are interested in the audience, what made BFI pivot from being a relief-based organization to something that's looking at core innovations? Just because traditional philanthropy doesn't take risks.
Yes. No, it's also a small group of people who realize that funding usually starts. They look at solutions, not the problems. So then we started thinking that I was also on the other side of I was asking money. So then I got an opportunity to be a part of a group of people who think, if you have an opportunity, how do we think differently? How do you make it possible? So then we realized that how a trust-based funding can help, and how a problem-based funding can help, and also how a flexible funding can help. So we saw a lot of positive things. Maybe we might not showcase huge numbers, but at least we can bring in some sort of one is the change in the mindset, how funding can be done. That's one thing. And how we can support innovative solutions, because we want to spend more time on the problem than the solution. So the idea is a lot of people come, most of the problem is we write proposals based on the solutions that we have. And then it's a vicious cycle, and the funder wants to fund that already existing solution, and then it's always managing the funder than the problem itself or the solution. So then we thought, how do we change that? So then we started working, spending more time with the problem, and then building solution along with the system, and generating evidence so that the policymakers can. It's a long term, and the fellowship is actually one of the longest. I think it's a 3-year fellowship that we are running. We realized that 1-year fellowship, 6 months fellowship doesn't work, because by the time they understand the problem, they're already out. So how do they build in accountability? How do you have a skin in the game, that if you are also doing it, you should also be accountable to what you're doing. So this is something that really wanted to bring in.
Yeah, sorry, I'm standing up a little bit because that ankle is a little off. I think Dr. Tlangi, managing health at a state level
and sort of balancing that act with what's happening at national and then at what's happening on the ground tends to be quite challenging. But I think if you could help us understand a little bit what is happening within the state from a solution perspective. Mizoram is one of the first states in India to be where the primary health centers are completely solar powered and off the grid. And the state has taken great strides and leadership in achieving that. So if you could maybe help us understand a little bit more.
Yeah, so we are very proud to state that 90% of our health facilities at this point, primary health facilities, are solar powered, and it has sustained not only the health facility but also entire villages during times of disaster when entire village is cut off and the sub-center is the only place where they can go and charge their mobile phones to connect to other people. So it was a proud moment for us. And how we brought about that particular aspect of climate change mitigation into the state is basically by having this strong private-public partnership with CELCO, with which we had a memorandum of understanding signed, and the good thing about it is the flexibility that CELCO Foundation brought in, because I work with a lot of agencies, international, national, and most of the time that flexibility is often not built in because of obvious reasons. But with CELCO, there was a lot of, I think the real commitment was to make it happen, to have these primary health centers solar powered, self-reliant, and we made it happen in a span of a year, and I think that's unprecedented. And also, I think sometimes what happens, especially in relation to climate changes, there are a lot of suggestions, there are a lot of solutions, but there are a lot of solutions in theory, but with regards to how to actually make it happen, it's often left to the states to figure out for themselves and to bring in the resources themselves. And it can often be a very difficult thing to do because, because of varying levels of understanding of what the solutions are. So for us, what we have done is, with our projects and with our programs, we've tried to bring into it these climate-friendly initiatives, and we try to bring in standards, different standards. So and it can only happen that way, rather than having one big project in which you try to, make the health system all at one go completely, climate resilient. It does not happen, but all the different interventions that come in, you bring in that elements of climate resilience, and then slowly it happens. Say, for example, now we are looking into bringing climate resilience into the built environment. So moving from this year on, we're trying to bring that into the designs of new constructions, so that solarization in the future is much easier. And also, although rainwater harvesting has always been part of the structure because of, because Mizoram is a very rainy place and people are already quite aware of it. But apart from that, what we also need is awareness regarding earthquake, resilience into the buildings is very critical. So I think it is important to support the states for funding agencies, but also I think what is very, very critical is with any public health intervention, especially with relation to climate changes, for the policymakers and the politicians to be well aware of the requirement, why we need to look into sustainability, understand climate change and how it impacts everyone on the ground. Because without that, any mid-level or lower-level practitioner finds it very difficult to get much done. That very high-level commitment has to be there. Especially, as you know, CELCO Foundation had a very strong backing from our chief minister, from our health minister, and because of that, we could move forward very quickly. So I think at all levels, policy levels, leadership, bringing those resources, all of those can be very important. Yeah. Thank you.
And I think speaking about resources also, you'll have to be a lot more inventive about how you're able to invest in climate change and resilience. What has the state been able to unlock, and what are still the challenges that you're facing that, or maybe ideas that you think would be critical for this investment in the state?
Yeah, so say for example, in our constructions, a lot of times, bringing in the design to avoid landslides in the future, or to construct these retaining walls in a hilly area like Mizoram, it is usually it can become difficult to make it part of a project. But we have always tried to bring into that. When you're constructing new constructions, and so bringing resources can be extremely tricky but I think on the whole there's a much greater awareness with regards to the requirement from these funders. So we have had some success in that regard, but I think when it comes to who actually agrees to fund a project, and if there's an available scheme, it's usually again the policymakers who control, the amounts and sometimes the design. So that is where, the lobbying can become very important again, and the awareness of the leaders.
Thank you so much. I did have a follow-up question along the lines of adoption itself, because we have observed that there are a lot of efforts happening at community level, at state and district, and maybe at a cross-national level also. But even in a program like Energy for Health, where we're powering, say, all of the facilities within a state, adoption tends to be still an issue, where people are still not accessing maybe healthcare, and whether that's trust in the system or that's something else. What are the ways that you think we could address those issues, and this could be open to the entire panel also?
So access to health services basically is very much an issue, demand and supply side. From supply side, if we are still struggling to provide basic medicines when patients come to a health system, to a health facility, there's no incentive for them to come to a health facility when they have to keep buying medicines. So like you said earlier, out-of-pocket payment for medicines, it has almost 76% of all health expenditure. So I think we need to ensure availability of these basic medicines, diagnostics and equipment in health facilities. And what CELCO has brought into understanding of this, especially Mizoram state level officials, is the availability of this technology that is sustainable, that can be solar powered, and we have introduced some of those technologies into the state as well. And for us, I think it is a no-brainer. If there is something that they can access when they come to the facilities, people do come to the facilities. And with health and wellness centers now operational, we have, in Mizoram at least, we have BSc nursing graduates. So people are very happy. Footfalls have also increased. When they have 24-hour power supply, they can provide 24-hour services. So I think that is very important. And so what we have also invested very heavily in Mizoram is, over the past 4 years, is to make our facilities quality certified with NQAS. And at this point in time, I think we have the highest percentage of district hospitals in the country that are quality certified. Now, PHCs are really picking up because we've invested over the 4 years on quality measures. And so we have observed that footfalls are also increasing accordingly. But like in Manipur and other states of India, we have a lot of issues with regards to HR. We have a lot of HR shortages. But somehow we're managing, and medical officers are available in all the PHCs, but support staff are still in short supply. But we're moving towards it, and I think with a lot of support from the national government and from other partners, international development partners, I hope in the coming years, the access will continue to improve. Yeah.
Thank you. I think a few takeaways for us for sure is that a lot of the contexts in India are low resource setting, and innovations for the gaps of HR, for the gaps of screening and diagnosis are the need of the hour. And I think if there are innovators within the audience, it's something that we need to be able to identify local problem statements and then sort of propagate towards the solutioning, but for sure. I'm just keeping an eye on the time, and maybe after a question I will be moving to the audience, so that's maybe a warning for you all to be ready. And this is just a question I think that maybe anyone could answer. We have been, like I said in the beginning, talking about working in silos. And have there been any examples or challenges in intersectionality between like working in convergence with other departments, especially in the need of the hour? Like we were just in another discussion where someone was talking about how the Panchayati Raj or the village council plays a very big role when it comes to sort of local level problem solving and governance. And are there examples of these that you have observed that could also help us understand a little bit about what it takes to implement?
It's quite an interesting observation we had during a COVID pandemic. So I was working with the health department in Assam under a Niti Aayog project. So we never seen the kind of collaboration what we had during COVID pandemic. The police department, the transport department, everyone is sharing data, railways, everyone. And we were shocked, like, how is that even possible? Even if I wanted simple RCH data, reproductive child health data, we had to write so many letters, wait for so many days to get a simple two-pager information. But how did it happen? It shows that it can happen. Definitely it can happen. But I think it's the intent to make it happen. So currently we don't have that need that we need to, or a pressing need that we need to share data. But I think we increasingly realize that health is not just a biomedical thing. It is also a lot of social determinants, lot of intersection between various departments, including now we have cyber security, which also has a huge impact on health and other things. In fact, the World Health Summit also has some panels on space, like how does space, interact with health, especially looking at GIS, looking at vulnerability mapping and everything. So, and there's also information that how do we share and how do we use that for our current. So we have seen that it can be done, but there is no intent to be done. So I think that is something that as departments at philanthropy, academicians, that we need to create that need and the purpose to share data. So this is just an anecdote I just wanted to share because it was so visible, and we were shocked, like how is it possible? So it's a great learning actually.
So what was your question? Can you?
Yeah, convergence, sir. So you've been working in Kalahandi for 10 years now as fast as Swaraj, and from what I remember, the collaboration within the district itself, within the block itself, was very challenging. So have you seen any examples where convergence has actually helped in moving the needle in healthcare delivery?
Yeah. I think the government, though is so to say, is a huge organization in comparison to NGOs and other smaller institutions, but it has also the difficulty of reaching to the needy, poor and the underserved. So they have also to depend on people like us who are also working at a micro level in a block or in a small area. So we are in communication with always with the government for this national malaria eradication program, tuberculosis program. So we are always closely coordinated with CDMO of the district and do these kind of things. Thank you.
So it's, okay, I'll make it very short. So I think that is where, I mean, I don't know where most of the audience, they work, but I am from the government sector, and in the state of Mizoram, the government is a major player. The services sector is a major driver for the economy, and the saddest part, I think, is because this lack of coordination between different departments, if only they work together, could really bring about sea change. We cannot work together most of the time. So there are many schemes. Say, for example, under Tribal Affairs Ministry, through Article 275(1), you can construct sub-centers. Now, as I was on my way to Delhi on the airport, I received a phone call from a chief medical officer saying that there's a sub-center quarter being constructed somewhere in a village, but the chief medical officer did not know about it. I did not know about it, And if we had been informed beforehand, maybe we could have also kind of intervened in the design somehow. So we work with limitations, and we accept that it is going to be difficult to coordinate. But there are coordination committees. We do express this, and Tribal Affairs, Health Department. At the moment, we share the same health minister, but somehow there was a huge gap in communication. So it is very difficult. Biomedical waste management, Health Department is a major stakeholder. And so recently, the Common Biomedical Waste Treatment Facility, for the first time in Mizoram, was inaugurated, has been made functional. And we did not receive the communication at administrative departments, but the health facilities receives the letter stating they have to start using. But the fee has to come from the state. Health facility will not pay the fees, right? So there I raised again the question, where are the guidelines? Where are the guidance? Now then the ISO Smart City Limited called me to say, oh, you need to call a meeting of the advisory committee to, So it is very difficult, considering how important biomedical waste management is in the state. So those are just examples, but I think everyone here knows that we all work with the limitations. We don't necessarily take barriers as physical. We think it's theoretical and still move forward. But at any level, I think all of us need to understand that trying to build in coordination is extremely critical. And if you're able to work together, even with one department or two departments, it really makes a big change. Like, say, for example, when Selgo Foundation project was initiated, we had to take permission from the Power and Electricity Department, the Renewable Energy Division that in Mizoram is the ZEDA. And it was only because they were so supportive of the project that we were able to move very quickly. They gave us the NOC, the No Objection Certificate, in record time. That's why we were able to move forward quickly. Had they made problems for us, we could not have started on time.
Correct.
So it is actually the key, because, like he said, it's social determinants of health that moves the needle, not the clinical practices, right?
Yeah. This conversion part, I think for our district, Tamenglong, we don't have much difficulty because our district administrator, this deputy commissioner, whoever comes, they are very much helpful. And whenever we require something, we always approach him. Because to reach out to the state, sometimes we need to go some procedure. So instead, I go directly, for us, we go directly to the deputy commissioner. Then we highlighted the issues. Then the deputy commissioner will give orders to all the departments. So the line departments, so we come together and we try to solve the problems. And just many examples are there for Tamenglong, like say a patient from a remote area where we cannot transport by the vehicle, but they have to bring the patient through the bamboo stretch. So they have to walk, they have to cross the bridge. That is also not a RCC bridge, but it was made by the bamboo. Then a patient it was a lady, like small child, around 14 years. She became unconscious. So we don't know what was the cause. So somebody put up in the WhatsApp group. Then we all have to put our head together and what may be the cause and how to bring the child outside for the treatment. I advise them to bring up to the PHC level so that we can send our vehicle and we can take the patient to our district hospital and do some investigation. But that also not possible, so our subdivisional officer of that particular area, he like everyone was in action. So how to like bring the patient to the hospital? So somehow we managed and we told the villagers that we'll give some money. Then we requested them to bring the patient up to the up to the jeepable road. Then they brought, and that way the patient was taken to the Silchar Medical College, and there unfortunately the patient died. But that way, like whenever something happens, we always used to put our head together, depending on the head. If they are very sincere, we don't have much difficulty to work and in the conversion way. But sometimes the deputy commissioner or the district head, if they are not willing to help, then there is some issues. Otherwise, and moreover, it is within our heart that we wanted to save
Correct.
the people who are really in need. So that also should come from our insight.
Correct.
That the willingness should be there. Otherwise, this conversion part sometimes is very difficult. But if the willingness is there, there is always a way.
Yeah.
Like somehow, anyhow, we have to deal with it. So that way, since our district is a very small district and a remote area, though it is a remote, but we are like if something is there, we are all in together. Even during COVID pandemic, the TrueNet machine, we procured it from our public fund. So it was under the guidance of our Sir Armstrong Pame. I think everyone knows him. Most of the people will know him as a miracle man. He was the one who has started with the this People's Road from Tausem, which is a very remote area, up to the Haflong. And that was done from his pocket. And he was the one who has initiated to procure that TrueNet machine. Before the state government has given us, we procured from our district side. So that way, there is always a way how to mobilize the department, the public. So that way we can do many
Thank you.
things, I think. It depends on the willingness.
Thank you, Dr. Gracie. I think we have time for one question, if there's any from the audience at this point. Your hands were up first. Right there.
Hi, if you can permit maybe two questions. So Devdas, a big fan of your work. One of the questions that I had is that, so as a civil society organization working in such a remote location, how over the past 10 years, advocating your model to governments and other districts, how has that been for you? I just wanted to know that. And Dr. Ram, my question to you is that, so essentially what the fellowship and BFI is basically doing is kind of having a community-driven biosurveillance, which is like bidirectional. I just wanted to know how sustainable it is, if it is sustainable, and if it is, what do you think is the driving factor in the community?
So I think 10 years is not a small time. So maybe after 1-2 years, everybody comes to know that the good work that is put in, and they also witness what is going on the ground. So I don't think, even now we don't advocate much. Even now we don't advocate much, because seeing is believing. Whoever sees the work, they come out. They come out to support. So they look for people who work. So they come out from their side. Thank you.
And yeah, to answer your complex question. So, see, the one thing is that we are working with the district. We believe the district as a unit of change, because there are nearly 700 districts in India, and every district is unique in its own problems and the resources they have. So the idea is to leave some process of understanding the problem and solutioning, and how do they mobilize resources locally. So that one is to create ownership of the problem and the solution itself. It's not coming from an outside perspective saying that, yo, you have this problem, then I have a solution. So how do we build that, design thinking process there, identifying the problem and actually solutioning locally. And we add more experts if there's resources required. But And then idea is to find people who are local. So even our fellows, our first priority is for the local, and the idea is they get absorbed in the local, either the government or the civil society. And we are also working, we are conscious decision is to work with the local civil society organization. It also makes it important that the role of civil society is also established, because government can't do everything. It's a known fact, and civil societies also can take risks, some sort of risk, and help de-risk the government initiatives. At a very small scale, build evidence, but I think it's more sustainable, it's more local, it's more accepted. And the most of the solutions, if you see, there's all local, which is sustainable. If you give any technology, it's good, but if it's not sustained locally, accepted locally, it is not going to. So that is the idea.
I think we have time for one more question before we wrap up.
Yeah, it's not a question anybody can answer. But how do you look at separating the word medical from health as a grassroots system? Many occasions you get into the problem of getting professional resources locally, as you mentioned. But many occasions from the urban approach, if you look at, a lot of solutions are available locally. So probably the institutional convergence then actually, the social governance work better than a public governance mechanism. So is it not that we're getting stuck into a public governance kind of a mechanism instead of creating a strong social governance structure which can actually create a better resourceful and a better model locally, which can even kind of, the lessons can be transferred from rural to urban, urban to rural. Somewhere it looks like, you always look at the rural society with an urban lens, kind of. So any experiences from this angle that there is social governance, strong social governance model? I don't know if you fully understand.
Yeah. So I think Kerala has done something along with that line. In fact, a very strong local panchayat raj system and social governance system there. So holding local leaders accountable, in whatever they did. So similarly in health, it's a very siloed, very health. Even at the district administration level, what we noticed that district collectors are also, they are interested, but they don't have that. Usually, most of them, if they are not medical or they don't get into very details of the issues at the biomedical, because they feel it's also very technical. So what type of data or what type of information is also given to them makes a lot of sense, and to build some sort of governance and accountability. And locally with the panchayat, panchayat is already, there are a lot of gram sabhas and there are a lot of accountability measures, but they are not much involved in public health per se, because that's something that we noticed, that it's very much confined to biomedical, very just community engagement. It's as a process of tokenism, not really engaging the communities for their understanding and actually giving them power to decide. That has not happened, at least I don't know. Small pockets might have happened, but largely it's not scaled or it's not been practiced. But in Kalahandi, especially with the communities and Ekjut, they have done very fantastic work in bringing community voices and accountability measures through very grassroots movements. But yeah, madam, I think if you have any examples.
In Mizoram, actually, we have an example. So you know that there are sub-centers in some villages, because you cannot have sub-centers in all the villages. So it so evolved in the early 2000s. So you have a sub-center and they would have around 2 or 3 villages covered by the sub-center where they would go occasionally to provide vaccines. Now say there's a sub-center A and he has village A, B, C under them. And in village B, the village council decides that they want to provide a space, a building, and furnitures where the health workers would go and deliver services, and maybe stay 1-2 nights and then go back to their parent subcenters. And it started evolving like that, and we called them clinics, subcenter clinics. But now, without any kind of legislative decision around it, it has evolved so much so that now we are posting health workers in the clinics. But I think it would differ from state to state how the local political economy of health is designed. In Mizoram, what has happened is now wherever there's a clinic, the village council will approach us to upgrade that clinic to a full-fledged subcenter, so that it can be a health and wellness center. Now it's not possible, right? Like many, already the average population covered by subcenter in Mizoram is much lower than 3,000. That is recommended by the IPHS. And it is not even cost effective for us to have a subcenter view because we're a resource limited state. So it was initially, pushed by the village councils, definitely by the villagers themselves. They provided the building, they provided the furnitures, everything that the health worker would require to deliver the services to that village. But now they come to us requesting us to build the clinic building, So it evolves like that. So we have not had a lot of success with that kind of model. And also sometimes what they also do is with their village council funds that they get from the finance commission, and sometimes the local MLA would also hire health workers for the facilities if somehow the government is unable to post. And they would have for 1-2 months on an ad hoc basis, but we find that is also not that helpful. Maybe to some extent, but considering that it's an organized service providing health facilities, so we need to have maybe better models that we could draw from, but in Mizoram we have not had a lot of success. Yeah, thank you.
We are maybe reaching the end of our session, and I really wanted to take time out to thank all of you for really traveling from very far off areas. It doesn't take one single flight to reach Delhi from wherever you are, I mean, other than Dr. Ramnath. But thank you so much for being here and sharing with us all of the learnings that you've been having over the years. Maybe a last plug is that Silka Foundation, we have a stall up in the exhibition space. So you can learn more about our initiatives and our programs up there. And I have two of my colleagues, Sijil, you can wave, who's going to be up there, who can maybe help you understand a little bit about how we're working with multiple states. We are currently in 12 across India. And our aim is to look at 25,000 health centers being powered by 2026. We've already achieved 8,000, which only happens through collective action. So thanks to everyone seated over here. And with that, yeah, thank you for joining us.
पता नहीं इनका न्यूज़ है रहा इसलिए कोई पूछे कि पेन ड्राइव लेके गए
Excuse me.
पेन ड्राइव है उनके पास
So the person has to just give a key and we'll play it. Yeah, we just
दिस वे मैम
हाँ ये आप इसको कहीं सिस्टम पे कॉपी कर सकते हैं तो जो आपका जो लाइव स्ट्रीम है उसमें भी जाएगा ये
हाँ जी जो लाइव स्ट्रीम होगी ना तो उससे भी पीपीटी जाएगी वहाँ पे ये आपका 3rd नंबर है वैसे तो मैं फुल करके रख देता हूँ ठीक है जब आपको करना होगा मैं शो कर दूँगा
चेक चेक
म्यूट है अभी ठीक ठीक
Check, check. Hello. Check, check. क्या लास्ट वाले का नहीं चाहिए पानी पी लिया छः ही चाहिए नहीं 6 मेंबर चाहिए थे हेलो हेलो हाँ कौन मैं मेरे रूम में हूँ हेलो मैं वहाँ 10 में नहीं काम है मेरा काम है मेरा स्पीकर्स काटा जाए सब ऑन है चेक चेक
Sorry? One of the partners is hosting, but all these speakers are not. It's not a very big thing.
Dave is here to help.
आप किधर बैठने वाले हैं One of your bilaterals sit here.
We can come and switch it. If you're speaking from here, then you can switch it.
I'm very new to this place.
Bypassing this is the speaker, your signature and sure. On non-speakers को all good.
Welcome everyone. To maximize the time we have for discussion, I'll request my panelists to take their assigned seats. I'll introduce them, of course, but we don't have to have them all come one by one. I'm very, very happy that you're all here for our session. And we'll talk about accreditation for advancing quality, standardization, and excellence. And I think this topic is very obvious at core level. Many of you here have degrees. These degrees are some form of accreditation of an organization. They stand for a standard that sets excellence, and why should that not occur in district health? So who better to lead the chair of this session, Mr. Rizwan Koiter, and he has told me very clearly not to embarrass him with over long introductions. But the hat he's wearing today amongst the many, as a philanthropist, as a person who led one of the largest health software organizations from this country ever made, and as a person who has been running the Koida Foundation for a while. But the hat he's wearing today is that of a person who's heading NABH, the national body that provides accreditation for standards and is the most important body in health. And I thought, with Rizwan here, we will initially hear from him his overall view on what I just briefly introduced. Then just going from this side to that side, all friends over here. Dr. Rana Mehta is a person who used to be a doctor, then effectively made Apollo and their entire electronic health systems what it is. And then, of course, moved further to consulting in PwC, is one of the top people for health consulting in this country. So we look forward to hearing from him about how they see this particular thing. Dr. Mona Duggal is a person who is one of the earliest people who did both community health and health informatics training from abroad, came back and tried to use these kind of systems to make community health better. I know her personally for a very long time, but when it came time for Niti Aayog to decide, is diabetic retinopathy screening worthwhile in a community, she's the person who led one of those trials. But the hat she will wear for today's discussion is not that. It's a very new one, and she's yet to figure out how exactly and how many thorns it contains while it fits. But she's the incoming director of a new ICMR institute. I shall refer it to as National Institute for Digital Health Research. All that name is not yet officially formal. But if digital health is important, we certainly need a National Institute for research in that area. And of course, it is very, very important along with all this to have people who have been doing this for a long time. The entire idea of building standards, the idea of creating excellence through those standards, and Jay Ganesh as the leader of AEHIN, and in a previous role when he used to build electronic health at Satya Sai, has seen how to implement this in India, but more importantly, he has also seen how to take this globally across the entire region. And his advice is very well sought after regarding how to build standards, create excellence, and measure it quantitatively. So we look forward. One of our panelists, Lieutenant General Madhuri Kanitkar, is on her way. She's delayed. I'll introduce her anyway right now. She was the highest ranking ever medical officer at one point in time. She is currently the Vice Chancellor of Maharashtra University of Health Sciences. Along with the Koida Foundation, they were the first to create a digital health course for medical students that is now available on the government iGot platform, where it has received rave ratings, and I think tens of thousands of people, lakhs of people have already benefited. So who better than her to talk about how all this can be learned from the time today's generation enter medical schools. With that said, I'm going to hand it over to the chair, Mr. Rizwan Koiter, to set the deeper foundation for the kind of a shallow vision that I provided. Over to you, Rizwan.
Yeah, thank you very much, Professor Anurag. It's a pleasure to be with you all today, so appreciate the opportunity. And as Professor Anurag mentioned, while I've been involved with healthcare in many different ways, as an entrepreneur, as a tech entrepreneur, in my role in running the foundation, but today's session is largely wearing my hat as the chair of NABH, and talking a little bit about how we think about accreditation, and unlike the previous chairs who have all been very senior doctors, in this particular case, NABH has a chair who is more of a business person and an engineer.
So I'm going to give you a business perspective to why accreditation is important and being able to really drive the business of healthcare forward and make quality a reality. Yeah. So before I start, I'm going to come over. So we have one more panelist, Neeraj, who has just walked in.
So sorry.
Yeah. So Neeraj leads a Path, which is one of the largest, not-for-profits working in the space of healthcare. So welcome, Neeraj. Yeah. So if you look at, how many of you all have been involved in some form, fashion in buying a car? Can you all put up your hand? Many of you all would have, right, in our lives. Now, each of the cars has an engine, and the engine, with respect to today's regulation in India, has to be BS6 compliant. How many of you all can put up your hand and say you all understand the BS6 certification? The BS6 certification is very complex. It has emission standards for carbon dioxide, for hydrocarbons, for sulfur, for various sort of nitric oxides. It has standards for pollutants, the amount of carbon emission. It's a very technical standard. Any of y'all have any sense of what those standards are? Do you worry about it? And the reality is none of us do. Because what ends up happening is that there is a very well-defined standard, which is called the Bharat Standard 6, and car manufacturers are supposed to comply to it. And all cars which are sold are naturally compliant to the BS6 standard. So there is a complex standard for emission control for cars of all types. It could be a two-wheeler, four-wheeler, buses, trucks, whatever. But the buyer is oblivious of the complexity of the standards. Because what is sold in the market is certified and complies. So there is some body somewhere which goes to a factory or goes to an automobile plant and checks whether the engines are compliant, and they have to go through a testing certification process. And eventually they get a small logo or a small badge which says, yes, you are compliant. And millions of people around the country who have no knowledge of what it takes to come up with those standards actually are able to buy a car which actually meeting those standards. Now you look at what's happening in the world of digital health in India, and in fact it's a problem globally, that today we all talk all the right things about digital health adoption and why it is important to use technology to improve healthcare. But when it comes to actual procurement of that software or that system, we're expecting the end user, typically a doctor who could be running their clinic, or he or she could be running a hospital, to actually make a decision on a complex piece of software. They have never been trained on it. They kind of don't even know all the nuances of what it takes. The same thing as when we buy a car, right? And just trying to draw the analogy. And we're expecting them to go through every single detail before they do the procurement. So now you have a situation where if you look at digital health as a business, then the buyer has no ability to buy. And interestingly, the seller, who kind of knows their product, has no ability to sell. And the reason they don't have the ability to sell is not because they don't know their product, because they just don't have the ability to train the buyer to buy, right? So imagine, for example, if every car company had to sell you a car, first had to make you go through a 3-day training program to explain to you how the BS standards for emissions work. And then you would first understand it, and then you would go to buy the car, and then you would ask the car company to validate whether that particular system is actually compliant. And only then could you buy a car. Then buying the car would be so complicated that if you had a mechanical engineering degree, perhaps you could buy a car. Maybe electrical engineer could buy a car. But maybe if you're from the arts segment, it would require a big lift, because now all this technical jargon to matlab samajh mein nahi aayega, right? Now we are doing the same thing today in the healthcare industry. We're expecting every single seller to go out and communicate what they are selling and explain that to the buyer and train the buyer. What is cloud software? What is security? What is privacy? Now there are new jargons, DPDP Act. So everybody's got this sword of DPDP Act hanging on their head. And then they have to worry about so many other factors. And then we say, "Arey, digital adoption nahi ho raha hai." So nobody is able to sell. Hospitals are not using technology. So we have made the job of buying and selling software or digital tools so complicated that the buyer doesn't know how to buy and the seller doesn't know how to sell. So we need to demystify that. And we have to really make it easy for, very simply put, the buyer to buy and the seller to sell. If we can't do that, digital adoption nahi hoga. So what is the solution? You need an agency like the NABH which is able to demystify. So I have 2 slides. I'm going to share with you what we are trying to do at NABH, and hopefully all this background I gave you will make sense to you. Yeah. So what are we trying to do at NABH? Okay, so there are, just pull this up. Okay. So this is a very important slide. Okay, and I have only shown this slide a couple of times before, so in a sense it's net new information. So let me explain the slide. It goes from, first I'll explain A, then B, then C, and how it all needs to tie together. Okay. So NABH is a 20-year-old organization. Over the last 20 years, it has built a very mature standards for evaluating hospitals. So they know how to go to a hospital and they can look at inpatient, outpatient, admissions, discharge, billing, inventory management, all of that. They have procedures and guidelines, and they have come up with a nice big book which explains how it should be done, and they have thousands of assessors that we send to the field to go and check whether hospitals are following our guidelines or not. And when they follow the guidelines up to a certain level or above, then we give them a certificate or an accreditation. So A, which is the core standards, has been around for 20 years. What we did about 2 years back is we worked at NABH to develop the digital health standards for hospitals, which is that yes, you want to do all this stuff in A. What is it that you will need to do so that the systems can support you in doing what NABH wants you to do, which is A. So taking off all the requirements that a hospital needs. Oh, you need to do admissions in a certain way. You need to monitor patients in ICU in a certain way. You need to maintain this documentation. That drives what digital tools are required in a hospital to be able to achieve objectives of A. Okay, so far you're with me? What that is doing now, so we've got about 125, close to 125, 150 hospitals who are certified now, and we have 200 in the pipeline, so it's starting to pick up. It is giving direction to a hospital on what is the requirements for digital, and so prioritizing for them, that these are the more important things, these are the less important things, because all NABH guidelines, if you all have seen those guidelines, define requirements into 4 levels, right? Core, commitment, achievement, excellence. It's a sense of priority, right? So imagine I'm running a hospital. Earlier, if you go to me and I don't have anything, I'm not a technology person. I'll say I want to automate everything. But automate everything actually means nothing. What the digital health standards for hospitals does is it gives you a framework to think about how a hospital should get automated and in what order it should get automated, so to be able to give you the best results for your investments you want to make. You may not be able to automate everything, but you can automate a few things, then you prioritize this, and so on and so forth. Now, assuming that is now understood, which is B, what we did last year, which is 2024, is that we developed the guidelines for electronic medical records and HIS systems, healthcare information systems. That imagine the hospital has to do all of this. What should technology companies build in their software so that the hospital can do this? Is that making sense? Actually, very simple when I say it, right? So now we have these 3 standards. They're all in the public domain. You can go and download it on the NABH website. There are 3 standards. You got a core standard, which is about 20 years old, which is A. You got the digital health standards for hospitals, what hospitals need to do, which is about give or take 2 years old, and it's starting to pick up. But now, most importantly, we have this 3rd standard, which is the NABH standard for EMR and HIS. The most interesting thing is they're all consistent. So what that means is that imagine if antimicrobial resistance is an important area, and if the NABH standard says, okay, before you give antibiotics, do these 3 things. Then the digital health standard for hospital says, hey, before you give antibiotics, make sure that the system is able to capture these 3 things. And the digital health standards for EMR is saying, if antibiotic is selected, then ask these 3 questions. Only allow the next button if the 3 questions are answered. So you are enforcing the discipline of antimicrobial resistance through your EMR. Now, if you don't do it like this, then you do the traditional way. What is the traditional way? You have to send thousands of assessors across the country, and then you go to each hospital, and then each hospital will then take a sample data, and then for the sample data you will check whether those 3 protocols were followed, and then you will determine whether your antimicrobial resistance is working or not working, which is so complicated and in today's world so convoluted that we don't really need to do that. Maybe we need to do it today, but perhaps not 5 years down the line, if all our solutions, which are being implemented in hospitals, are NABH compliant. Yeah. So the fact that we have an internally consistent, integrated approach, I think is very cool. And to the best of my knowledge, I think India is the first, probably the only country today, which has this integrated approach between the core standards, the hospital standards for digital, and the EMRH. And I think that is very, very important. So all very new. Of course, the evidence of many of these things and how it will get panned out will take several years. But I do believe that we have the right framework in place. Yeah. Okay. And then the next slide is also as exciting, and I'll share with you our overall strategy for how we are scaling this. So now what I spoke about so far is in the context of what I would call a general hospital, but reality is that healthcare is getting more very, very specialized. So whether it's cancer, whether it's cardiac disease, whether it's diabetes, so orthopedics, every department and every specialization is trying to build more and more sophistication. And it's really hard for one organization called NABH, irrespective of how good we may be, to become great in everything. It's not going to happen. So what we now have is a very systematic, structured partnership approach, where we are saying is that we will build the general standards for hospitals, clinics, and so on and so forth, but we will partner with the best of breed organizations to be able to build specialized standards. For example, we want to build specialized cancer protocols. So for example, what is the problem we're trying to answer? You're a cancer hospital and you've now got all this figured out, the general EMR, what it should contain, etc. But there are so many things you need. Only you'll need it for medical oncology or for surgical oncology or for cancer tumor boards or what have you. What if we can define the digital protocols associated with those requirements? Then we will create a add-on certification on top of the general certification, which will be NABH's cancer module. And we will not do it by ourselves as NABH, but we'll do it in partnership with the National Cancer Grid. What if we could do the same thing for cardiology? We haven't started working on that as yet. What if you could do the same thing on diabetes? We've just started working with here. We have Dr. Sanjay here from the RSSDI with whom we are collaborating for that. So the approach is modular and scalable. And what I would like is 5 years from today, for most different types of or important types of health conditions or specialities, we define a certification accreditation framework which defines clinically obviously what needs to be done, but even digitally what we can do, so that we can drive the quality, we can drive accreditation to create standardized care pathways, evidence-based guidelines, and even do cooler stuff like healthcare. You want to do healthcare AI, guess what? If you don't have structured high quality data captured, you can't do healthcare AI. So a lot of this stuff will eventually drive a significant acceleration in the adoption of AI and other tools in healthcare. So I'll just pause here. Thank you very much. And hopefully this was interesting.
Thank you, Rizwan. That was, I think, absolutely beautiful way of capturing it. I think if we know what health should look like, and we have the capacity to imagine what healthcare should look like in a digital reflection in the digital lake, then we can figure out how to record it so that you can see that reflection. Sometimes, of course, it is harder to think of one way in which health goals are common across systems. It might actually be easier in specialized systems like oncology, which have greater degree of standardization compared to, say, getting down to the core of the public health, where people have such different requirements in different contexts, in different places, with different resources. So for that reason, I think I'm going to go with the very first opening question to Neeraj. Ooh, ma'am, good to see you. No, it is rare you walk into a room and somebody misses you, so my apologies. No, I can see where everybody is looking behind me and not at me. I already took the pleasure of introducing General Kanitkar, so I'll not do that again. And I'm anyway sure that most people in the room will recognize her. But coming back to the vision that Rizwan provided, which I think was absolutely critical, in terms of if you have to know what you want to deliver in healthcare and you want to standardize it, you can then trace the path digitally all the way up to the records. I would imagine that when you get down to the periphery where people don't necessarily know what they want, or what they write they want is different from what they really want, life gets a bit complicated. So Neeraj, what are the operational challenges you see in India in this entire area? And as you continue, are you able to imagine some kind of interoperable, standardized system that works for everything?
Yeah, firstly I'd like to apologize since I was a little late, but ma'am, thank you for coming later than me. It kind of solved it for me a little bit. But yeah, I think Anurag, you're talking about imagination. I'm a hardcore optimist. Actually, if you're working in public health in India, you have to be an optimist. There is no other way to actually survive. And I think we, as an organization, since we work right from, starting at the primary healthcare level, upwards, we are extremely optimistic. I think Rizwan has actually already sort of said how India is ahead of the curve, in terms of the way we are imagining our digital backbone, etc. The challenge is in the implementation. The challenge is that we are 1.4 billion people. The challenge is that we are it's a large geography to cover. So those are going to be things which we will have to deal with as we go along. But just, focusing a little bit on the public health side of it, I think one of the big problems is the way that our forms are structured. And, standardization is a challenge. We have also, over the years, those have developed, and a lot of data which we are capturing, we may actually not need anymore. But somebody's got to go back and redesign some of that. We've got to standardize them. We've got to make sure that we are only focusing or capturing the data that is actually required for decision making, for knowing what's happening in the sector. And I think that'll require some sort of a mandate around the standards of electronic health records. And you know, that's going to be my first task. And look at some sort of a common minimum data set concept, some sort of a vendor compliance enforcement will also have to be brought in. So yeah, those are a few of the asks on that side. Capacity is the other one. So, you know, Rizwan is talking about capacity at tertiary care. Now let's go down, Rizwan. And I'm sure you've been to primary healthcare centers, you've been to CHCs, etc. We will have to really think about how we're going to build some of those capacities. And also the understanding of the importance of overall about electronic health records, etc. Again, I don't think it's impossible, Anurag, because you know, if you think about UPI today, I couldn't have imagined it 10 years ago or 15 years ago. I mean, I just couldn't imagine it. What's happening today and the way things are moving, the way payments are moving around, we could never have imagined. So let's not simplify EHR into a UPI, but having said that, I think that digitization and that capacity building is possible. I know that, you know, Rizwan Koita Center is doing a lot of work with Maharashtra University of Health Sciences around some of the training, etc., maybe a trainer model, and some sort of a way where we can figure out how we are going to build that capacity. Finally, vendor fragmentation, and I know my time is almost up, so quickly, vendor fragmentation, lots of vendors out there. Lots of people wanting to jump into this boat of electronic health records and digital health in India. I think we need some sort of a certification system. We need some sort of a basic rating system and some sort of maybe a government endorsed marketplace, which is already forming and coming along. But I'll stop there, Anurag, back to you.
Thank you very much, Neeraj, and you are absolutely right. I mean, in UPI, one huge advantage is usually the guy paying wants to pay and the guy receiving wants to receive. So as long as you solve the tech, everybody is happy. On that note, I'll clarify why I said that as I move to General Kanitkar. It's a little different from where we are going, but you've been, you know, in the armed forces and in general, so we can go anywhere you want with difficult questions. Now in healthcare systems, let's imagine what Rizwan talked about was if you know what you want your healthcare system to be, you understand what that process would look like digitally, and you create a recording system that gives you an accurate idea of that image, you can go all the way up to providing the best care. And that makes complete sense. Now you run a Maharashtra University Health Sciences. A lot of care is provided through your system to people. But there must be multiple alignments, right? When you want to record care, you will also record deficiencies in care. When you record deficiencies in care, you might get people who are not fully aligned with the idea of creating a perfect electronic health record system. So in the realities of a state, large scale, university system, where you're catering to a large number of people and providing services, what I want you to see is what do you see as a potential for using these standardized, quality, excellence-driven systems with proper accreditations that make your life easier in convincing all sides to adopt and perhaps create a scalable system for others.
I think, thank you very much. I think it's a very important question, and when we deal with state health university or any state for that matter, and what you spoke here, that we're not dealing with just tertiary care. And I'll, just to tell an example, I've got 660 colleges of across, because we are not talking pathies here. We are talking every health system, and we want it to reach every person. And then look at the numbers. One medical college has 10,000 deliveries a year. And there are 68 such colleges in one state. So the numbers are humongous. But at the same time, you need the standardization. The reason being, more and more the society is wanting it. You want standardization. criminalization and legal things are increasing, so a documentation is required. Now, if it was not standardized, it would be a huge khichdi with no alignment. And the problems in that are, again, in most states, health systems and education systems are under two different heads. And when this happens, they're two different ministries, they're two different, the problem is even more. Because when you provide a health system and you digitize it, you want a continuum of care that every individual from whether it's preventive, promotive, palliative, curative, rehabilitative, and primary, secondary to tertiary. So unless there is interoperability and a standardization, you'll land up speaking different languages. And I think we won't bring languages here, there's enough controversy. So I think that is where the huge requirement is. And the other challenge when you deal with these numbers is, in our public health system, the care providers are far and few in between, and there's a huge divide between the haves and the have-nots. So when you go, and plus the urban and the rural. So unless you have a KISS principle, keep it short and simple, keep it really easy to capture that data. Unless it's standardized, unless we think out of the box, and like you said, UPI, simple problems were solved by simple people. But complex problems, I think, need collaboration, and forums like this where, the best of minds and the health, but at the same time, we need to take the end user, that is the healthcare professionals, in part of the decision making. If we don't do that, we give a treatment and without understanding the problem. It's exactly like when a patient comes, the doctor, you and me have been clinicians, and and when you're teaching, you're very happy with the diagnosis. Patient isn't interested in your diagnosis. He wants relief. So the same way when we are prescribing a electronic system, the user, both the patient as well as the healthcare provider, wants it simple, so that to use it is easy, to retrieve it is easy, it is standardized, and it's clear. I think that is it.
I think the last point you mentioned was very easy. You have to keep the doctors in mind. And I think you alluded to it when you said about, in your optimistic way, perhaps some of the forms need to be retired with some of the fields. So, diplomatically said. The point is, if you start digitizing forms the way they exist, requiring people to collect information, because now it's visible, right? What you did not do. Requiring people to collect unnecessary information or information that is not meaningful but will translate to poor quality. You really will face fight back from doctors. Often it will be passive. So taking doctors on board while deciding how to go about it is critical. Mona, I'm going to come to you next. And the topic will be one we're going to continue from a recent discussion we just had. All over the world, when people build quality healthcare record systems, very well standardized, people know exactly how to access them, extract information. They are doing high quality real world research, trying to understand what drug is working, what is not working, side effects that were not anticipated at the time the drug was licensed. Where do you see a vision for India in your new hat and your previous ones of what these kind of systems could mean to accelerate healthcare research in India?
So Anurag, I think it was a dream when I returned. My entire training in US was actually on electronic health records. And when I returned to India, there was nothing. So I went into implementation research. But now when Rizwan said the EHR, I jumped back and I actually wrote the day I got to know, I reached back to my mentor and told her, okay, now I'm going to be leading and I hope to reconnect with you. I was trained in HIV research, and that entire, which kind of was the starting point for me, it's the Veterans Aging Cohort Study. So the entire cohort study was built on that. It was like 8 active sites across where active good data was being collected, in addition to all the VS sites where there was passive data collection. So And out of that, I did see how the research could be built. We had a healthcare outcomes research. We had a chronic kidney disease. We had a respiratory arm. We had a cardiovascular arm. And we had a precision medicine and the basic science arm. And it was an aging study. And from that, the entire research around that, it was almost like a electronic Framingham study. And it's still continuing. So that was one example when I saw the power of, if you have the right data as an electronic health record, how you can build the research and how you can, the outcomes can be so powerful. So thanks to Rizwan, I think now I can, when you say the vision, I think now I can actually just start building off the vision now. So till now I had always been talking at every forum on diabetic retinopathy. Now I can start talking about my vision on the electronic health records. Coming back to what Anurag just said, even if we are able to start as an implementation research on electronic health records, as an example, taking some of the diseases as the use cases and see how it works, I think that is where it is going to spur more research. Having longitudinal case models. India is rapidly moving into a space where a lot of research needs. It is not maternal and child health, of course it's an important area, but the chronic disease models, the aging models, and where you need the longitudinal models to work on. So the electronic health records are going to be extremely important. It has to have the personal health records. The ownership has to be with the patient also, and the responsibility so that the right data is there. So anything that the doctor is feeling, it should be equally a partnership with the patient so that you are able to have the right partnership. And of course, the research component is going to come in. So this is where I see my vision when I see the electronic health records and how we can build in and how it becomes a feedback loop. The third component, I always say, the evidence that we create is based on the data. If we have the correct data, we are going to have the correct evidence and we are going to have the policy. And my favorite example is like morning, everybody was talking about pregnancy and nobody is talking about the late pregnancy and the NCDs in pregnancies when it is such a huge problem. So that entire, the infertility and everything, because that evidence and the data collection probably requires a lot more in it. So I think the vision that I saw when I returned to India is probably going to happen now. Thank you.
So by now you have heard about the vision laid out by Rizwan, some challenges by General Kanitka. You heard the word mandates from Neeraj. And you of course heard if we are able to succeed in doing this, we could absolutely do stellar research and generate evidence. Now we go to Rana, because Rana, you have started creating electronic health records and making them worthwhile for people. And you didn't have to have government pass mandates to get people to adopt electronic health records, at least in a given sector. But I'm sure there is a case that can be made by which people sufficiently benefit from having these records as a business case that would allow people to seek this kind of digitalization of systems, easier accreditation, things like some of our past experiences and a vision of the future. What can we do that without creating legal mandates on everything, create a self-uptaking system that is incentivized and benefits people who do this?
No, thanks, and thanks for having me over. I think on the electronic medical records, I think obviously we have no one better than Rizwan, who's an expert. But I just wanted to bring a different perspective. We've been talking about and the significance of the digital accreditation, right? We often don't understand. So we've been doing the same accreditation for 20 years. But that's very, very incremental. Healthcare is about three things. It's about the infrastructure, it's about the process, and finally it's about the outcomes. So accreditation has always been a proxy for the outcomes. Okay, I put in great infrastructure, I follow all the processes. But I could never measure that. Now with the digital accreditation coming in, I have that data to measure it in. So I think the biggest change which is coming in and which will help out is I was looking at policies, I was looking at procedures, I was looking at compliance. I leave that out. I want to look at outcomes. I was looking at the input. I was looking again. I want to really look at what's the result, what's the impact on the population over a period of time.
I was looking at audit and checklist. Now I want to look at the data. I think that's the whole thing. Whatever I was doing was retrospective. 3 years later, I'll come and accredit you. What about the outcomes for the 3 years? So now I can do that in real time. So I think that's been the biggest change, because I think accreditation is great, but what is the whole objective of accreditation? To improve outcomes. And the digital component has catalyzed this. So it's, again, the UPI example is great, right? What was the objective? It was not about opening bank accounts, opening banks. There was a different way to look at it, right? So in a way, now we want to look at the whole outcomes. Outcomes in a healthcare sector will become most important, because what's happening is the Indian government over a period of time is moving away from being a provider to actually becoming a payer. So should it be paying only for processes? Should it be paying for infrastructure? Or should it look at and saying that this taxpayer money should go for something which would really value? And over a period of time, it helps you set up, like you said, a business. I have much superior outcomes. Now, outcomes also, till today, are generic, right? If you go to a hospital, we say 90% success rate. I was recently, in a conference with one of the academic medical centers in the US, and they're saying, with GenAI, we can tell you your outcomes. So if you bring your mother to this academic medical center with breast cancer in this stage, this would be the outcome. So I think this whole thing of putting this is putting in building blocks, which we will appreciate 5 years later. Because this now data is getting captured where we can really. Because I think in India, our access to healthcare would be very different, right? You have these 3 axes. You have a geographical axis, but 70% of infrastructure is just in 20 cities. And let me tell you, that's not changing. The second is the financial access the government has given. But finally, I think it's going to be this technological access which is based on outcomes. I'll give you a very simple example where this works out very well. You've had the same cancer drug for 5 decades, right? Your cancer drugs haven't changed. Your outcomes have significantly changed because you have the data to say that if there is going to be a side effect, if somebody is going to go and vomit, I've already given him something to prevent that. So I think, what we are looking at, and this whole thing is actually a very tectonic shift. And this will bring in a lot of business models where people will say, okay, fine, can I even enhance this further? So I think we are really at the inflection point on the healthcare side.
Thank you very much, Rana. I mean, that makes a great case for people to want to do it as opposed to being forced to do it. But Rizwan, you probably have more thoughts on making people willing to do this, because you must be looking at this problem from NABH angle, right?
So, what we have seen worldwide, that to achieve any of this, to try and force it through a government mandate is very difficult. Because the reality is that even in a country like India, 30% of healthcare delivery is through the government system, 70% is through the private sector. So maybe if there is a government mandate, at best it will have a direct impact on 30%, but almost a very little impact on the 70%. So the way we need to solve for this is to try and look at it as a business problem rather than a compliance problem. Because if you say, hey, I want all my stakeholders to comply, and I go down that path, we know across the world and through our little endeavors in India that it is very difficult to achieve any meaningful success. But if we can try and create the right financial or business incentives for organizations to do what is right, then it is perhaps going to be, and I use the word perhaps because there's a lot of uncertainty. So nothing that I said in my 2 presentations should imply that NABH has figured it out or this is exactly the way it's going to work. A lot of it is work in progress. It will take us 5, 10, 15 years of effort to be able to make some meaningful thing. But we need to think about as much as a business problem, as much as a healthcare or a technical problem. We want to create mechanisms where software vendors want to comply because it will create more business opportunities. So it is as important for NABH to publish those guidelines. As important is to put each of the vendors who are complying to our guidelines on a pedestal, so the vendors know that they get marketing and business development brownie points if they comply. to ensure that we create a virtuous cycle where good companies are working hard to comply to certifications and then they are succeeding. The same thing is true for hospitals, right? You can make a diktat to a hospital, but private sector hospitals are notorious worldwide that they'll do only what they want to do, you know. But if you create the right financial incentives, going back to what Rana mentioned, in fact, PwC has been a very strong partner for NABH in our digital journey. Then we create the right business reasons why hospitals want to comply to our requirements for digital, because they can measure, they can monitor, and the responsibility of NABH is to again put good hospitals on a pedestal, so that if I am a patient and I want to select a hospital, then between two hospitals, incrementally I should be able to make a decision to go to a hospital which is more digitally savvy than less digitally savvy. And the reality is that in the world where consumers are becoming digitally savvy, insurance companies are wanting e-claims, government is also now requiring e-claims or will start to require e-claims more. You got industry bodies like NABH and others who are also asking for it. I think slowly and steadily the shift in thinking will happen, but it's a very it will require a lot of patience, it will require a lot of systemic effort, and most importantly, we'll have to drive the business angle. We can't really look at it as just I'm the government of India, I'm NABH, I'm going to come up with a rule and therefore people will comply. That is not going to work.
Thank you very much. So, Jay, you have seen the beginning of all this from Satya Sai, pure philanthropy. Now you advise people who want efficiency or who want better returns. Where do you see this area going?
Thank you. It's sometimes it's inviable being the last speaker when most of the things that you wanted to say is already said. But then nevertheless, I will try to actually, okay, I've been an implementer in the previous hat that I was with the non-profit hospitals. So when we first got started, it was an era where we didn't even have the electronic medical record standards for India. So I had the first job right out of the college to do the enterprise hospital information systems. Those days it's a web-based system. One of the first ones, I think the first one in India. When we did that, there was nothing like a standardization. So literally we had to do a study of like what could be the demographic standards. Like MDDS came up much later, and then the electronic medical records standards came up much later. So everything was done from the scratch. And then being a non-profit, so we are not a corporate hospital, what is in it for us? But we were very clear, health is the focus. And then we believe a digital is a means to do it in a nicer way. And then we had a telemedicine project from then, which is still running actually even now, like 5 days a week without a stop. Whether it was like, we started with the satellite-based network from ISRO, then of course the things improved, and then we have our own network right now. But I think there was a systematic way of what is in it for the doctors and why we have to do it, because there was no other incentive. Nobody was actually paying us or motivating us to do. So one of the experiences I would like to share is before we started the telemedicine service for like in tertiary care or for cardiac surgery as well as the neurosurgery. So how do we go about it? So we started with the HIS. Once the HIS implementation was done, the data like to whatever extent possible, like starting with the demographic standards and then ICD. I remember those days I wrote to the WHO and they gave the CD. You know, those days it was available as a CD just for reference. You cannot pull anything out. Then we actually typed. Then the doctors were not comfortable to identify which code. We even made it a mandatory that before you discharge a patient that they have to actually record the diagnosis. But then if they do not know what to do. So what we did is, and then all these codes were like, of course, ICD is not very much for the procedures, right? And then so what we did was like to sit with the doctors and the medical record department, identify the, like what we do as the most popular procedures regularly done, so that they just need to look at that list and then put that and discharge. Or when in doubt, you actually consult with the medical records department and do it. It took a while. And then, but when we went to the telemedicine, like how we started was like first established the HIS, then we had the PAC system in place, and then we already started, like I'm talking about 2007, we started remote registration of our telemedicine patients from the 4 different states. So it was a journey where like we did it because it was like almost like a mission-like thing, why we wanted to do it. And then we created that, as I said, like everyone looks at what is in it for them. And then doctors would like to use it, but they have many, many things to do. So one of the first things that we faced the problem was, even if the doctors were willing, the HIS was not allowing. Like there were no provisions. For example, our doctors wanted to use SNOMED, but at the time the government of India had not subscribed to that. There was no NRCES at the time. But then how do we actually bring in? First thing was to actually convince our provider, HIS provider, to actually make those provisions and then pull in those standards. So it was a long journey. But now I am very happy that, Mr. Rizwan mentioned about NABH and then things were available. But then having standards doesn't mean that everybody will use it. How do we actually take it? What is in it for them to start using it? How do we, like for example, SNOMED came up like when it was, I remember it was in August 2013 or so, when India subscribed and we started getting, but then NRCES, the National Resource Center for Electronic Health Record Standards, got the mandate to conduct workshops throughout the country. It took several years for many other hospitals to take interest and for them to start using SNOMED. So I think we have to look at that way, because like again, with the kind of population we have, so much of diversity that we have, and then how do we actually also get the public hospitals? Probably the corporate ones have certain, to have the accreditation means certain things for them. How do we, my father is a pediatrician from the government system. I've seen literally the issues that they have, the number of cases they deal with. So how do we actually get the public health system also to use that? So that's where my goal or vision is, like again, wearing a regional network like AHIN, Asia E-Health Information Network, which is a peer network in the region. So we have volunteers across several countries. In fact, I can see one of our AHIN members here, Dr. Pak Askar here, very much in the audience from Indonesia. And then what we have done right now is to take the standards into action. So we have created this standards and interoperability lab. And it's like, not many investments or something, but we start in the universities because universities find it easy to work with either industry or the government or anyone. So we start with that and then identify the core interoperability issues with the national information systems and then start working with that. So those are a couple of efforts. I would say I wouldn't like to sort of take your time, but if there are any questions, I would be happy to answer. One last thing, like for example, the telemedicine practice guidelines was one of the contributors. Like what we still have is the one what we did in 2020. It will be good, like that time it was a common minimum program kind of a thing because we wanted people to start using it. So we kept it simple, but then it's already 5 years. So how do we actually, get those things into action? One example, I'm not actually trying to promote what US is doing, the US core data set for interoperability, but the process what they do is something really good. They have version 1.1 is already a standard, but right now they are in version 6. What I like is a process where people could actually contribute data elements, data classes, and then like it's available in the public domain, and then like, so the vendors actually know, oh, okay, this is the kind of a roadmap that they have, so they can build their systems accordingly. If we could probably do that, I'm sure that, Mr. Koita already mentioned like the NABH efforts, but then how do we actually kind of take in a country with so many challenges, especially like ours? That's what is the area that I would like to actually contribute. We'll be happy to work together with everyone here. Thank you.
Very, very useful. And I think the layout of the land is now very clear. And I think we all agree that using these digital health standards for accreditation would make many things better. But the question will come back to what you just said, the million-dollar words. What's in it for me? And that me is typically either a person or it's an institution. And the original topic that we started it was accreditation. So let's, in a shorter version of this, now go back around and start with Neeraj talking about what's in it for me for accreditation in a public health system down at the bottom.
Okay, I'm going to be a little bit provocative here. So since I have the liberty of talking about the public health system, and you also, picked on me on the word of mandate. So, the challenge is I totally agree with Rizwan on some sort of an incentive which is going to make this happen. Unfortunately, in terms of how long it's going to take to build those incentives in the public health system down to the health center, and really see the impact of what this digitization could take quite a long time. And that's the reason that somewheres, I think, looking at the Australian example of opt-out versus what we are doing of opt-in, I'm almost sort of encouraged to say maybe we should also have thought of an opt-out mechanism where people did have the option to opt out of it, but it was in a way a soft mandate which went down there. We've got a problem of equity. And I think incentivizing will probably work very well in the private sector, in large hospitals where there is a way to incentivize. But somewhere I think we need the carrot and the stick to work together rather than just the carrot or just the stick. So I'm gonna nudge Rizwan. You're a creative person. I'm happy to brainstorm with you, but we really need to come up with that balancing act which is going to make it happen. And we did a lot of that work in private sector in getting them on board, right? The whole story with the program in urban primary health, urban private sector. Is it successful? Well, we got a lot of people signed in. Is it working well? I'm not sure. And we have our own, I'm sure, I mean, we did the program, so we always say nice things about it, but I'm not sure if it's working the way that it was envisaged. So I really think that if we want to think about equity, we will have to figure out a balancing act of this and how it's going to work. Just to correct you a little bit, Rizwan, I think the data that the government of India is now sort of putting out, we are at about 50-50 public and private. So that's been a movement. I mean, we can always question the data, but that's where we're heading. And public systems are getting better, etc. Ayushman Bharat has had an impact with people being able to access private healthcare facilities. Our IPHLs, public health laboratories in districts are getting set up, which are absolutely free of cost. Health and wellness centers are getting better and better as we move along. So there is that movement which is going on, which is going to continue. So I'll stop at that. Sorry for being a little bit provocative, but I think we need to find a solution that's going to work towards an equitable India to move forward.
I completely see your point. In fact, with the new education policy, this opt-in, opt-out problem has been around for a long time. And now ultimately the government has decided that you are going to shift to the NEP or you will lose benefits. So that's almost a mandate. I mean, it's on the way direction. But I would love to now hear from General Kanitkar. Opt-in, opt-out, mandate, switch on your own, take your time. You are running about as big a system as can be possible at every level that is possible. How do you see this?
I think there has to be, it's a democracy, so there has to be an opt-in, opt-out. Right? But that carrot and stick, I love this thing because I think the armed forces always works on carrot and stick. So I think what is important is here, when we are looking at developing the systems and equity, if we want to really fast track, we have to link up the incentivization with individuals. So why did UPI work? Because you simple said the person who was paying, who was receiving, both wanted to have an app down. And any app that any of us download, and that's irrespective of today that, I mean, even if they live, your workers, everyone has smartphones. Why do they download? Because they get an advantage. So if you link just the simple, all the schemes, whether it's Ladki Bahin in Maharashtra, whether it's whatever, that if you have a ABHA, you have your this, and you start giving in the data. How we have to, that's what for the others to figure out. But everyone gives their data to get back something. I think that would be the model that would really reach, because then people will hog it up. Okay, if I get this, I'm going to get my wellness center, I'm going to get my appointment, I'm going to get my treatment, I'm going to get my medicines, I'm going to get everything. So it's the stakeholder at the grassroots level. The equity will come immediately because each one wants that. There is no difference in equity. The needs are the same. So you incentivize that and you'll probably collect. The second aspect of, opt-in, I think was, wherein I came in was, I think really came in, and Rizwan and MUHS is working together, is creating capacity among our healthcare professionals and incentivizing that with that, when they go in for their jobs, whether it's the RRs, it's a very simple tweak. But you have that, you get that brownie points is what's going to work. People are going to adopt it because everyone finally, we are still at that stage, you learn to earn. We're not just enjoying courses. So if we bring that in, I think that's going to be a huge hope. And simple thing, a little carrot and stick that worked, we launched out and said, I'd like we'll start with medical, because we had 68 medical. And we said the interns would have to do a digital health foundation course, which Koita Foundation helped us develop. Surabhi's here. And it was, initially there was a whole lot of resistance. But when we went and spoke to the interns what their problems were, and we, brought in changes in that, today we have 3,000 kids of this batch who have already registered. So it happened within 3 months then. And the same thing when we put on to the iGot platform, I was surprised in 3 months, 62,000 people in the country are using it. Because they saw something new in it. They said, if I do this, I'll get something. I think that is what will finally, the business model will work, that the businesses who need them have to incentivize that if you do this, you come back, you implement it, we'll be able to give you something. I think that's the way forward.
I think that makes absolute sense. Now let's go to Mona. Because when people get accredited, they earn, they can get brownie points. What would the equivalent for institutions that maintain the records to enable research? Why would they want to do it? What can be the system that makes them want to get accreditation?
Thanks, Anurag. So Anurag, I'll go back to my, I was at PGI in ophthalmology, and ophthalmology, luckily, our head of the department was one of the early adopters of digital system and the EMR. I saw the evolution, it started with a glaucoma. Of course, he was not the head when he was there, but he had introduced it in the glaucoma. It actually improved the efficiency, you have the appointment system, and the queues were much less. And if you compared it to the other, because you had retina, you had glaucoma and the others, I think glaucoma was one of the better managed. So the consultants there were probably, they had more time. They could come to have their coffee and go back. So let me put it that way. And the others were totally, flooded with patients and long queues, and you could see that happen. So that is one thing when we say, what is the incentive? It is incentive on both ways. I think it manages the care better. For the doctors, it is more time with the patient, and for the patients who matter. So you don't really want everybody to be coming, and that is where the tertiary cares or the advanced cares are getting hit. Second is you also start looking at what are the kind of patients you really want to spend more time. So doctors are much more fresh in the morning. So a lot of that research. If you start looking at what are the pattern of prescriptions, so you can start building on those models. Like when a doctor comes in, he is more fresh, how he prescribes. Over a period of time, who is looking? Most of the care is then left to the residents. So the errors can start coming in. The health system strengthening starts coming in. The second opinion. And PGI, one thing which I always saw as one of the areas was being the only advanced center where we had highly qualified doctors, And being we are the capital of, we are a union territory and we are capital to 2 states. So we have a lot of political and bureaucratic pressure. So we have the unique, we are highly VIP city. So everybody is a VIP in this, and everybody would call a director, and everybody would need that appointment. So it's simple, if you actually, I always say, if you can just build it into the system, people who need the appointment, you can have the gold, silver and this, and people can actually pay for their appointments. And that is again another model. People who actually need the care, they improve the access to the care, the equity, who are standing in the queue since the morning and really do not get the care, would probably get seen first. And people who have the ability to pay would actually get to the doctor who really needs the care. So those are some of the things that can be built into the health systems with the help of the EHR. And doctors will be much more happier because they will be spending more time getting the right treatment, giving the right treatment. And you will also get to bring in a lot of the retired doctors back into the fold. So many of the people who retire, if they are just simply there on your EHR system and are accredited on the same system, can be done. So there is a health system aspect which you can bring in, and then you have a research aspect that you can bring in, where you can build the e-cohorts and start looking at how the improvement can be done at every level and what are the kind of disease patterns. So one thing that came into the notice, I didn't note, there was a simple conversation. This, you have the syphilis, and there was a sudden increase in the eye manifestation. For me, as an epidemiologist, I immediately picked up okay, there has to be some hotspot. But as a clinician, you do not. So when you start looking at the patterns, it becomes okay, which geography, where it is coming from, and this, it actually makes a difference. How is the access to care? And again, I think there's where the epidemiology, the statistics, the data scientists, they really need to work with the clinicians, because that is what I always found different among the clinicians. The gap is there. They look at the patient, but the behavioral and where the access to care. And last thing, when I'll come to Rizwan, it was very interesting. My last thesis before I came in was looking at how a patient who has had trauma, eye trauma, what is the outcome after 2 years. It was we built an e-cohort, the cohort from the trauma center. We matched it to our eye center. And then my student, she followed it up. It was an active test. So when she had presented it as a thesis, what was how the clinician came back to her. She said, this can be done by a data entry operator. Why do we need this to be a thesis? So I'm just trying to tell you the gap, the capacity building, where the gap has to be there, and why we need to look at the meaningful data, the research, and how at every level the health systems, implementation, and research need to go hand in hand. That's
Sounds like incentivizing for research a little bit harder than others. So Rana, you already partially answered this, because in private health systems, with payers using these indexes to determine payment, anything else that comes to your mind that should be done or can be done to incentivize accreditation via these means?
Yeah. No, I think, see, at the end, the payer is the strongest component, right? Ultimately, I pay for it, the government pays for it, my company pays for it, so the control is always. So a long time ago, I had gone to the Mayo Clinic, and so initially there was no concept of accreditation in India, nobody had heard. So you have JCI, which is the international, but they have JACO, which is the thing. So in one of the meetings, I just asked, is JACO compulsory? And they said it's not compulsory. You can run a hospital in the US without JACO. But the only thing is, the predominant payer, Medicare, will not pay for it. So there isn't a single hospital in the US which is not accredited. So I think we got to relook back, say, how do we get it done? Now, I agree with Rizwan. There is a problem because the government is not only a provider, it's not only a payer, it's a provider, right? And if you're saying it's 50%, then I think our problems just got compounded, right? Because Rizwan was saying that maybe 90-10, and then you're not sorted out much easier. So, you really put the water on that.
We're hoping to take it further.
Yeah. So I think that component of how do you get the payer to actually look at it, because if the payer starts saying that, okay, right, in the US, predominantly there mostly is government, the veterans is a separate sort of thing. So over a period of time, if you're convinced that the payer wants this, because it's not more than accreditation, it's linked to outcomes. As a country, we have finite resources, right? It's not that we be the best payers. We haven't been the greatest of providers. But now if you're moving to a payer and you also fail, then in a way, you've actually done disservice. I'll tell you where this whole thing comes from. You had a great medical colleges, but maybe that funding is coming down. So someone goes in for, say, an orthopedic surgery. Now he goes to one of the private hospitals which accepts PMJY, which may not be of the greatest standard, because we all know the top 100 hospitals don't do much. Now because of that, now there is an infection which happens. Now he's stuck because the next level doesn't accept, and you're even worse off than before you did the surgery. So I think these are issues which are going to come into the limelight over a period of time. Because if you're not an effective provider, you're a suboptimal payer, these are problems, and that is where I think this whole accreditation could really play a role.
Ineffective providers and suboptimal payers. That sounds... Okay, we'll not go further on that. But Rizwan, I think we'll ask you to maybe start summing up the key learnings from this session. And if we have time, we will go back to Jay for some example that he had in mind.
Sure. So I'll make a comment and then I'll just summarize. So, Neeraj spoke about challenges in the public health and digital adoption there. So one of the things I would like just the audience to understand in terms of what is really happening on the ground. What happens on the ground is that because public health is delivered by the government machinery, the people who are in the government machinery are required to use tools which are predominantly built by government. It could be the Poshan app, it could be RCH, it could be even the public, the PHC software, the secondary, the tertiary software, and so on and so forth. And what is happening is that because of the fact that the government is the producer, government is the buyer, it precludes a lot of the innovation that often is coming in the private sector. So one of the challenges that India should really think about is how do we look at the procurement of such software, or creating an ecosystem where public sector entities and government bodies have access not only to government software but also private sector software in a manner where we are able to demarcate between the producer and the user, right? Because if we don't, then we get caught in a ecosystem where innovation is probably slower than what it is possible in the private sector, or when we have hundreds of technology companies who are doing really cool things, they just can't penetrate that segment because there's a government buyer. So with that, I'm going to sort of just spend a couple of minutes just summarizing. So first of all, thank you very much for being a really patient audience. This was a really fun session. We couldn't have had a more diverse and a more sort of outstanding panel here, right from Dr. Kanetkar, Jay, we have Dr. Rana, Dr. Mona, Neeraj, and of course Professor Anurag himself. And we were able to cover aspects all the way from how the private sector, hospitals, payers should think about it, how an entity like ICMR thinks about the problem, how in the public sector on the ground, we see in the public health side of things, Jai giving his thoughts around what's happening from an interoperability and data sharing not only in India but even outside, and Dr. Kanetkar having her oversight of 600 plus entities in Maharashtra talking about the challenges that she faces. So I think this has been a really exciting, at least for me, lots of learning. I hope that was like that for you as well. So thank you very much once again. I'll pass it on to Anurag.
Thanks. In fact, I'm reminded of the pandemic when for telemedicine, Tech Mahindra, I'm trying to think TCS, they all created digital solutions for people to access. In the end, because only the government can supply the government, many of the better received solutions during the pandemic simply disappeared. Jay, I know you wanted to say one thing about your experience on the same matter. We'll do that, then we'll take a couple of questions if we can.
Sure. I think one of the ways of incentivizing or making the life of physicians, the clinicians, more productive is what we did was, for example, I'll give you, in income tax returns, right, we have Form 16. Can you ever think of such a similar one across, considering all the specialties that we have? It's extremely tough because I worked with 7 of the specialties for the hospital information systems. It was very difficult to get them all agree on a standard reporting format. So what we did is, okay, you do whatever the flow that you would like to do, but there is one particular module where we got them all to see a single picture. So it was easier for them to get everything in one page. And then the second one was actually our mobile hospital, where we had a portal, disease management portal for diabetes and then comorbid conditions. And that was completely run by volunteers. So they keep changing every month, but then when they come back, we devised in such a way that within one A4 sheet, we should be able to get their data across the months. So if we could do such tweaks, I think probably it makes it more easier for the clinicians. And then in the hospital, typically it is the nursing staff and then also the DNP who are the workhorses in terms of actually putting in the data. So, and they actually look for certain things. Like we created incentives like you could publish it if you actually, it's not like, you just enter tap for all the mandatory fields and then completing it. But then if you do this, you will be able to actually get you the better data for your own publications and work like that. So we built in such smaller ones and then it worked. I wouldn't say that everything was successful, but it did help. Thank you.
Okay, we'll open this up for questions now. You can also name the person you want to address, or you can leave it open and somebody from the panel will volunteer.
Thank you so much, sir. It was an amazing session. So I have 2 points to ask the panel. So the problem with the data is that the data is in different silos present in different points. Like if we have a program for mother and child healthcare, so the data is in different silos. If we have Ayushman Bharat going, it is in different silos. They don't talk to each other, or they are not interconnected on a single portal. How do we solve this problem first? And the second point is, everyone talks about keeping an expert in loop for building those systems and things. How do we tackle to that challenge, sir? If we have any thoughts on it. Thank you.
The problem can't be solved. And it's very simple. You can only see, it's nobody wakes up in the morning and says, you know what, I'm going to aggregate this data with this data, right? So the question is, why should the databases get aggregated? So let me finish the thought process, right? So it will only get solved if there is a problem that gets defined at a higher level, and there is a person or a team in charge of that problem. And to solve that higher level problem, there is a need to integrate these two databases. And then somebody becomes accountable, responsible, you create a budget, and then perhaps the data will get integrated. Perhaps, okay? But until you don't do that, there is no way it's going to happen. Why should it happen?
So for having a unified digital ecosystem, how then we...
I think the larger point is there has to be a bigger problem you're trying to solve, with people given responsibility for solving it. Only then will it happen. Until then we'll keep talking about it, that it must be done, but nobody will do it.
Yeah, this is for Dr. Muna. You mentioned about doctor coming in the morning, they are fresh, and then by the end of the day it comes to the residents. That reminds me of the hungry judge effect, where it was, So my point is, when you start collecting such data sets and they make models out of it, I'm sure I come from a machine learning community and we always look for the bad data, bad output scenario. What they found was the judge just before the lunch break and just after the lunch break. The decisions were bail were not given before lunch. After lunch, bail were just given. So there's a disproportion, and they made a model out of it, Compass, and which was discontinued various states in United States. Now, what do you do with such scenarios where you make such systems for health people start using these models, and then they have these very, very adverse effects in the field.
And I want to touch on intermittent fasting also while you're at it.
I'm not sure if you have been following the US models, like the decisions where earlier the residents used to do those 72 hours duty. So I think that's why you have to have those data, because it is actually impacting the health outcomes. It can be internal, it doesn't need to be public, but for the internal quality control, we always say that unless until you have that outcomes data, you cannot make those changes. We have seen it, but we have nothing to document it. But when people started document it, that's when people actually started looking at the health of the residents. You cannot make logical decisions if you have not slept for 72 hours. So that is where we are coming. Of course, the judge thing is there, but here you are dealing with the human life. So it is important that you have that data, but it has to be for the internal quality checks. So that's there.
There are two different clocks giving two different signals, and one has beeped, so we'll go with that. But what I can tell you is that the panelists were probably supposed to be with you for about 10 minutes longer, which gives those of you who want to maybe walk up and ask something or have a chat more opportunity to do so that you may not want to ask publicly. So we will not have this beeping much more. Thank you very much to the entire panel, and absolutely lovely for your cooperation in getting this done. I think people will definitely be free for another 10 minutes because that was the scheduled time. Thank you.
Okay, ma'am. ये ऑन है बट
ठीक आ गए ठीक ठीक आता गए ठीक रुको मैं कम कर देते हाँ ठीक है चेक टेस्ट चेक हेलो टेस्ट वन चेक टेस्ट चेक हाँ ठीक चेक टेस्ट चेक हाँ
तो आदत
Hi everyone, thank you for
check
being here. We are waiting for two of our speakers and we'll be starting in a few minutes. Thank you.
Good evening, everyone. Thank you so much. I know it's been the end of a long day, and it's good to see the room all full and everyone looking forward to this discussion. I think we're closing out with a very, very important discussion today in this world where we've seen a completely change and reimagining of the global order to see how countries of the South, I don't like that phrase, but still, to see how countries of the South can work together, can collaborate, and what can they learn from each other. We have a really special moderator. She is going to liven up the session if I know her. And let me request Anshu Mohan to please start the session. Anshu, I'd like you to introduce yourself, say a little bit about yourself, and then call your panelists.
Thank you, Anjali. Thank you very much. I do have to confess she's biased. She's my friend. So, and thank you for that wonderful intro. My name is Anshu Mohan. I work as Senior Strategic Advisor at the PMNCH Secretariat, which is hosted by the World Health Organization, Geneva. My focus area is adolescent well-being and SRHR. And so this is going to be an interesting conversation because anemia is cross-cutting. It has impact across the life course, and I anticipate this is going to be a robust debate in how we're looking at solutions. And I'm with you, Anjali, when you say you don't like the word global south. Absolutely not. This is high time we start talking about, not only just talking about, but we start walking the talk on global decolonization of public health and issues that face us. So on that note, may I please call on this wonderful, wonderful and very vibrant panel that we have, and I will call on them by introducing them because we are a little short on time. So may I please invite Ms. Gertrude Kara to please take her seat. And as I call upon you, I'll say a few words about introducing you. Gertrude is a leading voice in nutrition policy. She is the Nutrition Policy Advisor at the African Union Commission. She spearheads development and implementation of the regional framework at the African Union to address malnutrition and anemia through multi-sectoral and collaborative processes. That's a very big mandate. You must get some signposts from Gertrude. Gertrude, you're very welcome to this panel. Big round of applause for Gertrude, please. Thank you. Akhil Paliat. Thank you, Akhil. Akhil is the Chief of Staff and Director of Strategic Initiative and Partnership at the SIF. Akhil leverages his extensive experience in strategy and partnerships to drive impactful initiative in child health and development. Akhil is also AKA Moneybags, so all of you who have proposals in your back pocket, I have his number, I'll take 10% in commission. Monica, Dr. Monica Kocher, Advisor, Health Dakshin, Global South Center of Excellence. Monica, are you in the room? Oh, she's coming. Dr. Vani Sethi, Regional Nutrition Specialist, UNICEF Rosa. She's online. Is she with us? Okay. Hi, Vani. You ditched us this time. Next time, no go. You have to be there in person.
Hi, Anshu and everybody. Very happy to be here on time.
Thank you. Then last but not the least, I have an old friend and collaborator, Dr. Somesh Kumar, Jupaigo, Global Director and Lead for Asia, Middle East and North Africa Hub. With over 20 years of experience, Dr. Kumar has contributed extensively to maternal, newborn and child health program and has played a pivotal role in designing and implementing transformative health programs across Asia and Africa. So with that, we have a panel complete. We are still waiting for Monica to come, but we can start. So without much ado, I'm going to hand over to a keynote speaker, Gertrude. I would request the room to be a little... Oh, Monica is here. Monica, 10 points less for being late. Did you? No, just kidding, just kidding. It's the end of the day. We need to energize the room a little bit. So putting specialists on spot. Dr. Monica Kocher, 10 minutes late into the session, is a public health expert with a focus on system strengthening. Monica works with Dakshin Global South Center of Excellence to support scalable, please note scalable, lots of learnings from Monica, and context-specific health innovation across the Global South. So that's our wonderful, wonderful panel complete. Gertrude, may I please call upon you to set the context and give us the keynote. Big hand for Gertrude, please, everyone. Loud one. Over to you, Gertrude.
Thank you, Anju. Good evening, everyone. It is my honor today to welcome you to this important session discussing an important issue related to maternal anemia. And I'm also acknowledging the support provided by global health strategies to bring me all the way from Africa to come to this important session. Maternal anemia should be taken as a matter of urgency because it affects 37% of women globally, and more especially in low and middle income countries, particularly Asia and Africa. And it affects maternal and child health. It also affects the workforce productivity. It also affects economic status of families as well as health sectors. In addition, the ripple effect of anemia affects education. It also affects economic development. So this should be taken as a multi-sectoral issue. It's not only a health sector issue, but it has to be addressed in a multi-sectoral manner. Why are we discussing anemia today? It's because it is a problem, but we are not only going to discuss a problem. I think it's high time we look at solutions. So today's session, it's more about looking at solutions to address maternal anemia. If you may know, although she said we should not call it Global South, currently we're still calling it Global South, that is Asia, South America, Africa, has been implementing different innovations. So from food fortification, community-led antenatal care, and also targeted social protection, and intravenous iron therapy, which is mostly being implemented here in India. So all these models, effective solutions, which we can share across the Global South, and also they give us scientific evidence and also programmatic related strategies for us to address maternal anemia. For a long time, the Global South has been a recipient of solutions. So I think it's high time that we take action and be innovative. For example, in Bangladesh, we have an example of digital health strategies which are addressing maternal anemia. In India, I already highlighted that we have rural intravenous iron treatment, which is addressing maternal anemia. And in West Africa, we have food fortification as one of the strategies to address anemia. And in all this, we need partnerships. So you can see we have CIF here. We also have partnerships for maternal and newborn children, which has been very instrumental in working in India and making sure that India is on the global map to share its experiences in addressing anemia. So as a call of action, I urge every one of you to treat maternal anemia with agency. Our chance is to bring together all political leadership, all partners, community wisdom, so that we can change the lives of the affected people. That includes under 5 children, adolescent girls, and women of reproductive health. So let us use this session to at least catalyze for new ideas, stronger partnerships, and the needed commitment to address anemia. The solutions that we are seeking are not far. They are here within the Global South. Like I've already indicated about India, about Bangladesh, West Africa. So what we need is to just connect them, scale them up, and sustain them. I thank you for your attention. Looking forward to a fruitful discussion. Thank you.
I see the energy being low. Did you get tea, biscuits, ration of biscuits outside? Big one for Gertrude, guys. Thank you very much. Thank you very much. It's my turn to give you a context setting, but in interest of time, I'm not going to do any context setting. Gertrude has already done that beautifully. I'm going to draw upon some of the messages that Gertrude said to us in her talk. Solutions, innovations. I mean, that's the reason why we are here. We are looking for solutions, we are looking for scalable solutions, and it's very important to have that solutions-based approach. The global world order, as we know, it is crumbling. All the more reason for us to come together. And apart from solutions and innovations, three principles that we need to look at. We need to look at the root cause of the problem. We must not ignore girls. I heard women throughout, and so I do want to thank the organizers for bringing focus to this issue. Please don't leave the girls behind. They are the young mothers. They are the most vulnerable ones. It's very important to take them into account. So during this panel, I'm going to keep repeating that. That's my mantra. That's my buzzword. Focus on young girls. Preventative approach. Social determinants of health. Don't lose sight of that. So girls, life course. And the third one, the bread and butter, the organization that I work for, partnerships. Multi-sectoral partnerships. We need to bring that. Thank you. So we need to bring that multi-sectoral approach to make sure that all actors, all stakeholders are putting their shoulder to the wheel. Nutrition is not just the business of health. Yes, we have the iron and folic supplementation, but it's also about availability of food, the right kind of food, education, platforms like school, where you have supplements. So all that multi-sectoral approach. So the big thing here we want to talk about and to celebrate is partnerships. We've talked about Global South, we've talked about countries that need resources. But remember, adversity is the mother of inventions. But Global South may need a lot of resources, but they are also hubs of innovation. Let's not forget that. What comes out of here, the evidence that is generated in Global South is the evidence that is most relevant to us. It's time to decolonize this conversation. So with that, I'm going to turn to our moderators and give them very tough questions. Are you with me on that? Yes? Okay. So we'll first go to Gertrude. She set the scene so very, very nicely for this. And so Gertrude, the African Union launched the strategic framework for anemia prevention in Africa, aimed at halving anemia rates by 2035. So my big accountability question is, how are we doing on that? Are we anywhere close to the target? So that's one. Then a little bit about the key objectives, which I think is simple and quite straightforward. Key objectives, how are we doing on that? And what are the strategies? And Africa is so, just like India and Asia, Africa is so diverse. What are the different strategies that are contained in this framework? So over to you, Gertrude. May I request the room to be silent, please, and shut the doors? So, Gertrude, over to you for the deck.
Okay. Thank you very much. I prepared some slides because I wanted us to have a clear understanding on the strategic framework for accelerating anemia reduction in Africa. And I wanted to start by highlighting who we are. Maybe you see African Union Commission, but you don't know who and what we do. So basically, it's a collaboration of 55 member states, African member states in Africa. And we are working in Ethiopia at the headquarters, coordinating policy, advocacy, monitoring of nutrition interventions at continental level. I have put in the partners that we work with there, but I think basically that's what we are. In terms of policy context, we have an Africa regional nutrition strategy, which was developed in 2016 to 2020 to be implemented for 10 years. Every 10 years we have a strategy. And this strategy adopted the WHO World Health Assembly nutrition targets, the 6 targets, which you can see on the right side in green. And one of them was to reduce anemia by 50%, more especially among women of reproductive health. So considering that Africa has got a high burden of anemia after Asia, we decided to develop a framework to address anemia. We already have a strategy which is currently in implementation, ending this year, but we are going to extend it from 2026 to 2035. But what happened is that we were addressing anemia without any sub-strategy. So right now I'm talking of no country in Africa which is on track to achieve the 50% reduction of anemia among women of reproductive health. And also to note that it's a complex issue, context specific. We have a diverse number of countries in the region which need context-specific interventions. And also it's cross-cutting, like I already highlighted, it has to be a multi-sectoral approach. So we developed a strategic framework. The goal of the framework is just to provide strategic evidence-based implementation actions. So we know countries already have their own strategies in place. So what we are asking our member states is to just implement, to develop an implementation plan on how they should address anemia. And with that plan, they should come along with the monitoring and evaluation tool to check progress. So you can see this is a conceptual framework that we used. On the top, we are contributing to Agenda 2063 of the African Union Commission. And then the Africa Regional Nutrition Strategy, which we are going to develop now, is to achieve 50% reduction of anemia in adolescent girls, women of reproductive age 15 to 49. We highlighted adolescent girls because there is a missed opportunity. Adolescence starts at 10 years, and we only tackle from 15 years. So we are saying let's start from 10 years. Other girls reach puberty earlier than others. So we are addressing adolescents. And we have 4 outcomes, and we have 5 action areas which we are encouraging member states to adopt. It's not that we are forcing the member states to adopt each and every action area, because it is context specific. So in action area 1, what we are requesting our member states is to analyze data on the causes and risk factors of anemia at country level. We did a landscape analysis for the whole continent, and they know the statistics, but if they may wish, they can conduct an in-depth landscape analysis within the country. So that's the action that we expect them to do for action area 1. For action area 2, we want them to prioritize key preventive and therapeutic interventions. So this is following the 4 direct causes of anemia. Cause number 1 is micronutrients status. Cause number 2 is infection and inflammation. Cause number 3 is gynecological and obstetric conditions. And the last one is genetic blood disorders. So we've put different type of strategies to address each and every cause. So just for example, for us to improve micronutrient status, we are saying, let's promote diet diversity. We do food fortification, the supplementation that we are implementing. I heard this morning in India, they are giving adolescent girls food supplementation and fortification and all those. For preventing infections and inflammation, it's more about malaria. We know malaria causes a lot of anemia cases, more especially in under 5 children. So if we treat malaria properly, it means we will reduce anemia. The same with schistosoma, hookworm, all those diseases, they affect red blood cells, HIV, tuberculosis, all those diseases. If we treat them well, it means we are also going to reduce anemia among the global population. In terms of gynecological and obstetric conditions, we are promoting family planning, modern contraception to prevent frequent pregnancies, and also promoting proper management of postpartum hemorrhage during delivery. Uterine fibroids is more common in women. And lastly, we are talking about sickle cell anemia. Currently, we have cases of sickle cell anemia, but because we are not monitoring, we don't know what is happening. But we have a high prevalence in Africa. Action number 3, what we are saying is it has to be a multi-sectoral approach. It has to be integrated in different forums. For example, you can integrate it in schools, you can integrate it in agriculture, you can integrate it in social protection programs. So all those forums can be used to identify anemia as well as treat anemia. We also have like a community health care program whereby we are promoting community health care workers to also address essential nutrition issues. Action area number 4 is basically strengthening governance, leadership, partnerships, communication, and coordination at all levels. So I've just highlighted the actions that will have to be done at different levels, but I can just give an example of accountability mechanism. At continental level, we have a Continental Nutrition Accountability Scorecard, which helps to monitor progress in implementation of the World Health Assembly targets. So, but there's advocacy, all those factors under action area 4, which member states have to address. Lastly, we have action area 5, which is to improve evidence-based knowledge generation and dissemination. What we are saying is they can conduct a landscape analysis, but still data availability in Africa, and I guess also even in Asia, we've heard in several sessions this morning that data may be available, but maybe comparability at the regional level is a challenge. The demographic health survey, they did it long time back, and when you compare with other countries, it means other countries are behind because we don't have available data. So here we are promoting research. Research institutions can help countries to conduct context-specific research on anemia. At continental level, what we are trying to do is to establish Africa-wide community of practice. We have high-burden anemia countries. We want to bring them together so that we can share strategies and map the way forward. And also, we are trying to get funding for implementation of comprehensive studies to have real-time data available on anemia. In terms of accountability, I already indicated that we have a continental accountability scorecard. I've put here, when you get it, you can see the link. But what we are trying to do is to assess nutrition at different levels. We have nutrition indicators, direct, socio-economic impact, we have governance and policy indicators, nutrition financing, service coverage, and other health services, including WASH. So if you can go on that link, you can see. What we do is to encourage member states to go on the link and they check how they are progressing. That will help them develop appropriate strategies for their context-specific programs. Now coming to the role of South-to-South collaboration in facilitating knowledge sharing, I indicated already that the Global South comprises of Asia, Africa, and South America. Here I'm just giving one example of an innovative solution. At continental level, we have African Union Nutrition Champion, who is the head of state of the Lesotho government. We've been using him since 2014, extending his term of contract. What happens is that he helps to garner political commitment from fellow heads of state. So we have him as well as African Leaders for Nutrition who are supporting in advocating for finances in Africa. This is just one of the examples. There are other examples which can be shared. We talked about India implementing intravenous iron. In Africa, we only have one country, which is piloting. So the lessons from India can be shared in Africa. Right now, we were talking of multiple micronutrient supplementation. In Africa, we are still at a stage of implementation research, which means scaling up these programs is even a challenge because countries don't have a policy in place. So these can be issues which we can bring together different continents to share. We also planning webinars to launch the framework as well as address issues of anemia. I think through those webinars we can also link up with colleagues in Asia to be part of that forum. And lastly, we have the cost of food and nutrition in Africa methodology. We have developed a methodology which will assess the cost of anemia, iron deficiency anemia in children, and the implications that it has on adulthood. So we are assessing the impact on the gross development product. So that methodology can also be used in Asia to do the same. So these are the issues that we can promote through South collaboration. Thank you very much for listening. Dania Vadi.
Thank you very much, Gertrude, and Dhanyavad back to you as well. So I'm going to need your help, Shuchi. We're going to time keep 5 minutes per response, and then because we do want some time with the audience for an interaction. So I want to turn to Monica. Monica, with your experience in research, and I'm making a reference to the presentation Gertrude made about the work that they're doing across the continent and looking for solutions, scalability, but evidence-based research. So Monica, in your role at the Dakshin, in your extensive experience in healthcare delivery, what are the primary challenges in implementing evidence-based maternal anemia programs within public health systems? And how can they be effectively addressed through South-South collaboration? Now, disclaimer, this is the question that have come from the organizers. I'm going to throw in a spanner in the works and ask you to focus very much on young girls as well. What is it that organizations like yours can focus on vulnerable, marginalized population? I feel at this point in time, women writ large are vulnerable, but let's focus on the ones that don't have voice. Over to you, Monica. And 5 minutes, guys. We will tax her. 10 more points down. Over to you, Monica.
Thank you for this important question. So I will go
That's partnership, guys.
That is how we are going to collaborate.
Absolutely.
So, first of all, let me answer the first part of your question. What are the challenges? Challenges of implementing evidence-based maternal anemia programs within public health systems. Now, before even I answer this question, we need to understand that anemia is not a medical issue. It's not just a medical issue. It is dependent on whole lot of determinants, the social determinants, the medical determinants, and several other determinants. And the issue with our system of working is that we all are working in silos. Health determinants are being taken care of by Ministry of Health. The agriculture, which will give a bigger food basket, will be taken care by the Agricultural Ministry. The Women and Child Health is being taken care by the other ministry. And that is how, we all are working in silos with the same, and we all want the same end result. And that is what we are lacking. We are lacking in collaboration, the interdepartmental, the intergovernmental collaborations. That is where we are lacking in the first place. And then secondly, most of our activities, the awareness programs about anything, are a top-down approach. The community is not being involved. We actually do not know what is the community demanding. What is the reason of anemia out there? So that is one issue, that is one gap where we really need to work on. And then, do we have, once the implementation is happening, do we have enough monitoring and evaluation frameworks in place? The implementation has happened, but is the implementation research being happening? We start lacking on those points eventually. The course correction, will it happen? And that is where we lack. So these are the three challenges where we really need to work on. And how South-South collaboration is going to be useful? So I happen to work in an organization which is working very closely with Ministry of External Affairs. And what is my work? I'm a health advisor there, and my work is to take all the good practices from India to the global South countries, to tell them what exactly are we good at, and in turn learn from them, bring a couple of good practices from the other nations to India to work, to better, to improve our systems. That is what we work on. Let us not reinvent the wheel. Let us not reinvent the wheel. Everybody is working in their own areas. Let us not reinvent the whole process. We can bring in these learnings, bring in the good practices from other countries, and start working on that. That is how South-South collaboration will go forward. And this is a high time we start speaking about global South-South collaboration. With the changing scenarios, it has become highly important that South-South collaboration becomes ever so important now. Instead of we being receivers of anything, of knowledge, funding, it's time that we start working ourselves. The data, the research works, the articles, the scientific articles, the scientific journals, where are they coming from? Probably everything from the global north. And we are trying to emulate the similar data, the similar innovations in our country, which is absolutely has a different, am I over time? Okay. So the last line is, it's really time to work on everything which showcases global South, and we come out of the hegemonies of global North. That is very important.
Thanks very much, Monica. It is indeed time. That was pun intended. But but I am going to come back to you and hold you accountable to my question on what is it that we are doing for adolescent girls. So, but hold our horses. I'm now going to turn. I mean, you spoke about what we are doing for Global South collaboration. From AU, we moved towards Global South collaboration. Then I want to move a little bit towards hand-on, closer to implementation, turning to my good old friend Somesh. So, who's Global Director and Lead for Asia, Middle East, and North Africa. That's a very large remit, very diverse context. Huh? Somesh, are you ready for the googly? So, what practical system-level strategies do you see critical for overcoming these challenges? Some outlined by Gertrude, some outlined by Monica. So, do you have solutions in there? So, and what kind of solutions? And again, I would encourage us to encourage Somesh, join my voice, people are not listening, to focus on adolescent girls, the most vulnerable population, because that's where the need is the most. Over to you, Somesh.
Thank you, Anshu. So, we got to see, the multitude of dimensions that anemia entails, as if we have to solve the problem or address the problem definitively and holistically. So, I'll share some of the learnings that we have had and across continents, from India to Ethiopia and a lot of countries in between, especially for anemia. So one of the things that I've learned is the detection of anemia is still a huge problem. We don't know the magnitude, and we don't know it early enough. So decentralizing care, decentralizing antenatal care, as well as, even as Anshu is nudging us to think about the girls and adolescents, decentralizing testing of anemia to where the girls access care or where they access institutions like in schools. It's very important. So, and decentralization is a huge ask, as it's a strategy more. So, what do you do tactically? So, point of care technologies which are as much as possible grounded in countries, because of supply chain issues. You can bring technologies from elsewhere, but if they're not grounded in countries, it's always going to hit some kind of a supply chain issue. So as much as possible, have point of care technologies and easy to use solutions that you can equip your frontline last mile healthcare workers, even community health workers in most settings. That goes a long way. And in schools, your teachers, or your other teacher aides, and so that the solutions have to be really point of care, really easy to use, and this is all coming from practical experience, and as much as possible from the regional or a country context developed there. Second is deployment of human-centered design. You know, these bringing any new solution, you have to take care of the perspective or the perceptions of the user and the receiver of care. So whether it's women, whether it's girls, Anshu, as well as the providers who will use them. And we sit and deploy or design solutions from our vantage points, but if unless each persona is different, the way a girl will access care, a 15-year-old will access care, and when a girl or a woman of 21-year-old unmarried versus a married will access care, they are very different. So you have to really be sensitive to their needs. So bringing of human-centered design to designing products as well as deployment is another very important. Third, the entire introduction of a new technology, a new innovation which will be required in anemia, whether it's an IV iron, any other parenteral iron, or any other product, will need to be having a multi-sectoral approach. So starting with a professional association or a public sector to first educate them about the availability of these new innovations and technologies, get them included in the national guidelines or normative guidance as much as possible, the training pathways, including them into the drug pathway, essential drug lists or desired drug lists, and then having that, investing in that local manufacturing capability or distribution capabilities. These sound very unsexy, but for all of these newer solutions, unless you invest in these last mile capacity, whether it's a provider capacity, whether it's manufacturing capacity, whether it's distribution capacity, you can have the best products, but they don't go the last mile. So as much as possible, thinking holistically, multidimensionally, and bringing everybody together in different path of the rollout is going to be very key if you have to solve this holistically and definitively.
Detection, decentralization, point of care, and one lovely thing, human-centered design. I mean, I was a big fan of patient-centered care, but now, are we good? Closer, okay. I'm going to give the mics a big hug. So detection, decentralization, point of care, and human-centered design. That is fantastic. Now, I go on to Vani, who's been very patiently waiting online for us. So Vani, how is it, and given your work in UNICEF, and how is it that community-based platforms such as Frontline Health Workers, Women's Collective, or adolescent groups, hurrah for adolescents, yeah, I see it, adolescents groups be better leveraged to increase awareness, uptake and adherence to anemia prevention interventions? Over to you, Vani. Can we
Hi,
see
good evening, everyone. Am I audible, visible both?
Yes, please go ahead.
All right, so I have 5 minutes and let me put the stopwatch. Okay. I think, let me go back to not only putting the word leverage, because when you use the word leverage, it's actually using people. And that's actually against the people-centric approach. You engage people, and where systems stop, people come forward. Why do we need to do that in areas that we work? So at the regional office, I'm working and supporting adolescent girls and women's programs across the 8 countries of the South region. And before this, my role in India was on focusing on girls and women's nutrition before, during, and after pregnancy. Both my role in India and in the regional office, working on community-based platforms, working with women's collectives, community collectives has remained central. And why? All forms of anemia today remain a pernicious problem. It's not only, some people look at it as medicalize the issue, some feminize the issue, but no one humanizes the issue. Look at Afghanistan, where girls are not able to come out of their homes. There we needed doorstep delivery of the rich services, because girls are not allowed to come out of the homes. Where women's groups are sitting on safe spaces for helping each other, mourning, there we started layering nutrition programs. In social protection programs, where people were only giving cash in Pakistan when floods happened, their layering of food and cash programs were started, where women's groups and communities themselves came forward to support. In tribal areas where I started working 15 years ago when I was in India and trying to find out solutions to reach out to women in the most difficult areas, take-home ration was being thrown away, but women come together to eat food, and their girls used to tag along with them. And the take-home ration was converted into a hot-cooked meal, and during some of those days, health services were also provided, and a third IFA was provided. What did we learn? Bundling services help. They're busy people, they're working on very meager means, their time is as precious as all of us, and they need care on a fixed day, fixed time, and fixed strategy. At the same time, I had realized that in the most poorest communities, oftentimes we think that we're going to give education, we are going to give services, but we don't look at social franchisee kind of models. But in Bangladesh, pharmacies, community groups, they came forward for MMS promotion and also point of sale purchase. You didn't need only services. For reaching out preconception, women churches came forward in Sri Lanka, where for marriage purpose, if you want to get married in the church, you have to do preconception counseling. And there we layered nutrition and food services. So 2-3 things which I learned in this process was that you need to bundle, you need to work with network of networks, and you need to think of the white and the grey areas where there's no service. Women are in conflict, they are in climate crisis, and they are marginalized. And the framework that was just shown on the first slide, that is the comprehensive framework for anemia reduction. Did any of you see the word caste, class, equity? How do these frameworks really change for the poor? The word maternal itself commodifies women for her reproductive rights. Is it time that we think of women's rights as an issue and women's services as a life force? And all these examples taught me look beyond frameworks, ask 3 questions. Who is left out? Where do they live? Why is their situation not changed? And what are the 3 things that can be done? If you can't do it, bring people together to do it and let them lead the process. And believe me, friends, we are seeing this in Afghanistan, in Pakistan, in the tribal areas of India, in Sri Lanka. Even after floods, people have come forward. After the
Thank you, Vani. Thank you, Vani.
Right? So
Absolutely.
I'll stop here,
Yeah.
but now what my closing remark would be again, just humanize it. Don't medicalize it and don't over-feminize it.
Absolutely, and that rallying cry, about reducing women to a commodity. So thank you very much for that. A couple of things that I picked up in what you said. When systems stop, people step forward, and that has been so true. Where resources have been less and where people have stepped forward. Another thing that I picked up from that very, very fantastic intervention from Vani, bundling services, layering things. But that is not just the message that we are giving out. We as the development community, including UN partners, need to start thinking about joint-up planning, right? And who can drive this agenda? It's the donors. So without much ado, I'm turning to Akhil here, and to bring in the accountability element that we started this conversation on when Gertrude talked about accountability and what is it that we can do to hold nation, countries, stakeholders, ourselves accountable, the 360-degree circle of accountability. So very specific one, Akhil. Digital tools and digital tracking tools, community outreach models, or how they can be adapted and scaled across diverse geographies in global south, but also giving it an accountability spin. Over to you, Akhil.
Thank you. So I'm going to be quick, partly because I want to hear more of the panel with my own voice, but mostly because I'm terrified of that buzzing sound at the end. And if we scale any innovation, I think that's the one we scale to other development
I'm with
conferences.
you on that.
So, I mean, I'm not an anemia expert, as you'll soon find out from what I'm going to say. But as a global foundation who is working in the so-called global South areas in Latin America, Asia, and Africa, we do spend a lot of time thinking about scaling across these geographies, right? And India is one of the reasons India is a really important geography for us is the innovation potential. Both to absorb innovation, but also to sort of scale innovation outside. But the honest truth is, it's like really bloody hard, right? And even internally, within an organization, within states in India, it's super, super hard. And it can be deeply frustrating as development practitioners when you know something is working, and why isn't it more accessible, more available across the world. And we've been thinking about this, and there used to be Anil Swarup, who used to be the ex-education secretary in India and the ex-coal secretary, used to say, for any sort of policy to be feasible and scale within a system, there's a few minimum things that he used to look for, right? So he used to say, I think it should be administratively doable, politically acceptable, financially viable, socially desirable. He recently said he added environmentally sustainable and culturally relatable. That's a lot of bubbles, right? And if you think about translating innovations, whether it's digital tools or all the things you spoke about, Anshu, because contexts are so different, it does take a lot of work to take something and scale it in different contexts, and that requires dedicated resources. It takes dedicated bandwidth, which is why all of the organizations that are on the panel are super accountable. And unfortunately, we are in a resource, constrained environment, but bandwidth and resources, we're always in a resource constrained environment, especially in 2025, when it seems that we don't have resources to even do what we were doing before, right? So that's the sort of challenge in which we think about scaling innovation. And in terms of, I think, accountability, it's quite easy to slash this in conversations around restructuring, reprioritization, but actually it's the most important thing we could potentially do, because it's very clear that there is no funding to do the things that we were doing before, right? So we are going to have to look internally to find what are the lower cost methods, what are the way to do things that we were not doing before. And I'm not going to answer your accountability question because I don't have a good one, and the buzzers at the back of my mind, but that's something that we're thinking about all the time.
Chicken, Akhil, chicken. Okay, but no, noted. No, you did. He did. To be fair, he did bring in some really good points. Yeah. You talked about systems. Akhil talked about systems. So I'm going to turn back and try and make your life a little more harder. So you have 3 minutes now because we do want some audience interaction. We have such wealth of knowledge in the room, and we can't let go of them without taxing them and also taxing you. They'll ask you questions, and you in turn can ask. And I have to be kind to all of you as well. So Monica, over to you. Given your background in health systems, and I can introduce systems, how can countries like ours in the region, I'm trying to shift away from the global south, how can countries strengthen the health infrastructure to better support the prevention and management of anemia? I'm also ditching maternal here in light of what Vani said and in light of my own rant that we need to focus on girls as well. So how is it that we can do it, but using some of the verbs that Akhil used: sustainable, country, culture, context, friendly. Over to you. 3 minutes, guys. Monica, you're on the clock.
So, anemia needs a multi-sectoral approach. I've lost one more minute. So, if I talk about anemia in specific, anemia needs a multi-sectoral approach. And if we are talking about health of the girls have to be empowered with knowledge. And that would bring the education system in place. If we are really talking about sustainability, we are talking long term. And if we are talking long term, it has to be ingrained in the minds. And as we already know, behavioral changes, they come slow. And if we really want to work on this, it has to be ingrained at the first day when the girl starts understanding her body. So she needs to understand what is spacing, what is birth spacing, when is she ready for a marriage, when would she get pregnant. Not even the girls, but also the boys. That has to be ingrained in our education system so that the people start understanding what health exactly is. And that is how we can take it forward. And this education has to be very culturally sensitive. We cannot... I have been working in Haryana for quite some time, and the word sex cannot be spoken in open. So, it has to be the education we start giving to our young minds has to be, as you said, culturally very sensitive. If it has to be sustainable, it has to come from day one. And that is how we are going to go in the long term. It will definitely going to take some time, but yes, we are on our ways. Yeah, thanks.
Thank you very much. And you did fantastically well on time, sir. So excellent there. I'm going to go back to Vani because we are talking about infrastructure. And so, Vani, the next one that we're throwing out to you is, how has your organization, now, out of all the UN agencies, UNICEF is one that has boots on the ground. You do a lot of implementation work. So how has UNICEF prioritized strengthening primary healthcare systems, particularly in underserved community? We go back to the most vulnerable communities. And how can peer-to-peer learning in a global south context be used to enhance country capacities in addressing anemia in women, particularly in high-need areas? It will be nice for us to hear of a concrete example, and I give you a challenge. 3 minutes, over to you.
Okay, let's put it in this way that I guess working on the multi-systems approach, adapting the health systems, building blocks model to nutrition systems remains central piece of our work. And we do that working with the government, working with regional bodies like SARC. But one of the most important functions that we have started working is leveraging the capacity of academic institutions and research institutions within the region, tying them up to each other to learning from each other. In this context, I'm going to give you 3 or 4 successful examples where I have had the good fortune of working with. It's also where India actually came forward to support other countries in accelerating plans for reducing anemia in girls and women. The first thing which has ever happened in the government of Bhutan is to set up a center of excellence on anemia in the medical college. There's one big medical college in Bhutan, and to date, there was no center of excellence, no National Institute of Nutrition in Bhutan. But what happened? National Center of Excellence, which was established in All India Institute of Medical Sciences under the Indo-Bhutan Treaty, they helped them set up their center of excellence. Today, Bhutan has a center of excellence, and last week I was in Bhutan training them on implementation science research on compliance of anemia in the far east areas. And again, AIMS helps them with their research frameworks. So that was how India for the World strategy they are supporting. But it's not only South-South collaboration, it's also bringing Global North colleagues as allies in the process, and as part of their proposals, putting line items that you have to work with local institutions. So what we've done is that we have a coalition of a preconception nutrition and anemia collective that is made in South Asia. We invite all colleagues to be, whoever is interested in working with local academic and research institutions, to be part of it. And together what we are doing is having harmonized frameworks, guidelines, capacity building programs to support each other. The third example is legal networks. A lot of us feel that legal networks, we go to them when the problem arises. What do they have to do with nutrition or even health? But we can help a lot looking at the legal issues with regarding food environments, maternity rights and others. And today we have a legal network that is also looking at how can we help implement policies in that direction. So we are helping make network of networks, different people coming together, and one institution as an anchor. Different countries work in different ways. One is just helping each other exchange knowledge, but the second is writing a multi-country proposal together and pitching for grants together. And now these research institutions and academic institutions started pitching for grants together. Finally and lastly, how we are also helping in building institutional capacity and systems on ground is bringing the global North, Indian and South Asian diaspora who we've connected with on innovation challenges, mentorship programs, internship programs with these local universities as docs and postdocs. So we're trying to build a critical mass within South Asia that works for South Asia and supports each other, not only in learning or India for the world or the world for India, but writing grant proposals ourselves. Because oftentimes we don't do that. Grants are written somewhere else and they're implemented here, but how we can do it ourselves. And finally and lastly, also working with academia wherever they are on unified frameworks to bring the best possible evidence together.
Thank you, Vani.
So I think these are some of examples. We've published some work together, which is just released today, on how academia around the world and in South Asia have come together. I encourage everyone to read that, and I'll also put it in the chat box.
Excellent, and thank you for sharing the resources. Some of the points that Vani highlighted, allyship, building, trust-building exercise, also learning from each other, knowing that these are scalable in different contexts and circumstances. From Southeast Asia, I do want to move to Africa, so Gertrude, over to you. I wanted to give you a bit of a break because you had 2 big questions. Circling back to you, given the amount of commitment we have from the African Union for eradication of malnutrition, how can partnerships between African nations and other global South countries enhance the implementation of multi-sectoral nutritional strategies? And I think it'll be good for us to understand that, these strategies just not remain strategies, but what is the mechanism for implementation? And I again bring the dirty word of accountability in it. So over to you.
Okay, coming back to multi-sectoral nutrition strategies, at continental level we are developing a multi-sector nutrition policy framework because we noted that most countries have like a strategic plan on multi-sectoral nutrition, but the interventions are not forthcoming. Most of the issues are implemented by the health sector, it's easy to cost nutrition-specific interventions from the health sector, but when you go to nutrition-sensitive interventions like agriculture, education, it's difficult to cost. And even looking at the impact, for example, we had consultations in the regions to assess what are the evidence-based impact interventions in education sector. The people brought in the issue of school feeding. But when you look at school feeding, is it addressing nutrition or it's addressing education outcomes? So those are the issues that we have to share at Global South level to see how best we can integrate all these interventions in different sectors. And also, we are developing a funding target for nutrition because, for example, in health, in Africa, we have 15% of the budget to go to health, 20% of the budget to go to education, $3 per child to social protection. But we don't have anything on nutrition. So what we are trying to do is to look at how much from each sector can go to nutrition and then bring up a composite indicator for member states to be able to allocate resources. For a long time, we've been advocating domestic resource allocation. You can see the issue that has come up now. As much as we want to accelerate reduction of anemia, now the US has, pulled out in funding, and most countries are already suffering. So maybe it's high time the Global South starts looking at domestic resource allocation and how best we can scale up the innovations. For example, we talked about iron, intravenous iron in India. How big is a program? Probably it's just a pilot program. How can we scale it? We don't have resources to scale it. So probably domestic resource mobilization should be one of the areas that we can share. Thank you.
Thank you, Gertrude, and also for making a specific reference to the elephant in the room, the US pullout. We've been skirting around the issue and saying resource crunch, resource constraint, but yeah, that's a big one, and that is a cause of people dying. And loss of all the gains that we've made. I mean, the situation gets more and more complex. I'm going to now turn to Somesh. We talked about partnerships and AU, a big intergovernmental partnership, but we want to bring in other stakeholders because even though we acknowledge governments are the sole not the sole, the largest service providers, there are other actors. So what do multi-sectoral coalitions, what is it that organizations like yours can do to support robust coalition building? So everyone has a role to play so that you have everyone doing something. Over to you, Somesh.
Thank you, Anshu. So I think the multi-domain partnership everybody has talked about because it's a multi-sectoral effort that's needed. I'll talk about like what are the big categories of partners in any domain, whether it's health, agriculture, nutrition, that we have to look at when we are thinking about these coalitions. Obviously, public sector brings the scale and for the impact. So absolutely, that's the anchor, the cornerstone of it. But I think we'll need a lot of innovation, leapfrog innovations, and that's where the private sector comes in, especially now in our emerging economies, our countries where we work in. There's a vibrant innovation ecosystem brewing. You have great startups coming with really cool point of care, for example, hemoglobinometers and whatnot. So I think harnessing that enterprise, local innovation ecosystem, bringing together in a platform, that's where we come together and getting these innovators the access to public sector and access to resources, finances, etc. Through institutionalized mechanisms is where we come in, through creation of platforms, incubation or accelerator platforms. Then you need financing, right? So you need financing. So how And we talked about the resource constraint environment, and this is where what I think to think about as multi-stack funding. You know, you have different stacks of funding that you need to access, the public sector, but also development finance, like development banks coming in, and you need to partner with them to around the global, around the national or national goals, essentially in this case. Then you will have a lot of venture capitalists or even social investors who want to invest in these innovations, who want to solve social problems. So bringing them in through these innovation platforms or accelerator platforms, essentially talking about different sources of funding to solve one large set, one set of partners, and finally bringing the civil societies, because you know there's nothing about solving problems of women and girls without partnering with voices who represent them. So you know, bringing different kinds of partners across shared values, shared objectives. They will bring different competencies. They will have different sizes and capacity, but giving them equal respect. You know, those are the learnings that we can bring in as partners to create such platforms.
Thank you very much. Thanks, Somesh. Now, you introduced many complex financing terms, so it's but natural that I go to Akhil. So you talked about stacked financing, and I could think of pancakes, but that's not to be taken lightly. Yeah? That's where our money is. So stacked financing, I want to introduce a few more terms. Long-term, sustainable financing, but also domestic. Resource mobilization. So organizations like yours, a private fund, what is it that you can do to ensure that you are using the resources available to you for catalytic domestic resource mobilization, also to long-term, thinking long-term, there has to be an end goal. How do we become self-sufficient? So over to you, Akhil.
Yeah, it's an important question because we're in a world now where we're spending more on debt than development. And therefore all of the sources of financing that Dr. Somesh spoke about is super important. The other one to add to that is I mean there is a lot of also sort of south development, right, for I mean or aid from developing countries in some sense. It's it's not an insignificant amount in some sense. I think our realization is that accessing it is difficult, partly because none of these financing is part of the regular development conversations that we work with. And so a lot of our focus is as a philanthropy that can provide sort of infrastructure, long-term risk capital. Specifically for scaling South-South collaboration, a lot of our focus has been on creating platforms or the scaffolding that allows all of this to come together, right? So the global, so I'll give you an example of how this comes together. So I think last year we partnered with the WHO to fund the GIDH, right? The Global Initiative for Digital Health. And the idea was very simple, right? So there's about $55 billion that are spent on digital health every year, probably a lot lower now with the US pullout, but still we haven't really seen the returns of that kind of spending, right? Most digital health initiatives remain subscale, and there's lots of issues that all of you know better than me. But what GIDH does is sort of it maps needs to existing technologies, but then helps countries develop funding plans and then matches them to funders, right? And this is not as easy as the theory of change slide that GIDH has. It takes about a year and a half to do this, right? To go to a country or a community, think about what is the digital health need, build a digital health roadmap, figure out what's the appropriate technology, find a funding plan, connect them to funders, make all of this happen. And it's probably going to get more difficult now that we have to access unorthodox, let's say, sources of funding because the more traditional ones are drying out. But that's the role that we would like to do more of, like setting up these kinds of platforms that not only curate innovations, because I feel like we have enough platforms that are curating innovations, but are actually sort of funding the nuts and bolts of this matchmaking and making it happen.
Thank you very much. I think there are important points and tips, and the more we are tuned into this conversation around financing and sustained financing and how do we leverage that, the more secure we are going to be going forward in this conversation. So that was for the tough questions. Then I have one last bit left, which is a rapid fire round of questions for our esteemed panelists. Just one question. You have 90 seconds to answer it. The buzzer has been kind, but that's because you have been good. So, but before I go to a panelist, I would encourage each one of you to take your cell phones, pen, paper. If you're old-fashioned like me, get your questions ready. You have 10 minutes to grill them and vice versa. So, ready, panelists? So over to you. Your big question, and I will start with, in the order that I'm saying, Monica, Somesh, Akhil, and then the last word to Gertrude. Name one transformative innovation or collaborative approach that you believe could significantly accelerate progress in combating combating anemia across South. And my apologies, Vani, you are there online. So Vani will come in after Monica. So Monica, over to you. So I once again repeat the order. Shuchi, help me please. Monica, Vani, Somesh, Akhil, and then Gertrude.
So, can you just repeat the question? I'm so sorry.
Sorry. Okay, I'm going to take one transformative or collaborative approach that you believe could significantly accelerate progress in combating women's anemia across Global South, or anemia in women.
Yeah, I think I have a ready answer to that.
Excellent. Let's go for it.
So I think IV iron should be one of the best innovations which we could bring for women and for girls, for women, especially in the second trimester of their pregnancy. I think that would be really great. The consumption of IFA tablets hasn't brought much difference to women's health and in reducing anemia. For probably this initiative has been there for some 50 odd years, and nothing like concurrent changes haven't been seen. So I think it's about time that innovation happen in that sector as well.
Excellent. Thank you for calling a spade a spade. IV anemia supplementation hasn't worked. So Vani, over to you.
I think simplify diagnosis and start look for ferritin diagnosis is in the field. Based on if the deficiency is an iron deficiency, give IV iron. But women suffer from multiple nutrition risks. Assess those nutrition risks and do a test, treat, and track approach till it is resolved. Over 15 years, we've developed a 5-action framework just released today. I encourage that we test it out as one collective.
Thank you. Test, track, treat, and anemia exists in multiple forms. Over to you, Somesh.
Yeah, so the most important ones have been taken, but I'll still share something that is really important, and that's both transformative and collaborative, is sharing of data. We need to know where the woman is who is anemic, and so we have lots of departments collecting different sources of data. We have education department, we have women and child development, we have health, and I'm just talking India now. And then if you go out, multitude of departments collecting data, and you have data on poverty, you have data on so many indicators. So if we really bring these data together, harness this data for targeted action, and as we move ahead using the different advanced analytics that are now available to us, I think we will be doing much better and efficient and effective this problem solving that we are collectively here to.
Thank you, Somesh. Numbers, and more numbers. Then we are moving to the numbers man, but a different kind of numbers. Over to you, Akhil.
I think it would be investment in infrastructure platforms that are focused on scaling innovation across contexts. I think if we could replicate that fund that really well and put all our efforts into it. That's what I just.
Sharp and pithy, less than 90 seconds. He's a money bag. You know his approach. Over to you, Gertrude, but take it away.
I think taking a multi-sectoral approach would be the best way to address anemia. Because if we talk only health sector strengthening, then we are leaving out issues like diet diversity, which is the key issue. The diet is what we eat is what is really, nutritious, and if we promote that good diet diversity, it means we will prevent anemia, we will not have therapeutic treatment.
Thank you. Diversity in diet and diversity in approaches. Thank you very much, Gertrude. So with that, we are at the end of our panel. A huge round of applause for our panelists, please. And thank you for putting up with my very brisk moderation, all in jest and all for a good cause. So, audience, over to you. Oh my goodness, there's an exodus. Don't go away. No, 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 the lady in red, come back. I will sing for you. So, anyways, that will scare people away. So, I'm going to pause here, and colleagues are going to help me organize questions. I see two very eager hands. I want two more. So, in order. Oh, excellent. Guys, ready? I'm going to start with the gentleman at the back. He was the eager beaver. So, over to you, please. Your name, organization, and then you.
Thank you. I'm Avinash from Japaigo. My question is to Monica ma'am. Monica ma'am, you have rightly highlighted the need of intersectoral, interdepartment coordination. And as we know, some of the best solutions to anemia come from economic empowerment and educational strengthening. So is Dakshin focusing on building accountability of nations to ensure interdepartment coordination?
Yes, Dakshin is trying its best. In fact, it is at Dakshin where all these collaborations have started happening. We are bringing all the stakeholders together at one platform, talking about things, and that is how we are planning to take it forward. This good practices, we need to take it forward to other nations as well. I'm trying to be very crisp to answer your question.
Thank you very much.
Thank you very much. The lady in front sitting here, sat in front of me, and then the gentleman on the other side of the room.
So first of all, thank you so much. This is the area of my interest, and as I am Juhi, I am working as an India Health and Climate Resilience Fellowship program with BFI, and I am working in one of the tribal district of Jharkhand, that is Khuti, and my problem context is anemia in pregnant women. I'm looking that with the SCD approach, what Somesh sir mentioned. So going on, you all have told very nicely ki early screening, detection, adolescent, this is fine. I just want to know simple thing ki let's look back just on a simple thing, IFA consumption. Okay, because this is very much scalable and easy to go through that solution for some time. So is there, we talk about IFA consumption and all, I just want to know ki despite of everything, there is no compliance, which we say 100 plus days, 180 plus days before and after, and even knowing that ki there is no consumption, compliance of IFA, follow-up is not happening. Okay, so this is a very basic, we can go to some of the rural tribal district, we can do at least little bit of 1%, 0.1%, something, it might change. So please help me with any example where any solution has been done, any step has been taken for the compliance of IFA, or which also helps in the follow-up of that. Thank you so much.
Juhi, your question was to Somesh? Okay. Yeah, excellent. Over to you, Somesh.
Yeah, so I think first, when we say word compliance, we are putting the burden on the woman. right? Compliance meaning you have to do it, right? It's there, probably she doesn't do it. So first we have to, as health system deliverers, you have to frame it differently, is my little suggestion, or request rather. You know what, I did some research on this for a workshop earlier, and there have been a few things that have worked. I think the core of this solutions finding is human-centered design. Why is the woman not taking it? And there are a multitude of reasons. I'll share some of the examples that I remember that have countries have solved. I remember Nicaragua, Nepal, some countries have attempted it and in a definitive manner. One of the reasons, one of the ways that they have solved it is, giving it in short, small numbers, like not giving 180, 100 tablets in a one go, giving it a weekly dose or 10 dose strips, and then that is how you ask them about how did you take it, and if not, you have a much more contact with the client. Then there was another one that has been tried, and is when you take a drug out of a pill box, you have a reminder that goes to it's a digital tool, that a reminder that goes off, and a virtual tool, they recognize that when a woman has not taken it for more than 3 days, and so somebody can call. So these are some of the things. It also causes iron causes some kind of bowel disturbance, so you have to take into account that and counsel it. So it's a lot of communication, scheduling, as well as some digital solutions can help. Bottom line, human-centered design, because you have to understand why the woman was not taking it, even when she knew. One final thing, also relating it to the newborn issue. If once we realized that if you tell them that this will lead to the child's problem, there's a more chance of women accepting and using it. So some of the learnings that I remember reading.
Thank you.
Absolutely. Just to add,
Please.
Just to add what Sumay said. How much time does a ANM or a ASHA or a doctor takes while they are prescribing iron to the girl, to the woman, to the pregnant lady? Hardly a few seconds. Anemia, medicine written, take it from the pharmacy. Is that what is happening? So who is going to tell them why is this tablet important? And that is where what Sumesh just said, human-centric approach. Explain them why this iron tablet is important for them, for their unborn child. Why is it important for them? And see, once they understand, once they are sure what they are going to consume and what effect that tablet is going to bring in their lives, day-to-day lives, or in the in day-to-day life of their child, so that is when compliance will start happening, and that is where we are actually lagging. They really don't know what change is going to happen after they start consuming this tablet.
Thank you very much. Okay, one more question. The gentleman in the red shirt. Oh, and the lady in red is back. Okay, and she has a question. No, she doesn't have a question. She was just being honorable. So, gentleman in white shirt, and then I will allow you one question. But you have to be quick with your question, and the panel has to be quick in your response. Over to you, please.
So, hello everyone. My name is Ashwani Dudeja from One Infinite Inc. And I make environmental products, clean energy products, in order to prevent pregnant women, to prevent premature deaths, and further climate change. My question is that I work for them in tribal areas, rural areas, for their growth and development in a positive way. But the thing is that when I see that in reports, in the documents, there a lot of positive notes are written over there, but versus in actions there's less. I'm going to say, in other words, that, sorry? Yeah. So in other words, practically actions are taken very less. And on paper, we do write, we have done this and that, and percentage, we show the graph like this. But practically where we are, every year we'll keep talking like this. So my humble request that I'm looking forward for the solution. If I can work with you guys, that will be, more helpful for the people. So practically talking. So what will be the plan of action after this conference? Plan of action, working towards action, then taking action.
You've stolen my thunder. Those were my closing remarks. So, but I am going to. I don't think that's a question in there, but
It's there, but.
I can answer that question if you allow me.
Vani? Yeah, of course. Go ahead.
Thank you so much for your question. And climate and sensitive programming is of great importance to us. 9th to 11th July, UNICEF, along with SARC and 14 organizations holding a regional conference in Colombo, including market stalls, to accelerate reduction in all forms of anemia. We've just come up with an innovation challenge. I throw this question back to you. Come join the effort. Come showcase the innovation, how you can contribute to the regional agenda for reducing all forms of anemia in girls and women, and ensure that the recommendations goes via the member states, because SARC is convening it across the region. So come join the effort, and there will be a call to action, and all organizations are there. And I'm making this open call to everyone who is.
Thank you so much for giving me the opportunity for this, and I would request humbly that if you can provide us linked way to apply and how to come, what is the process, I'll appreciate it. Thank you.
Excellent, and thank you, Vani, for that open call to action and invitation as well. The lady in black, last question, gone. Please make it very brief, and the panel, please remarks.
So we know
very
that
brief.
different partners and different ministries and different division within the same ministries have different mandate for the same cause, let's say anemia. So I just wanted to know, do we have any example already in the space of anemia, or even in the broader context of nutrition, or even the larger context of public health nutrition, where these coalition or partnerships have really worked, and maybe one achievement that has happened? Because we keep talking about collaborations, but in my past 15 years, I have a lot of failures. Examples, and I'm sure shared failures, because our mandates are different for the same cause. So any example that can be replicated, or some learnings?
That's a very loaded question, but it will take more than 90 seconds that I have. But whoever wants to attempt, please go ahead.
Okay, just to respond, one example is what is happening in some of the African countries, whereby coordination on nutrition is in a neutral ministry. For example, office of president or vice president, not in health. Because if you put it in health, it means everything will be health sector related. So everyone who is coordinating matrixectomy interventions are posted in the neutral, what should we say, ministry or infrastructure, so that they pull all other sectors to meetings, to development of strategies and the like. So that's one good example that is happening.
Thank you.
Excellent. That was very good, Gertrude. And I just want to take the moderator's privilege and also say that applies not just to nutrition, it applies to population groups as well. So that executive leadership, Rwanda has done great things, where the president monitored things directly. So it's my great pleasure to sum up, which I'm not going to attempt because there was such a huge wealth of information and knowledge in this room. But what I take away, and I hope you do too, is the sense of urgency. And it is time to act now. Beyond the conversation, that gentleman did raise that question about what happens now. It's up to all of us. 360-degree accountability. Take what we've discussed, take good example, take learnings, take failures, and make good use of them. It's up to us. I mean, why do we look at others to take action? Why is it that we can't take action? It's up to us to act for us, for the future to come. As it is, the future of this planet remains threatened. It's time to do it now, to do the right thing and to motivate others. So thank you very much. I do want to take one last moment for the audience. You guys have been fantastic. Thank you very much. And for a fantastic panel who put up with my absolute hazing. Thank you guys. Thank you very much. And have a great rest of the conference. Oh, hang on guys. Group photo, okay. There you are.
We've been awake since
Morning, and it's not ended. We have the inauguration now. You need to. Thank you very much. No.
There's no drop in space in between? No. My official one is Sarah. Okay. At Africa. Dash union. Yes. .org. .org. Yes. Thank you, madam. May I take your number also? Plus 265. Plus 265. Okay. Quad 9. 1, 2, 3, 4, 9. 1, 2, 3, 4. No. 4 nines. 9, 9, 9, 9. Yes. 1, 4, 6, 3, 8. Thank you, madam. I'll share my details. Thank you, madam. Thank you. I am Kumar. Looking after the rest of the food for the okay. So you are based there in which area? This side of the area. I used to go to Senegal and Nigeria. So there you met with the Regional Nutrition Alliance group is also there. Regional Nutrition Alliance and Fortification Alliance is also there. Okay. I remember meeting with PAC last week on a partnership. Yeah. So that's why I mean wondering if I can get your contact so that after that this conference we will get in touch with you. So I think 3 months back